I hope I am audible. Okay. So I hope now you people are reading well and making best use of the time. And today I am just wondering that what kind of excuses I will get now. What kind of excuses that we have now, that why we are not studying now. अभी तो मेरी भी excuses की list खत्म होती जा रही है, and every day I'm getting some great excuses that why we cannot study now. Uh, अच्छा चलो, अरे अभी देखते रहो, अभी बहुत तरीके के एक्सक्यूजेस आ जाएंगे. एवरी डे इट इज adding into the list. All right, so the net result is that please, all your apprehensions and anxieties are over now. You have a date available. You know that you have around 34 days available for your preparation, and you know that they can make a significant change in your preparation. And me and Dr. Praveen came very late yesterday night, so today, and both of us were busy in the class, so today we will work on your schedule and we're gonna give you a new schedule for this. All right, but till then, today anyways, it's an anatomy one shot program, so please go with the anatomy one shot program. A few points before we go forward is related to this new matter of apprehension and anxiety that has added to our life, and that is about the normalization. All right. So honestly speaking, when this news was announced, even I was not aware that this is what they are planning to do. But when I went into the more depth of this is probably has done on the request of the students only, as a lot of students requested that they cannot travel. When the previously exam was happening on 23rd of June, a lot of students had to travel to different city and some to different state to write the exam, and this has created a lot of inconvenience to them. And in order to provide them into the same city, this step must have been is being taken basically. So now the first message that is there is that your center is likely to be changed. That's the first message that you have. One. So that means previously if you had to travel to 400 kilometer, now in all probability you will be accommodated in your city. But that now will they have this exam process repeated again? I don't think much repetition will happen. They will do it at the back end there, at their end. They have not changed the internship completion date, so I don't think they will be taking any new forms, and the same forms is gonna be applicable on this one. The second is, now let us talk about this normalization. All right, so I do not know why there was a confusion. There will be two shifts. One paper will be there in the morning and one paper will be there in the evening with the same pattern. That means 5 sets, 42 minutes, 40 questions. So this is gonna remain same. There will be not any change in that. Now let's talk about this normalization. What is happening? I was, to be honest, very irritated when this news was announced. Normally, I do not get irritated with these news, because I believe that whatever that is happening for the good. And specifically when you can't control anything that you cannot control is eventually happening for your good. I do not know why I got irritated yesterday, but when I thought about it, I felt that it is probably in a larger good for the students. But now the challenge is that what if you get an easy paper? What if you get a difficult paper? A lot of students were messaging me. This was a very interesting message that I got. Sir, I think I should get a difficult paper because there are more chances of a higher normalization in a difficult paper. Sir, I think I should get an easy paper. So I have worked a lot on normalization when AIMS did the normalization 2 years back in 2022. So I will record a complete video on the normalization, unlike a confusing video, to give you a very clear scenario that what happens. But please remember, if you are really praying, देखो भगवान सुनता है ना. एक बहुत एक भजन है, इसको कहते हैं ना, कौन कहता है भगवान आते नहीं, तुम मीरा के जैसे बुलाते नहीं. तो God listens to everyone if you are really praying from the bottom of your heart. So don't pray that you get a difficult paper. क्योंकि डिफिकल्ट पेपर प्रे करोगे तो नहीं आता होगा। ये भी प्रे नहीं करना कि बहुत इजी पेपर हो, क्या प्रे करना है, ऐसा पेपर हो जो हमको आता हो, दैट्स ऑल। इजी हो डिफिकल्ट हो मैटर नहीं करता, वी हैव टू प्रे that the paper should be the one that you know, that's all. There is no concept of easy or difficult. The only and the only thing that matters is that what is your raw score. The single most important thing that matters in normalization is your raw score. You are forgetting your raw score. Raw score is the only, I should not say only, but the most important thing in normalization. So let us work on increasing our raw score. And do you know what? The only thing that is in your hand is your raw score. So let us work that how can we get maximum correct in the paper that we get. What? Raw score means your total number of correct minus the negativity. That's what is called as a raw score. For example, there are 200 questions. You did 150 correct and you did 50 wrong. So your raw score is 550. That's what is called as a raw score, right? That's non computer equated score. All right. Okay. Now, what happens? Now, a lot of people were talking about easy paper, difficult paper. Let me tell you that the average level of the paper for the both the exams will be nearly gonna be same. Obviously, it may vary. Okay. Now, normalization is a very, very standardized process considering the data is normally distributed. Now, a lot of people are equating it with the normalization that happened when the NEET prometric system was there between 2012 to 2017. That was not a correct system because the student had an option to choose the time, to choose the exam date. So that means the students are not normally distributed. Whenever there is a random distribution of the students, then it's normalized. Then it's normal distribution. And this is, I can tell you, in every class of mine, I give some questions to the student in the form of a telegram poll. And I can tell you, it does not matter whether I'm taking a class in Bangalore, whether in Hyderabad, whether in Delhi, whether in Chennai, whether in Calcutta, any part of India, the overall poll percentage remains same for almost every question. So that means the students are normally distributed across the country. And so normalization doesn't skew the result. The idea is to normalize. The idea is to equate them. The idea is not to create more difference. The idea is to narrow down the difference, and that is what is called as normalization. All right. So do not unnecessarily worry and unnecessarily add an anxiety level in your preparation. All right. A lot of time when I read the messages on the photo group, it reminds me of this movie which we recently saw. है ना कौन सी थी नाम भूल गया मैं I forgot the name. What was that movie? I told you ना Inside Out क्या हाँ है ना Inside Out 2 है ना तो the anxiety character is exactly matching those students that what if this will happen, what if this will happen. Anything that is not in your control is happening for your good, is happening for your good. Please remember this. The God is gonna balance out the things. All right. So, good morning, Dr. Praveen. Just give me a second. Okay. Yes. Now let me auto telegram group link. I'm gonna share it on both the chats here. Okay. Okay. But now it's a high time. Please stop doing unnecessary messages. Please come into the focus of exam again. You can do a very, very significant make and break in the 1 month. 1 month is a very, very significant time. And I'm telling you, I have seen a very significant difference in people's preparation. All right. But focus on the forgettables. Yesterday, I was talking to a student also, and I'm telling you, if you think that your marks are not improving, now identify that why. What are the kind of mistakes that you are doing? 90% of the people who feel, okay, tell me whether what I'm saying is matching with your thoughts or not. Most of the people who are thinking that their marks are not improving, you are thinking that you are forgetting this stuff. Can I have yes or no in this? Those people who are thinking that their marks are not improving, they feel that they are forgetting this stuff. Hmm. Okay. Now let's think about it. But do you know why you are forgetting this stuff? A lot of time I feel about it that actually speaking, what you are forgetting, you have to understand why you are forgetting. Because the problem is that the way that it is being asked, it has been asked in a specific way. And the example, in fact, one of our dear student from O2 came to meet me in Bangalore, and this is what I was discussing it with her. That what happens is that you have just randomly memorized that stuff, and because you have randomly memorized that stuff, you are forgetting it. And why you have done that? Because you thought that, okay, you will just do it and you just remember this particular table and you will be able to recall it in the exam. Normally, this does not happen. Okay, let me give you a very small example of this. And I want everybody knows about air bronchogram, right? Okay, is there anybody in this session who does not know about air bronchogram? Who has not heard this word air bronchogram? Okay, so can I say everybody has heard air bronchogram, right? Okay, now you get a question in the paper. All of the following are causes of air bronchogram except. All of the following are causes of air bronchogram except. Right. Now, can I say this is a very straightforward question that everybody should be able to answer it? Now, let us see whether you can answer it or whether you cannot answer it. So, I will give you one word. You have to tell me whether this disease will give rise to air bronchogram or whether this disease will not give rise to air bronchogram. Okay, let us try. Okay, chalo. Number one, alveolar hemorrhage. Alveolar hemorrhage. Okay. Number two. Now, no more answer for number one. Number two, alveolar pneumonia. Okay. No more answer for number two now. Number three, lung cancer. Okay. Number four, mycoplasma pneumonia. Okay. Now let us see this. Please think about it. Now, what is happening is, and if you have memorized the table of causes of air bronchogram, there are very high chances that you will do it wrong. Okay. But now, once you have learned what is air bronchogram is when the alveoli are filled with something. And as a result of which alveoli are white and the bronchus supplying it is still patent and it is black. So that means any disease that can involve the alveoli will give rise to air bronchogram. Any disease that does not involve the alveoli will not give rise to air bronchogram. Period. That's all. Okay. What is the most common disease that fills the alveoli? Bacterial pneumonia, consolidation, pneumonia. The most common cause of air bronchogram is pneumonia. But remember, alveolar pneumonia, not interstitial pneumonia. Mycoplasma pneumonia or a viral pneumonia is a type of interstitial pneumonia. So, interstitial pneumonia will not give rise to air bronchogram. So, that means alveolar pneumonia will give rise to air bronchogram. Mycoplasma pneumonia will not give rise to air bronchogram. Right? Okay. Alveolar hemorrhage. In alveolar hemorrhage, what is happening? There is blood in the alveoli. So, it will give rise to air bronchogram. So, alveolar hemorrhage will give rise to air bronchogram. Okay. Lung cancer. Lung cancer is blocking the bronchus. Lung cancer is a bronchogenic cancer. They originate from the bronchial epithelium. They block the bronchus. And since they block the bronchus, they will not give rise to air bronchogram. The only lung cancer that can give rise to air bronchogram is alveolar cell cancer or a bronchoalveolar carcinoma. So this is how you're gonna go forward. All right. So now, so try to work on this. Try to identify that why you did it wrong, and you're gonna see improvement in your GT score. Why you will not see improvement in the GT score? There is a question. There are four choices. The beauty of an MCQ is answer is written in front of you. You need that vision, that why and how this question has been structured. Okay, chalo. So that is how So now for the days, we will try to have this, that get it into the thought process. But I think we have crossed the time limit for the day. Let us get back to our time. Let us get back to our one shot program of the anatomy. But please do not forget to write the test after the session. All right. Chalo, take care and we will meet tomorrow.
Let's start. I know we are little. This is a time when everyone's a little tensed. Most of us have most of the time we have a fake smile on our faces. We are thinking of something else. There's so much going through your mind. What if kind of questions are hovering your head? But guys, take a chill pill. I mean, just relax for now. Let's kind of uh, just enjoy this process. Try to enjoy this process here, because what you can do is something which is possible in the present only. The future all depends on that how our process is. So how about we make our process wonderful, and I hopefully that the result also will be in our favor only. So in that, let us start our session. There are few, I would say, the instruction. Well, instruction. I'm sorry, it is a little harsh term, not an instruction. Let me rephrase. Some suggestions, humble suggestions from my side that I would say that you need to follow, if you could follow during this program. Guys, number one, I want all of you to please keep all your notes, your PDFs and all those annotated part and everything, books and everything aside here. I'll tell you the reason, because I'm not asking you to write down anything. Everything will be annotated here already. It's an animated PowerPoint here. I've really worked hard on this presentation. I hope you like it. And uh, because we had this one shot session last year also, so like obviously there are, like, most of the things are the same only, but it's the way how it comes in. It's the thing which I want to anticipate, that before it comes onto the screen, I want you to think about it. If you have the annotated PDF or the last year one shot PDF or something like that, or even if your class notes with you, then your anticipation will go a little less. So for your own good only, it will be really, really beneficial and you'll really enjoy it if you just keep everything aside and just listen to me for the next how many hours. Okay, it's more about visualization. I tried to put the presentation in such a way that you can visualize, understand, and learning. I kept it for the last, guys. Because you can learn later on also. If there are 5 branches of a certain artery, you have to learn it also. You can do it little later also. But the point is that you need to visualize it right now so that this picture stays in your head. So we need to develop the visual memory, and that is what I'm requesting you to be able to do. Don't worry, I'll give you a break also in between, like everyone is doing that. It's not that we'll be going for like good 4 or 5 hours continuously. So it may go for 4.5 hours, 5 hours, I believe. Okay, no, although I cannot make a pinpoint that exactly when it finishes here, but obviously it will go to the same amount of time only. But we'll do it in 2 sessions, guys. The first session we will be doing here, I'll be starting with the embryology. We'll be doing the limb, upper limb, lower limb. And histology is something that I'll be injecting in between only. Histology, guys, I know that we don't want to do the histology like at once. We don't want to discuss 20 slides of histology. So I've like chosen some 10, 12 slides, important slides of histology. I'll just inject them in between. 2 slides here and there, 2 slides here and there. So throughout this one shot program, we'll be discussing the histo part there. Okay. And the second session, which I'll give you a break of 15-20 minutes in between, and then we'll have a head neck phase, the neuroanatomy, and the visceral discussion. Whatever I feel important about the viscera will be covered in that part. So first we're starting with the embryology, and we're going to start with the general embryology first here. Let's keep the session light, guys. Just don't be stressed about it. I know that the people who are attending this one-shot program, there are 2 types of crowd I'm catering right now. Some of you are my students who attended my class face-to-face, or maybe online, or maybe on some app, or maybe earlier, or maybe you read my notes. And some of the people who never studied with me. So it doesn't matter. It doesn't matter absolutely. I've tried to create this presentation in a way that everyone is benefited. Okay, so look at this picture, guys. This image here, this is an image which is being asked over and over again. I mean, from the last 2 years, they were asking this electron microscopic image in which they're given this picture where the ectoderm, endoderm, the 3 germ layers are visible, different part of mesoderm is visible, and they're asking the derivatives. And this is a kind of question which is not an end question. I mean, they have already asked about neural crest cells in this. They have asked about the paraxial mesoderm. They have a lot to ask. There are many other things which are also available in this to ask. Okay, so let's start first. What you're looking at, guys, you're looking at the 3 germ layers there, the ectoderm, the endoderm, and the mesoderm. Obviously, ectoderm above, the endoderm below, and the mesoderm in between. And all the 3 germ layers are derived from the primitive streak. There's a notochord also which is marked with that green color over there, and it's the notochord which is responsible for the development of the neural tube. You can see the neural tube just above that here, and that neural tube which is actually derived from the ectoderm only, but that is derived from the by the stimulation which came from the notochord. So it's the notochord which stimulated the ectoderm, converted the ectoderm into neuroectoderm, and that's where the neural tube came from. And then at the junction of the neural tube and the ectoderm, we have the cells which are called as a neural crest cells here. I may not be able to reach to that point here, although I'll keep trying that. So look at that point here. This is the point where you'll see the junction of the ectoderm and the neural tube, where the neural crest cells are present. Okay. We'll discuss more about this neural crest cells and the neural tube in a while. Let me just first go through this entire thing. And then look at this, all this colored for area they have shown here. Just next to the neural tube is a mesoderm, which is called as a paraaxial mesoderm. Neural tube is like an axis. So just next to the axis is a paraaxial mesoderm. Just next to the paraaxial mesoderm, we have intermediate mesoderm. The red one which is shown over there is an intermediate mesoderm. And then we have the lateral plate mesoderm, which is the laterally present here. We'll discuss more about lateral plate mesoderm, how it is dividing, but that's the lateral plate mesoderm. Okay. Out of all this, now let me just look at the intermediate mesoderm first. Let's eradicate the one which we don't require for now. Intermediate mesoderm, we will be discussing more about this in the later part, because intermediate mesoderm contributes to the formation of urogenital system. It will give rise to the genital ducts, mesonephric duct, paramesonephric duct, even genital ridge, which will give rise to gonads. They will be derived from the intermediate mesoderm. Now, what are those parts of intermediate mesoderm? What are those genital ducts, their derivatives and remnants? We will discuss them at the end. So just keep it on hold for now. So all I'm trying to do here is, let's just this intermediate mesoderm, as said, it will give rise to all the genital ducts. So let's forget about this intermediate mesoderm for a second. Let's get rid of this, and let's compare the two mesoderm here, that is a paraaxial mesoderm and the lateral plate mesoderm. And they are very much comparable to each other. If you know about one, you automatically know about another one. If I know the paraaxial mesoderm, I also know about the lateral plate mesoderm. So it's very, very simple to compare the two. Look, when you look at the paraaxial mesoderm, guys, paraaxial mesoderm, like if it is a neural tube here, the paraaxial mesoderm is present on both the sides. So along the entire length of paraaxial mesoderm, there is a ball-like condensation which will take place, and those are called as somites. So somites are the ball-like condensation which are formed from the paraaxial mesoderm, which are along the present on the side of the neural tube only. Now, people do ask me this, that, okay, what is the number of somite? I mean, initially the number of somite is more, guys. Now, somites are like 42 to 44 pairs of somite initially. And then the somites will keep on reducing. Some somite from the occipital regions are gone. Some somite from coccygeal regions are gone. And the somite number will come down to 36 to 38. But sometimes the examiner get a little cranky and they ask you questions like, okay, tell what is the exact number of somite. Though I honestly, I don't believe that in the embryology, they should not be asking questions like this. But in past, not in the recent time, because recent time the NEET and INICET, they're sensible to ask the logical questions. They used to ask the question in which they ask like particular number, that just tell what is the number. So if the examiner being the Sardar, and the Sardar asks you that, okay, kitne somites say, how many somites were there, your best answer there will be 37. It's 36 to 38 pairs of somites which are there, but 37 pair is the best answer. It is according to the Langman, I'm telling you, the Langman has quoted 37 in that here. But again, the number of somite should be between 36 to 38 pairs. So somites, guys, these are ball-like condensation. As I said, if you look at the picture of the somite, this is how the somite will look like. So if this is a neural tube here, you can see that's a neural tube in the center. And look at this paraaxial mesoderm. And then on the paraaxial mesoderm, you can see this ball-like condensation present here. These are called as somites here. So this view is actually from the top. When you remove the ectoderm and then you're looking at, then I can see, okay, somites are visible only after removal of the ectoderm only. Somites, what they give rise to? Somites divides into different parts called as a dermatome, sclerotome, myotome. If you don't remember that, doesn't matter. Just remember, guys, somites will give rise to the dermis of the back, axial skeleton, and they will also give rise to the skeletal muscle. The skeletal muscle, except those skeletal muscle which are derived from pharyngeal arches, because that's a different story altogether. So somites will give rise to what? Dermis of the back, the axial skeleton, that is ribs and vertebrae. Very, very recent question, guys. Last year they asked this question only, that ribs are derived from where? And the picture was something like that, where you have to point out the paraaxial mesoderm. Somites will give rise to the axial skeleton, and somites are coming from paraaxial mesoderm. Okay. And we have skeletal muscle, like all skeletal muscle you can think of, upper limb, lower limb, and any kind of skeletal muscle, even axial skeletal muscle, they are all coming from somites only, except those which are like pharyngeal arch skeletal muscle. That is a different story, I already told you. Okay. What about lateral plate mesoderm? As you can see, lateral plate mesoderm is divided in two parts. If you look carefully, the lateral side of that embryonic plate, you can see that there is a coelom over there. And because of the coelom, the lateral plate mesoderm is divided in two parts. We have this, the somatopleuric and splanchnopleuric lateral plate mesoderm. One which is present above, close to the ectoderm, that is somatopleuric, and the one which is below toward the endoderm, that is a splanchnopleuric lateral plate mesoderm. Somatopleuric and splanchnopleuric lateral plate mesoderm. We already know what should be derived from the lateral plate mesoderm. I told you whatever is not derived from the paraxial mesoderm is derived from the lateral plate mesoderm. So I already have a list in my head. I know, okay, dermis ho gaya, dermis of the back is done, axial skeleton is done, and skeletal muscles are done. So what is left, guys? Dermis of the frontal limbs are remaining, appendicular skeleton is remaining, and smooth and cardiac muscles are remaining. But we need to decide that out of all these which I just said, which one of them are derived from the somatopleuric and which one are from the splanchnopleuric lateral plate mesoderm. So somatopleuric lateral plate mesoderm is the one which will give rise to what? It will give rise to the dermis of the front and limbs. Obviously, dermis makes sense. It should be from the body wall only, dermis of the front and limbs. It also gives rise to the to the appendicular skeleton here. Upper limb and lower limb bones are also derived from this somatopleuric lateral plate mesoderm. What is left? Skeletal muscles are from here. So what about the splanchnopleuric? This will give rise to what muscle? It will give rise to smooth muscles and cardiac muscles. Obviously, there are some exceptions in smooth muscle, and cardiac muscles are only at the cranial end. But at least I know that broadly the smooth muscle and cardiac muscles are derived from splanchnopleuric lateral plate mesoderm. So guys, if they give you this picture, here, then you should be able to identify that, okay, where and what it is derived from. Chali. Moving on. Now, let's talk more about this neural tube and the ectoderm, guys. Neural tube and the ectoderm. Now, when you look at the neural tube, guys, how exactly the neural tube is formed and what neural crest cells, where they're coming from here. Just look at this the animation that on the screen here. Now, what you see, guys, this ectoderm, it starts to fold on. I told you that notochord will stimulate this. Now, this ectoderm starts to fold and that forms a neural groove. And once this neural groove keeps on folding, the folds will come close to each other, and the cells which are present at the margin of the folds, these cells, these are the ones which are the neural crest cells actually. And eventually what will happen, the neural tube will separate, the neural crest cells will proliferate and they will leave that area, and ectoderm will also separate. So all the three will become a separate entity here. Look at that. Now ectoderm is separated, neural tube is separated, and we have a junction of the ectoderm and the neural tube where we have the neural crest cells, that is the neural crest cells. So this is just to tell you that how exactly it is done. So the ectoderm only it folded with the stimulation came from where? From the notochord, and that's how the neural tube, notochord is this neural tube is formed, and the neural crest cells are separating themselves from the ectoderm as well as from the neural tube. And I hope you all know that neural crest cells are also called as a fourth germ layer. They're giving rise to so many structures that they also called as a fourth germ layer. What about the notochord, guys? Notochord, after it stimulates the nervous system formation, notochord will just have some remnants only. And the remnants of notochord is what? That is apical ligament of Dens, that is one. Membrana tectoria and nucleus pulposus. If you don't remember all three of them, doesn't matter. At least nucleus pulposus you should remember that here. So guys, notochord is the one which will that's the notochord here. These are remnants of notochord that you're looking at here. That is a nucleus pulposus, apical ligament of Dens odontoid process, guys. There is a ligament present on the odontoid process. That is apical ligament of Dens, and tectorial membrane or membrana tectoria. It is just the continuation of posterior longitudinal ligament. Membrana tectoria is just a continuation of posterior longitudinal ligament. Honestly, not very, very important. Nucleus pulposus is something which is likely to be asked if this question is ever asked in the exam. Okay, now what about the neural tube and the neural crest cells? The origin is same only. They both are formed from the ectoderm only. One becomes neural tube, one becomes neural crest cell. So there has to be some similarity between them. And the similarity lies in, guys, that neural tube will give rise to the structure which corresponds to the central nervous system. So it's more like central nervous system and you can say the supporting cells of central nervous system. Brain and spinal cord, it's central nervous system. Oligodendrocytes will do myelination for central nervous system. Astrocytes will form blood-brain barrier. Ependymal cells, it forms the ventricles lining, also part of central nervous system. And retina and retinal pigment, guys, optic nerve, retina, they are all extensions of brain only. So if you look at that list over there, all you have to think about is this central nervous system. Anything which is, if you can correlate something with the central nervous system, it is directly or indirectly derived from the neural tube only. So the point is central nervous system is the keyword there. When it comes to the neural crest cells, now we have two types of derivative there. We have some derivatives which are corresponding to peripheral nervous system, and some of the derivatives which are mesenchymal derivative, which looks like mesodermal in origin. So if you look at this, like there's a long list for the neural crest cells, guys, but my recommended list is this one. So if you look at this list of the neural crest cell derivative, now first look at these three here, all ganglion cells. Now, it doesn't matter which ganglion are we talking about. Is it a parasympathetic ganglion? Is it a sensory ganglion? Is it a inferior mesenteric ganglion? Or is it a sympathetic chain? Or is it a dorsal root ganglion? Ganglia word aate hi samajh jao. The moment you say the word ganglia, obviously it is a part of peripheral nervous system. Central nervous system mein to we have nuclei. In peripheral nervous system we have ganglion. So any ganglion anywhere in the body, they are all derived from neural crest cells. Enteric plexus, myenteric plexus, Meissner's plexus, Orbeck's plexus. You read about all these plexes, right? And these plexes are present in the wall of GIT, part of peripheral nervous system. That's away from the brain and spinal cord. Schwann cells, guys. Schwann cells will do the myelination for what? Peripheral nerves. Like oligodendrocytes were doing the myelination for central nervous system, the Schwann cells will do the myelination for peripheral nerves here. Adrenal medulla, parafollicular seed cells, melanoblast, like adrenal medulla, guys. Adrenal cortex, the outer part of adrenal gland. Adrenal cortex is derived from the intermediate mesoderm, and adrenal medulla, which is having a sympathetic ganglion also inside, that is derived from the neural crest cells here. So adrenal gland you can divide in two parts. The outer part, the cortex part of the adrenal gland is from intermediate mesoderm, and the core part, the medullary part here, it is from the neural crest cells. Parafollicular C cells here. Parafollicular cells or C cells, these calcitonin producing cells, they are not derived from the pharyngeal arches. It's the neural crest cells which will migrate into pharyngeal arches, and then they will give rise to the parafollicular C cells. So if you have option to choose between the neural crest cells or ultimobranchial body or pharyngeal arches, whatever is given, your definitely best answer for the parafollicular C cells is the neural crest cells. Okay, melanoblast, guys, except for retinal pigment, leave the retinal pigment there, and except for retinal pigment, any other pigment epithelium you can think of, all melanoblasts, melanocytes here, that is all derived from the, what do you say, from the neural crest cells. And then we said some mesenchymal derivative. Especially when you look at the head and neck structures, बहुत सारे structures को देख के ना आपको ऐसा लगेगा कि यार this should be derived from the mesoderm. Like there are many structures you will see and it will look like okay, this should be derived from mesoderm, like skull bones, dermis of the head and neck, like cartilages, so dentine. But in head and neck region, that mesenchyme is actually coming from neural crest cells only. So the skull bones, most of them, the dentine here, the pharyngeal arch cartilages, head neck, the dermis of the head and neck region, that is all coming from the neural crest cells. Okay. And then we have a conotruncal septum, guys. Conotruncal septum, I'll discuss more about this. Conotruncal septum, it's a septum which is dividing, partly it is dividing the ventricle and partly it is dividing the truncus arterius. It's a conotruncal septum. It's between the conus and the truncus. Conotruncal septum. It's a septum which is dividing the heart, ventricle, interventricular, forming a part of interventricular septum, and it is also dividing the truncus arterius. So collectively we call it a conotruncal septum. Dr. Doolittle, yes, beta, this is, yeah, if you talk about the cell body, obviously it is inside the central nervous system. So that cell body is derived from the CNS part, but the axon which is going out, that is the peripheral nervous system. That is coming from the neural crest cells. Okay, chalo. So as I said, when you think of the neural tube, it's about the central nervous system mainly. And when you think of the neural crest cells, it's mainly about the peripheral nervous system. Like mainly, I'm not saying everything here, that their peripheral nervous system derivatives are there. And you also see then some of the derivatives over there are the mesenchymal derivative. So this is a little about the general part here. I mean, I hope you understood a little about that, what is paraxial mesoderm, the intermediate mesoderm and lateral plate mesoderm is doing. Neural tube, how it is formed, notochord, what are the remnants here, and ultimately the neural crest cells and the neural tube derivatives. Okay, guys, I may not be able to like look into the group right now because I can see they are posting some questions in there, but you know that will kind of break our rhythm here. So I'll definitely answer your questions, but I hope that you don't mind if I do it like after the session. Okay, chalo. Now guys, from this portion, let's move on to some development of some of the important structures. Like one is diaphragm, guys. Without a doubt, diaphragm development is extremely important. Diaphragm, development of the diaphragm, this question has been asked like since ages, guys. I can follow this question all the way back to 2005 and all that. Like even those examination, I remember the development diaphragm or aaj bhi poochte hai, development diaphragm. So diaphragm is derived from 4 structures, as you can see A, B, C, D marked over there, because they're now asking image-based question also. You should be able to identify them. A is the body wall mesoderm. You can also call it the cervical myotome. Now, what is a body wall mesoderm? Body wall mesoderm is a somite only. Paraxial mesoderm. Body wall mesoderm is a paraxial mesoderm I'm talking about here. And why I'm saying cervical somites or cervical myotome? Because diaphragm ka nerve supply comes from phrenic nerve, and phrenic nerve root value is C3, C4, C5. So it tells me that diaphragm is the muscular part of the diaphragm is derived from the cervical myotome only, the cervical somites only here. So that is the one which will give rise to the muscular part. The major muscular part of diaphragm will come from there. The point A, more toward the posterior lateral side. Then B is the dorsal mesentery of esophagus. Now, when you talk about the mesentery, we talk about the mesentery of the stomach, we talk about mesentery of the intestine, we talk about mesentery of colon, but we never talk about mesentery of esophagus. Well, guys, developmentally, there was mesentery of esophagus also, but that mesentery of esophagus is utilized to form the crura of the diaphragm or crus of the diaphragm here. That is coming from the dorsal mesentery of esophagus. Then look at most anteriorly, that's C. That is a septum transversum. What is septum transversum? It is undivided lateral plate mesoderm. Septum transversum is an undivided lateral plate mesoderm. Septum transversum, before the folding of the embryo, it is present at the cranial end, and with the folding of the embryo, the septum transversum actually came in this area. And then it gives rise to multiple structures, to the fibrous pericardium, central tendon of diaphragm. It contributes to the liver also, liver stroma. So in the septum transversum, in the developing liver, it contributes to the central tendon, So just don't be confused, guys. This is a picture of a developing diaphragm. Don't expect to see the central tendon in the center right now. Septum transversum came in here, and then eventually it will go inside and become a central tendon here. So when you look at a developing picture here, you may confuse the option B with septum transversum. Don't do that here. Septum transversum is most anteriorly placed, and eventually it will form the central tendon. And then look at the D, that is the dark pink over there, guys. This is the pleuroperitoneal membrane. Now it's the membrane, guys, which is basically separating the pleural cavity and the peritoneal cavity. That is called as a pleuroperitoneal membrane. And that muscles which are coming from the above, from the body wall mesoderm, these muscles will only invade it. So there's a very thin membrane formed there, and that pleuroperitoneal membrane is invaded or incorporated by the muscles only. But now there are two conditions. Let's say if this pleuroperitoneal membrane is absent, bana hi nahi. If there is no pleuroperitoneal membrane, there is a persistence of pleuroperitoneal canal. There is no membrane over there, so there is a persistence of the pleuroperitoneal canal. And if that is the case, obviously that leaves an opening toward the posterior lateral side, and that is called as a Bogd-like foramen, and that leads to the congenital diaphragmatic hernia. That leads to the congenital diaphragmatic hernia. As you can see that picture over there, that video over there, you can see toward the posterior lateral side, that's the Bogd-like foramen, and you can see the intestine herniating through it here. More common toward the left side, so obviously it will go above here, and these intestines will obviously push the lung, and they will not allow the lung to develop, cause the lung hypoplasia. Look at these intestines here, and they're pushing the lung, causing lung hypoplasia, the left lung hypoplasia. The congenital diaphragmatic hernia, correct. Then we have a pleuroperitoneal membrane incorporated by the muscle. Now guys, let's say the pleuroperitoneal membrane is formed. In this case, there was no pleuroperitoneal membrane. No membrane. It was a canal. But let's say the pleuroperitoneal membrane is formed, but there is a failure of muscle to incorporate that. If muscles will not incorporate that what will happen? In that case, there will be a thin membrane which will be separating the pleural and the peritoneum, and that membrane will not be able to stop the intestine to come above. So that is also leading to a kind of, although it's not a true hernia, it is called as an eventration of the diaphragm, guys. That is called as an eventration of diaphragm. Look at this very thin membrane over there. On the scissor you can see that's a very, very thin membrane over there, and that is a membrane which is separating the pleural cavity and the peritoneal cavity. So it's not a complete foramen, it's not a complete opening over there, but still it is like causing the kind of hernia only. It's similar to congenital diaphragmatic hernia, but the difference between the two cases, in the first case, when the absence is there of the pleuroperitoneal canal, it is leading to the CDH, and in this case, the pleuroperitoneal membrane is formed, but there is no muscle which is forming in it here, so membrane is very, very thin, and it is not able to stop the intestine from herniating above. Right, so that is about the about the diaphragm development and the conditions. Chali sir, let's move on. Now moving on to the pharyngeal arches. Now when I talk about pharyngeal arches, guys, I'll tell you something. Everything about pharyngeal arch is important. Pharyngeal arch, ectoderm, endoderm, pharyngeal arch arteries, pharyngeal arch skeletal cartilages, everything about pharyngeal arch. In your embryology preparation, please do keep pharyngeal arches as your priority. 100%. Okay, just to give you a better idea of the pharyngeal arch, guys, look at that picture over there, and that line is telling you that if you take a section through the pharyngeal arches, through a coronal section, now that's how this coronal section is going to look like. So you're looking at the pharyngeal arches over, that's one arch over there, this one arch in here, and in the core of the pharyngeal arch, we have mesoderm, that's a mesoderm inside. On the inside, that is an endoderm, and outside that is ectoderm. You have an endoderm and ectoderm here. What you'll also see that spaces on the outer side. On the outer side, all those spaces are called as the clefts. Between the pharyngeal arches, all those are clefts here, and the spaces in the inner aspect of the pharyngeal arches are called as pouches. So clefts and pouches. So our discussion here is about the clefts and pouches only. Okay. So now we got a rough idea about how pharyngeal arches are present. We have a core of mesoderm, endoderm on one side, ectoderm on one side, and then we have like clefts and pouches. Clefts are on outside and pouches are on the inside. Now the mesoderm of the second pharyngeal arch, look at this image, guys. The mesoderm of the second pharyngeal arch, that's the second pharyngeal arch. Look at the green color here is corresponding to the ectoderm, and the red color here is corresponding to the endoderm. So obviously all these are what? Pouches. Where I'm pointing it right now, all these are pouches. And all these are clefts. Look at my thumb here right now, it is pointing toward the clefts. All these are clefts. Ectoderm of the second pharyngeal arch will overgrow and joins below. And that's why what happens, all these clefts are obliterated. All the clefts are obliterated here. The second cleft, the third cleft, and fourth cleft are obliterated. And this space over there, this embryological space present over there is called as the cervical sinus. This cervical sinus, usually it is obliterated, but let's say if the cervical sinus, it fails to obliterate, if it persists even after birth, that will give rise to the cyst. I'm sure everyone knows that is a branchial cyst. The painless, harmless swelling that you see along the sternocleidomastoid, guys, that is a branchial cyst. It is nothing but the persistence of the cervical sinus. There is a persistence of cervical sinus. Okay. Then we have the ectoderm of the first arch. Look at it. If you look at the out of all the clefts, only first cleft is the one which persists. All other clefts are gone. Only first cleft persists here. And if you look at the side of the head and neck, there is only one opening present on the side, and that is external auditory canal. So guys, the first cleft will give rise to the external auditory canal, and it will also give rise to the outer layer of tympanic membrane. Which makes sense, guys. Outer layer of tympanic membrane and the external auditory canal lining, it is ectodermal. It is made up of skin only. So first cleft will give rise to the external auditory canal and the outer layer of tympanic membrane. That's about the cleft. So nothing much in the cleft here. The cervical sinus, it usually obliterates all the cleft here. If it persists, then the branchial cyst, and only derivative we have for the first cleft only. But when it comes to pouches, now look at pouches, all of them are there. So now we have the pouch number 1, 2, 3, 4, which I marked over there, right? Those are all pouches. First pouch, and you can get the idea of the first pouch from the first cleft only. If the first cleft is giving rise to the outer layer of tympanic membrane and external auditory canal, then the first pouch will give pouch cleft will give rise to the external auditory canal. So first pouch will give rise to the inner layer of tympanic membrane, middle ear cavity, and the two extensions, that is eustachian tube anteriorly and mastoid antrum posteriorly. So first pouch derivative, pouch means endoderm only. First pouch will give rise to the inner layer of tympanic membrane, which is facing toward the middle ear. So lining of the middle ear cavity also. And just think about the two extensions of the middle ear, that is the eustachian tube anteriorly and mastoid antrum posteriorly. Second pouch will give rise to the palatine tonsil, to be strictly speaking only the lining epithelium of the palatine tonsil. Third pouch will give rise to the thymus and inferior parathyroid gland. Now don't forget that it's thymus and inferior parathyroid gland, whereas superior parathyroid gland will come from the fourth pouch here. So superior is below and inferior is above. And this is because of thymus only. You know, thymus ultimately will migrate into the mediastinum. So when thymus migrates downward, it also brings the inferior parathyroid along with it here. So thymus and inferior parathyroid together, and that is it. Now, we don't have fifth pouch, because we don't have fifth arch. So we don't have fifth pouch, but we have a remnant of the fifth pouch, and that remnant of fifth pouch, it gives rise to something called as the ultimobranchial body. A remnant of fifth pouch will give rise to ultimobranchial body. If there is an anomaly in the development of the third pouch or fourth pouch, I'm sure you read about that, guys. That is one of the most common microdeletion syndrome you must have read about. That is a Digiod syndrome, when there is an absent thymus and hypoparathyroidism here. So if there is an anomaly of the third pouch and fourth pouch, sometimes only third pouch or sometimes third and fourth pouch both, that is the most common microdeletion syndrome, the Digiod syndrome. And the Digiod syndrome, we say that there is an absent thymus, there is hypoparathyroidism. That is the case of digital. This question is asked as an image-based question in the exam twice, guys. Twice it was asked in an image-based question. They just put an arrow on the different pouches in the cleft, and they've asked you that anomaly of the which of the pouch or which of the cleft will give rise to the to this absent thymus and hypoparathyroidism. And about the ultimobranchial body, I already told you, don't bother about it. Ultimobranchial body actually is not giving rise to anything directly. It's the neural crest cells which migrate into ultimobranchial body, and they will give rise to the parafollicular C cells. So if the question is asked, C cells are derived from where? Still, your best answer is neural crest cells. Ultimobranchial body is the second best answer. It's just the site where the neural crest cells will migrate. That's about the pouches, about the cleft, guys. One cleft and then all about the clefts here, right? Okay. Then, guys, we have the pharyngeal arch cartilages. Now, somebody is asking about the cartilages only. The pharyngeal arch cartilages. When you look at the cartilages inside the pharyngeal arches, they are derived from the neural crest cells only. They're coming from neural crest cells, the mesenchyme of neural crest cells. If you look at these different colors here, it tells you about which cartilage is coming from where. Like first arch cartilage will give rise to the malleus, it gives rise to incus, and it also gives rise to the Meckel's cartilage. Now, Meckel's cartilage is something which will give rise to Meckel's cartilage will give rise to some part of the malleus also. Meckel's cartilage directly will not give rise to the much part in the mandible. See, mandible is a flat bone. I mean, mandible is a part of a skull bone, and skull bones are membranous in ossification. And if a bone is coming from membranous ossification, then it doesn't need a hyaline cartilage. Meckel's cartilage is hyaline cartilage only. So Meckel's cartilage directly is not giving rise to too much in the mandible. Here we just have a remnants only. But it is not wrong to say that first arch will give rise to the mandible and maxilla and the zygomatics and squamous temporal. They are all indirectly coming from first arch only. But directly, if I say that from the first arch, direct derivative says the Meckel's cartilage, it is the malleus and the incus. Second pharyngeal arch will give rise to the stapes. Look at the blue color over there, the styloid process, the stylohyoid ligament, lesser cornua of the hyoid bone, and some part of the upper body also. If you say lesser cornua, that is still okay, but even upper body of the hyoid also. Stapes, guys, stapes except the footplate of the stapes. Stapes except the footplate of the stapes is derived from there. The styloid process, stylohyoid and stylohyoid ligament, and lesser cornua of the hyoid, along with the upper part of body of hyoid also. Look at the yellow color over there. The greater cornua of the hyoid bone and the body of hyoid, mainly the lower part of body of hyoid, it is derived from the third pharyngeal arch. And then fourth and sixth arch, they collectively give rise to the laryngeal cartilage. I would recommend you not to read them separately here because the different authors have different opinion on that. And there's a lot of controversy behind that. So I would say that thyroid cartilage, cricoid cartilage, in fact, all laryngeal cartilages are collectively derived from fourth and sixth arch. So first arch shown in the orange there, the second arch in the blue, the yellow is showing the third arch, and the red and the green collectively showing you the derivative of fourth and sixth arch. Exactly. Otic capsule is coming from the foot plate, giving us the foot plate of the stapes and the ligament. Right? Okay. Now moving to the pharyngeal arch arteries. But before moving to the pharyngeal arch arteries, because the next topic is quite animated here, you will see all different arteries coming in here. Let me just take a very quick feedback in the group here because I'm not talking too much in the group in between. So guys, is it going fine? Am I going with a fine speed? I mean, because we have to cover a lot. So if you find it a little fast, so do let me know. If the speed is okay, please do let me know that also so I can modify it right away only. I'll just wait for your response and then immediately I'll start with the pharyngeal arch arteries after that. Okay, that's perfect. Thank you. Chalo guys, perfect. Then you just kind of elevated my mood immediately. So now pharyngeal arch arteries. Now again guys, please look at the screen here because this you will not find this in the last year, the one shot, the way I've prepared these slides very recently only for you guys. Now pharyngeal arch arteries, we have two dorsal aorta guys. We have right and the left dorsal aorta. The name says dorsal aorta, so they're at the back. Look at that. Let's say this is a right dorsal aorta and there is a left dorsal aorta. The right dorsal and the left dorsal aorta. So dorsal aorta, Nami dorsal aorta, they are at the back here. And then we have the more in front, the developing heart is there, and the cranial end of the developing heart, that is called as the aortic sac, which divides into the right horn and the left horn. Look at that aortic sac here. It is dividing into the right horn and the left horn. And this aortic sac, which is dividing into right and left horn, it is connected with the dorsal aorta, the right and left dorsal aorta, by 6 pharyngeal arch arteries, like 1, 2, 3, 4, 5, 6, like the 6 arch arteries there, and that's how they are connected to each other. Okay, if it's a bit fast, I can kind of try to reduce the speed a little, but but I have to cover a lot, and I don't want to like make you sit the whole night. So the arch arteries, we have a first arch artery. You can see that's the second arch artery, the third arch artery, the fourth arch artery, fifth and the sixth arch artery. So they are connecting this aortic sac, the right and left horn of aortic sac, and they're all going backward and under connecting to the dorsal aorta. So I hope you got this picture in here, that these are pharyngeal arch arteries, 1, 2, 3, 4, 5, and the sixth arch. Initially 6 arches are there, fifth arch disappears later, but these are the 6 arches that we got initially. Okay. Also, I want to mention one more artery here, because next slide will use this picture, but in a more like light format. There is an artery which is coming from the dorsal aorta, and that is called as the 7th cervical intersegmental artery. Guys, 7th cervical intersegmental artery. What is the 7th cervical intersegmental artery? Initially, dorsal aorta is having multiple branches. We have 7th cervical intersegmental, thoracic segmental, lumbar segmental. Just segmental arteries are there. But I just need this 7th cervical intersegmental artery. That is right side, and this is left side here. And this will be playing some role in the formation of subclavian artery. We will see that here. So I hope you got this basic picture first, that we have an aortic sac, we got the right and the left horn, we got 6 pharyngeal arch arteries going backward and connecting to the dorsal aorta, right and left dorsal aorta, and that is the 7th cervical intersegmental artery. Out of other arteries are also there, but I've just chosen the 7th cervical intersegmental artery there. Okay. Now let me take this picture once again, but I'm just making it very faded here so that we can only look at the arteries which are going to persist here. There we go. So the same image, guys, the same picture again here, but it's very, very faded image here. Let's now start with the main artery first, guys. Now, this is the aortic sac, and you're looking at the right and the left horn of aortic sac. Now, guys, I'll keep showing you one artery here, and there will be text which will come onto the side here. I wanted to keep on comparing it so that you can kind of correct, you can check your slides also simultaneously, because the same slides are going to reach you as well. Now, aorta is derived obviously on the left side. So the development of aorta will take place by what? It is by the aortic sac, number 1, left horn of aortic sac. Then it's a left fourth arch artery. Look at that fourth arch artery, left fourth arch artery, and the left dorsal aorta. But I'll tell you, in the examination, you don't have to remember that much. If you just remember the left fourth arch artery, that I can promise you that is more than enough. Left fourth arch artery is more than enough. But to discuss the entire development, I need to tell you that there are 4 components there. Just check out those components, guys. Aortic sac, just check out on the side. Then we have a left horn of aortic sac, the left fourth arch artery, and that's left dorsal aorta. Left dorsal aorta. Thank you. I'm really looking forward to all your messages. I cannot curtail myself, but from looking away from the phone. But I need to focus right now. So this is the arch of aorta. Now, what about brachiocephalic artery, guys? Brachiocephalic artery has to go toward the right side, and obviously brachiocephalic artery will divide into the again common carotid and subclavian. Bas right mein to jana hai. So brachiocephalic artery is by this only. The right horn of the aortic sac will give rise to the brachiocephalic artery. Is it correct over there? Right horn of aortic sac. AS is aortic sac there. Okay. Now, let's talk about the artery which is on both the side. That is common carotid and subclavian. Look at it, guys. Look at the third arch artery. I wanted to focus on third arch artery. Third arch artery on both right and left side will give rise to common carotid and internal carotid, whereas external carotid artery will come out as a bud only. Third arch artery will give rise to common carotid as well as internal carotid, which will continue above also. No need to discuss that. And external carotid artery will come out as a bud, as in vasculogenesis from that artery here. So it is not wrong to say that common carotid artery is derived from the proximal part of third arch artery, and internal carotid artery is by the distal part of the third arch artery. External carotid is just like a bud only. So common carotid is by the proximal part of third arch artery, and internal carotid is from the distal part of third arch artery. CCA is by proximal part, guys, and look at that. ICA is from the distal part of the third arch artery. Let me bring those arteries back to you. 7th cervical intersegmental artery. There we go. That's a 7th cervical intersegmental artery. The left side and the right side. Abhi left side, no problem, guys. Left side 7th cervical intersegmental artery is now looking at directly coming from aorta only. So left 7th cervical intersegmental artery will give rise to left subclavian. Finished. Left subclavian artery, look at that, left subclavian artery. It is by the left 7th cervical intersegmental artery. Only this artery is enough to form the subclavian artery. No problem. But when you look at the right side, now this is a puzzle to be solved. On the right side, only 7th cervical intersegmental artery is not enough. I need something more there. I need this 4th arch artery also to contribute to that. So what will happen? The fourth arch artery will also contribute here, like it will join with that. Some part of dorsal aorta also, like I'm ignoring that, that's not very important. So fourth arch artery of the right side and then seventh cervical intersegmental artery of that side collectively will give rise to the subclavian artery of the right side. Right subclavian artery, very important, guys. Subclavian artery development, anomalies of subclavian artery, and I say this in my regular class also, that then one artery that you should not leave ever is subclavian artery. Everything about subclavian artery is important. So right fourth arch artery, this one, and then seventh cervical intersegmental artery. So quite a difference between the right and left subclavian artery. Then this LB here represents the lung buds, developing respiratory buds and lung buds. And obviously lung buds are invaded by the artery only, and that is a sixth arch artery. Look at that, guys. You can see sixth arch artery is invading the lung buds. So it tells me obviously what arteries are those? Pulmonary artery. That means this portion here is giving rise to pulmonary artery. So is it the entire sixth arch artery? No. Only the proximal part of the sixth arch artery forms the pulmonary artery. Proximal part, whether it's right side or left side, proximal part of sixth arch artery forms the pulmonary artery. Whereas the distal part of the left sixth arch artery, distal part of left sixth arch artery will give rise to what? What is that? That is ductus arteriosus. That is a ductus arteriosus. So ductus arteriosus, look at that. Just keep on comparing the text over there, guys. Distal part of the left sixth arch artery. If you keep on comparing the text right away, now you don't have to revise it later. I know we have to just finish off this with anatomy tonight, and maybe tomorrow you'll be reading through all these PDFs and everything, and you just need to get over with this here. Just tomorrow there's a new subject here. So obviously we have this only, this is this present is the time that we have to cover up this subject here. So guys, just please focus. So that's a ductus arteriosus. And you know that after birth, the ductus arteriosus will close, will become ligamentum arteriosum. And this also was a question asked in the INICET, that patent ductus arteriosus. They gave the picture of the patent ductus arteriosus, and the question was, it is because of the anomaly of which arch artery? And imagine they don't even ask the distal and proximal part. They're just asking right, left, and which arch artery. So sixth arch artery of the left side, precisely distal part of the left sixth arch artery forms ductus arteriosus. And if it persists even after birth, that is patent ductus arteriosus. Let me also resolve one more question here, which is asked in the NEET and INICET both, about the recurrent laryngeal nerve, guys. Now look at the left recurrent laryngeal nerve. All of you please look at the screen. If this is the recurrent laryngeal nerve of the left side, look at this recurrent laryngeal nerve going below the distal part of sixth arch artery. And this distal part of the sixth arch artery will persist. Even after birth, it will persist in the form of the artery, or maybe a ligament, or maybe some fibrous structure. Something will be there. Some anatomical structure will be there. And that's why this recurrent laryngeal nerve never got a chance to go above this level. That's why your left recurrent laryngeal nerve is longer. But if you look at this side here, there is no distal part of the sixth arch artery. There is no fifth arch artery. So ultimately, recurrent laryngeal nerve of this side will hook below the fourth arch artery. And guys, fourth arch artery on the right side forms subclavian. That's why your right recurrent laryngeal nerve is below the subclavian artery, and your left recurrent laryngeal nerve is below the arch of aorta and ligamentum arteriosum. So it's a longer recurrent laryngeal nerve in that case. Okay. So left recurrent laryngeal nerve hooks under the left sixth arch artery, which persists in the extrauterine life. Look at the text here. I've just given the relevant text here, so that when you read that, if you get a question, you know, okay, what exactly we need to, what language we need to look at here. Let me read that for you guys. Left recurrent laryngeal nerve hooks under the left sixth arch artery, which persists in extrauterine life also. Obviously, it is persisting in extrauterine life as ductus arteriosus, ligamentum arteriosum, fibrous eminent. Kuch to hoga na? And this nerve will never go above here. And on the right side, neither we have the distal part of sixth arch artery, nor we have fifth arch artery. So obviously, recurrent laryngeal nerve is present below the fifth arch here. Thank you, Neha. I hope I live up to this throughout this presentation. Okay, so that is about and let's do one thing, guys. Whatever the arteries are left over there, let me just shoo them away. Like let's give them off. Look, does it look like I've tried it? I hope it looks like that how the arteries are present in human being. Though I can try it a little better next time. I'll try to formulate a more curved lines or something. So, but yeah, that's the arch of aorta. You can see this, the brachiocephalic artery. You can see one common carotid, and you can see subclavian over there. You can see common carotid and subclavian over there. You can see the pulmonary arteries, which obviously is not coming from the aorta. That's from the pulmonary trunk. And then we have a ligamentum arteriosum. Okay. Thank you. I kind of like doing these little animations here, and if it comes good, then nothing like that. Chalo. Let's get back to the story again. Now, guys, let me just tell you a little about the abnormal subclavian artery. Now, that's a picture I took it from the IBSing only, so it's a picture which is like well known to everyone. In this, they have shown the aorta and the pulmonary trunk separated. Now, if you're looking at this is the aorta, that's a pulmonary trunk completely. Now, truncus arteriosus is separated here. Now, guys, the condition here is if the right side fourth arch artery is obliterated. If right side fourth arch artery is obliterated, then where the subclavian artery will come from? If the fourth arch artery of the right side is obliterated, then guys, this artery needs to persist. Generally, this artery is not there. If I go back and show you that that artery vanished. So generally, this artery will not. That means this is a caudal part of what? It's a caudal part or lower part of right dorsal aorta. This is the left dorsal aorta. This is the right dorsal aorta. Caudal part of the right dorsal aorta. This will persist now because there is an obliteration of the fourth arch artery, and that will give rise to the abnormal subclavian artery of the right side. Look at that, guys. Now this subclavian artery will be formed like this here. Instead of coming from fourth arch there, the subclavian artery will be coming directly from the aorta because there is a persistence of the caudal part of right dorsal aorta. That is only when the fourth arch artery is not persisting, and that is the abnormal right subclavian artery. The reason it is abnormal right subclavian artery, guys, because this artery is coming from the left side. Aorta is on the left side, and imagine the artery is coming from left side, so obviously it must be passing behind the esophagus, causing dysphagia lusoria. Look at that artery over there. This artery is like, look at this artery is going backward. It is passing behind the esophagus here, and then it is going toward that side here. That's the abnormal right subclavian artery causing dysphagia lusoria. Rightly said, that is causing the dysphagia lusoria. Rakesh dear, I'm really sorry. I will not be able to share this PowerPoint with you because no, they are being misused that way. But PDF will be there, and it's a very meticulous, every step PDF is there for sure. So whatever, like right now, what you're looking at the picture, that entire PDF will reach you. But I'm really sorry. I will not be able to give up the PowerPoint. It's a core hard work which I've put in. I think I deserve that to keep that PowerPoint with me. I hope you don't mind that. Okay. So guys, overall, if you look at the pharyngeal arches, like if you look at the first arch, second arch, third arch, fourth and fifth and sixth arch. Abhi first and second arch, we did not discuss anything about first and second arch because first and second arch arteries just have remnants only. First arch artery remnant is the maxillary artery, and second arch artery remnant is the stapedial and hyoid artery. Just remnants only, guys. First arch artery remnant is maxillary artery, and second arch artery remnant is hyoid and the stapedial artery. These are the arteries which are present in the embryonic life, right? That is artery present in embryonic life. Third arch, fourth arch, fifth arch, and sixth arch. Now, I want you to, because I hope that you've not opened any book or anything in front of your notes. Think about it, guys. Third arch artery was giving rise to the common carotid and then internal carotid, right? Common carotid and internal carotid. That's okay. Sorry, I was trying to hide it. Third arch artery is common carotid and internal carotid. Fourth arch artery is giving rise to the arch of aorta, and the subclavian artery. Arch of aorta on the left side and right subclavian artery, that is from fourth arch. Fifth arch artery goes nothing. Fifth arch artery, there's nothing. And sixth arch artery forms the pulmonary artery. The proximal part forms the pulmonary artery, and the distal part, it contributes to the ligamentum arteriosum. That is ligamentum arteriosum. Sir, maze maze lo tum. Okay. So right, this was pharyngeal arch arteries. Kya mushkil hai yaar? That's easy peasy Japanesey. So this is about the arterial arch artery and development. Chalo sir. Now from this arterial development, let me take you to the venous development here. We're going on time, no worries. So take a deep breath. Try to absorb whatever is coming your way. I know whether it's my subject or any other subject in these one-shot program, it goes very fast. It goes like there's too much of content to be discussed in a very short amount of time. But you know, this is what we asked for. So let's take it nice and easy. I hope you understood it, because when you see this slide, when you see this PDF, and which I'll share with you, just by looking at the picture, you can easily make out, okay, what is coming from where. Just do one favor, guys. Please make sure that you revise everything tonight only. Don't even leave it for tomorrow. आज सोने से पहले ही कर डालना है इसको. बस एक बार just go through this PDF and you're done with it. Thank you, Ghosh. Chalo sir, let's come to the venous development. I need more attention from your side here. So, venous development, people find it, venous development, guys. Okay. I should not be looking at to the Telegram here, because I know people will be watching this video even after we are done with this live session here. So they will be like that, whom am I talking to? But yeah, doesn't matter why they are not watching it live. They should watch it live. चलो सर, देखो बेटा, venous development in the embryo we have a vein called as a common cardinal vein. देखो, in the embryo, in the embryonic life, there is no superior inferior vena cava. So we have an anterior cardinal vein. The vein which is carrying the blood from above is anterior cardinal vein. The one which will carry from below is a posterior cardinal vein. Anterior cardinal, posterior cardinal. Right anterior cardinal vein, right posterior cardinal vein, both will join and form common cardinal. Left anterior cardinal, left posterior cardinal join together to form common cardinal vein. There we go. I hope this makes sense. Look at these arrows here. I hope these arrows will tell you that, okay, how the blood is coming here. That's a right side system, that's a left side system. Just to make it easy, I'm not writing right and left. You are smart enough to understand that. Look, the vein which is coming from above, those are what? Anterior cardinal vein, and the one coming from below are posterior cardinal vein. That is the right side system. And that same left side system is there, and they together form the vein called as a common cardinal vein. The right common cardinal vein and the left common cardinal vein. This is the initial type of venous system that we have, and that is not enough. We need more veins to develop because other organs are also developing. Simultaneously, kidney ban raha hai, gonads ban rahe hain, suprarenal gland. There's so many things which are developing. So we need more veins, guys. So with the developing kidney, well, these are the kidney, that's developing kidney here, and these veins that you see which are attached to kidney, these small veins over there, their embryological name is a mesonephric vein. Abhi renal vein nahi bolna inko. These are mesonephric vein. That's a right mesonephric vein. This is a left mesonephric vein. So now this posterior cardinal vein, guys, which is going above here, it is like, okay, I need to take the blood from kidney also. So it will just take the blood from the kidney and then join back to the respective posterior cardinal vein. It's like you have you're going from point A to point B and you're hungry and there is no restaurant there. So obviously what will take? You'll take a detour. You just eat at the restaurant and join back to the main highway only. This is exactly what is being done, guys. These veins are collecting the blood from developing kidneys and they join back to the main highway only, that is posterior cardinal vein. This vein is called as a subcardinal vein. Names are important. The subcardinal vein, that is right subcardinal vein, and this is a left subcardinal vein here. Subcardinal. So subcardinal veins are the one which are taking the blood from the developing kidneys. Then we have another set of vein. Before subcardinal vein are collecting the blood from right and left developing kidneys. Not only that, there will be anastomosis between the subcardinal vein, and that is called as inter-subcardinal anastomosis. Look at that anastomosis. There is a inter-subcardinal anastomosis. And guys, this is inter-subcardinal anastomosis. And there is another set of vein that you will see also coming like this and collecting the blood and going back from the other viscera also. That is called as a supracardinal vein. The another vein is also developing there. That is what? The look at that. So the same thing. Going away and then coming back to the same main highway only. This vein is called as a supracardinal vein, guys. This is called a supracardinal vein. I hope whatever vein you're looking at in this picture, you are able to visualize them here. You have an anterior cardinal vein coming from above, posterior cardinal vein coming from below. Then kidneys start developing. Then we have vein collecting the blood from developing kidneys joined with the posterior cardinal vein only, that is subcardinal vein. And we have an additional vein over there called the supracardinal vein also doing the same. Okay. Now again, let me take this picture. Please remember these names, guys, because I'm not gonna, in the next picture, I'll get rid of all these labelings here. And just like the arterial development, let me just make it faded so that we can look at the major veins here. Look at this picture. You're already oriented to this image. Now I need to move aside a little. Okay. Upar se shuru karte, guys. Let's start from above. Now what you see here, in the development of the first, let's start with the superior vena cava. Abhi superior vena cava is a combination of the right brachiocephalic and left brachiocephalic. Now be it superior vena cava or inferior vena cava, they are formed on what side only? The right side. So obviously, whether it's a superior vena cava formation or inferior vena cava formation, our main focus will be toward the right side. Guys, look at the vein which is now being highlighted over there. That vein is carrying the blood from the head and neck region from above. So that is brachiocephalic vein. Now this brachiocephalic, if I consider this as a brachiocephalic vein, that is going toward the left side. I want the brachiocephalic vein to take the blood toward the right side only. So there is a formation of anastomosis called as an oblique anastomosis. Look at that here. So it is not wrong to say that right brachiocephalic vein is this one, that is a right brachiocephalic vein. And this one here is a left brachiocephalic vein. So right brachiocephalic vein is by the right anterior cardinal vein, that one. And left brachiocephalic vein is a small part by left anterior cardinal vein. And this anastomosis called as an oblique anastomosis. That is called as an oblique anastomosis. Oblique anastomosis. And obviously, when the two brachiocephalic veins will join with each other, they will give rise to superior vena cava. Look at that, guys. That one and that one, these two are superior vena cava. So superior vena cava is derived from where? It is by the right anterior cardinal vein and also by the right common cardinal vein. Right anterior cardinal, small part of right anterior cardinal and right common cardinal vein, that is a superior vena cava. So one problem sorted. We got both the brachiocephalic vein and we also got the superior vena cava. Okay. Now, let's focus below here. Inferior vena cava banana, guys. Inferior vena cava. Now, it is like a puzzle only that where is inferior vena cava in this here. Inferior vena cava will be formed from only, again on the left side only. It is formed by, now look at my finger and look at this highlighter coming right now. This is the right side posterior cardinal vein. This one here. That is supracardinal vein. There will be anastomosis. There will be subcardinal vein. And there is a hepatocardiac channel, which I'm not writing because that's not important from the exam point of view. We need to be a little exam oriented here. So this, whatever I highlighted over there, guys, this is inferior vena cava. Before the labeling comes over there, I want to just say this to yourself, guys. What are the things which are giving rise to inferior vena cava? What are the things that you marked over there? This is the posterior cardinal vein of the right side, right posterior cardinal vein, right supracardinal vein, that is supracardinal vein. This is anastomosis, like you don't have to mention that, but there is obviously anastomosis there. And then we have the main thing is a right subcardinal vein. That is a right subcardinal vein, which will join with the hepatocardiac channel. That part is not very important. So the main four component of the inferior vena cava, if I write, I want you to please check that out. Right PCV, right posterior cardinal vein, right supracardinal vein, right subcardinal vein, anastomosis there, and then obviously right subcardinal vein. These are the component of inferior vena cava. And in the major vessel, the thing is, the moment you get the inferior vena cava or artery or main artery or main vein, then it's very easy to find out the tributaries. Abhinay, you start visualizing, guys. Obviously, when we talk about the kidney, look at this. Let me just make this area dark here. So, guys, that is a right mesonephric vein. I'm pointing my finger at that is a right mesonephric vein. So, right mesonephric vein is alone from what? Right renal vein. But left mesonephric vein, and also we need what? Intersubcardinal anastomosis. That forms the left renal vein, and that's why the left renal vein is longer also. When you look, obviously your IVC is toward the right side. So right renal vein is shorter and left renal vein is longer. The reason is in front of you. Because right renal vein is just by the right mesonephric and the left renal vein is by the left mesonephric and mainly by the intersubcardinal anastomosis, which is make it longer. Okay. Now the vein which connects the superior vena cava and inferior vena cava, this is last year NEET image based question, guys, cadaveric image based question. It was about the azygous vein. Azygous vein connects the superior and the inferior vena cava. Now I'll tell you, this is a superior vena cava in this picture. This is inferior vena cava here. The one common mistake which people does, and I want all of you to be very careful about that, guys. This is not azygous vein. Look at my finger. This is not azygous vein. Azygous vein job is to connect superior and the inferior vena cava, but ये azygous vein नहीं है. Azygous vein is this one. This is the azygous vein. That means azygous vein is formed by a small part is by the posterior cardinal vein, but the major part is by the supracardinal vein. Look at that's a supracardinal vein here. That's the right supracardinal vein. So generally, they don't give two options or three options to choose from. It is like one main option you have to choose here. So we'll say right side supracardinal vein forms azygous vein, as the job of azygous vein is to connect the superior and the inferior vena cava. This part will vanish, guys. This will be gone. So look at this. Does it make sense? Azygous vein is by the right supracardinal vein. That mainly is the right supracardinal vein and some contribution by right posterior cardinal vein also. That is azygous vein. A very recent question only. Okay. Then, okay, guys, just think about the vein on the right side and left side, which are draining into IVC and renal vein. Same story below and the same story above. Gonadal vein, right gonadal vein and left gonadal vein. Guys, right gonadal vein goes into IVC and left gonadal vein goes into the renal vein. So that tells you that, there we go. Look at that. These are gonads. All the gonads are almost the size of the kidney only. So I'm sorry for that inappropriate size. So this is the caudal part of the subcardinal vein that is giving rise to what? The gonadal vein, whether it's a testicular vein or ovarian vein, guys, that is derived from the caudal part of the subcardinal vein. And suprarenal vein, Adrenal gland will be formed. Adrenal gland will drain on the left side into the renal vein and again on the right side into inferior vena cava. So it's not wrong to say that I'm so sorry. I don't know why I said that. So adrenal vein is derived from the cranial part of the subcardinal vein. Cranial part of subcardinal vein. Just मौका चाहिए, जरा सा मौका चाहिए, जैसे ऐसे एकदम से गायब हो जाता है सब उधर से. Come back. वापस आते हैं. Caudal part of subcardinal vein forms the gonadal vein, and the cranial part of subcardinal vein, it forms the adrenal vein or suprarenal vein here, right? So, and that also justifies, that also tells you that why the right side adrenal vein and right gonadal vein goes into inferior vena cava, and left gonadal vein and left adrenal vein goes into the renal vein. The answer is in front of you, right? Just check out the text for that. Gonadal vein by the caudal part, and adrenal vein is by the cranial part of subcardinal vein. And again, let's shoo away other veins here so that we can see exactly how these things look like here. There we go. So that is about the development of the venous system here. And once you understand the normal development, you will not have a difficulty with anomaly. You can understand, whatever is giving rise to inferior vena cava on this side, if the same thing will persist on the left side, that will give rise to left IVC. If that oblique anastomosis is not formed, there will be left SVC. So the normal development is very important to understand, because then only the abnormal development can be understood here. So this is about the venous development. Need a little feedback from you once again, guys, how the venous development was. I hope you like that. These animation, this kind of helped you to revise it a little faster. My regular batch students, they know how much I made them draw in the class, everything, and then made them color and everything. But this, for the revision sake, I think that's easier. Thank you. Thank you for all these lovely emoticons. I don't know where you get this from. Paisa vasool. Chalo sir. Let's keep going. So after the venous development, let's come to another part where it is about I'm going to read every message that you're sending, right? Like I'll just scroll back to the very first message where I said, okay, I'm starting, and then I'm gonna go and gonna scroll every single all these topics, and we'll find out that what all lovely messages you're writing, and obviously we'll find out your queries also in between. So it's not that I'm just looking for those messages only. Chalo guys. So from the venous development, arterial development, so it's we're done with the main thing about the pharyngeal arches. We talked about the pharyngeal arch arteries. We talked about the venous system. Now let's talk about the mesogastrium. Dorsal and the ventral mesogastrium, guys. Dorsal and the ventral mesogastrium. Okay. See, what is the story about the ventral and dorsal mesogastrium, guys? If you look at the stomach, because stomach is the only viscera which is having a peritoneal fold in front also and behind also. Otherwise, if you see beyond, I mean, if you look at the intestine, if you look at the colon, the mesentery is only present at the back here. But in case of the developing stomach, gastrium, we have a dorsal mesogastrium. That's everything that you see behind stomach, that is dorsal mesogastrium, and everything that you see in front, that is a ventral mesogastrium. Abhi, ventral mesogastrium will give rise to what? You just have to think about lesser curvature stomach, liver, anterior abdominal wall. Whatever ligament you can think of, kuch ratna nahi hai. There is no rot learning in this. It's just a simple concept only, guys. Lesser omentum is connecting the stomach to liver. So that means lesser omentum is derived from the ventral mesogastrium. Liver is connected to anterior abdominal wall by falciform ligament, also from the ventral mesogastrium. And liver itself is surrounded by the ligaments called as the coronary ligaments and triangular ligaments. They're also derivatives of ventral mesogastrium. Falciform ligament was the image-based question asked in the NEET, but any other ligament they can ask you, doesn't matter. So whether it is lesser omentum, whether it is a ligament of the liver which is surrounding it, or whether it is a falciform ligament, they're all derivatives of the ventral mesogastrium. Then dorsal mesogastrium, guys. Dorsal mesogastrium will give rise to what? Dorsal mesogastrium may, you think about the greater curvature. You have to make up your mind that what I'm looking at. I'm thinking about the greater curvature stomach. Abhi greater curvature stomach, the fundus part is connected to diaphragm. That's a gastrophrenic ligament. Stomach and spleen are connected by gastrosplenic ligament. Spleen and kidney on the posterior wall are connected by lenorenal or splenorenal ligament. And then obviously on the greater curvature, what omentum will be there? The greater omentum. So obviously all these are derivatives of what? The dorsal mesogastrium. So dorsal mesogastrium derivatives are gastrophrenic, gastrosplenic, lenorenal, greater omentum. All these are derivatives of dorsal mesogastrium. So it's a very simple and basic concept that we need to see, that ventral mesogastrium, it's all about lesser curvature. Say you have to go toward the abdominal wall, anterior abdominal wall. And for the greater dorsal mesogastrium, think about the greater curvature and just go backward. Whatever ligament you'll find in your pathway, every ligament is derived from the dorsal mesogastrium. And again, that's not a terminal question, guys. They've already asked a falciform ligament and image-based question. I have a very, very strong gut feeling for this. They will ask you something else. Again, they give you an image, they put an arrow on maybe lesser omentum, maybe greater omentum, something, and they will ask you, okay, where it is derived from. So it's a question which is not ending just by the falciform ligament only. And I generally look at the questions that way only. In anatomy, there is nothing new to ask. Abhi tuberculosis ka treatment to hai nahi, it will keep on changing every 6 months. So in anatomy, what new they will ask you is, they will just keep on formulating the question from the same topic only, but the examiner is very smart to formulate new questions every time. But I always say these are very predictable, guys. When you're looking at PYQ, just knowing the answer to PYQ is not enough. Everyone is reading PYQ. Yaar, sabko aate PYQ ka answer. That's no big deal here. The point is how much you can extract out of the topic. How much, no matter how much the examiner tries to give you an image-based question on that or clinical question on that topic which is already asked here, मैं उसको miss नहीं करूँगा. I'm not going to miss out on that part. And this is the way of looking at the PYQs only. Just not reading all these long explanation given the GTs. That is not enough here, because sometimes I see there's a very, very long explanation given on some questions here, but I don't find it useful here. I need to look at, okay, what is that question? What is the answer? What is the important topic over there mentioned here? And then I need to read it from somewhere else, not from any of the explanation given in GTs. Chali sir. No, beta, not bile duct. Bile duct is not derived. Bile duct is derived from foregut only. It is the extension from the foregut itself. Bile duct is an endodermal structure. Mesogastriums are all mesodermal. So one last thing in the embryology part, and that is the genital ducts development here. Let me take you back to the very first slide when we said intermediate mesoderm. We talked about paraxid mesoderm, we talked about lateral plate mesoderm, but we did not talk about the intermediate mesoderm, guys. Intermediate, everything that you're looking at over there here, intermediate mesoderm only. This yellow colored structure over there, that is a urogenital sinus coming from cloaca. And whatever this blue, red, orange, and gray that is shown over there, that is all intermediate mesoderm, guys. Intermediate mesoderm will give rise to genital ridge, that is genital ridge over there, which will give rise to gonads, testis and ovary. And it will give rise to the two ducts over there, that is mesonephric duct and paramesonephric duct. The mesonephric and paramesonephric duct. Moon Knight beta, hepatogastric ligament and hepatoduodenal ligament is just a name of lesser omentum only. No, naam socho na, why, just again not outlining. Hepatogastric, liver se stomach, and hepatoduodenal, from liver to duodenum, that's lesser omentum only. The two parts of lesser omentum is called as the hepatogastric and hepatoduodenal ligament. So that is nothing new that you mentioned there. Okay, so intermediate mesoderm is having mesonephric and paramesonephric. Let's say if this is an image-based question, it's pretty simple. The duct which is more outside, it's para. जो परे है, that is paramesonephric duct, and the one which is more inside, that is mesonephric duct. So the duct that you see which is close to the gonads, developing gonads के जो पास में है, that is a mesonephric duct, the red one over there, and the blue one is a paramesonephric duct. Though eventually the paramesonephric duct will come and join with each other, and then they invade the urogenital sinus. If you notice one thing, mesonephric duct, guys, all of you look at the red color over there. Mesonephric duct is entering into the urogenital sinus individually. Right one separate, left one separate. Paramesonephric duct of both the side will come, eventually will fuse, and then they invade the urogenital sinus from posterior side. Mesonephric duct, also called as the Wolffian duct, it is a duct for both male and female. I mean, it is required equally for both male and female, because mesonephric duct will give rise to what, guys? Number one, it will give rise to the posterior wall of urethra, posterior wall of prostatic urethra in male, and posterior wall of urethra in female also. Trigone in male, trigone in female, and the ureteric bud derivatives and trigone. See, ureteric, what is ureteric bud derivatives? The collecting portion of kidney. All the collecting portion of kidney, the collecting duct, renal papillae, major minor calyces, ureter, all these is coming from ureteric bud, or ureteric bud खुद किससे आता है? Mesonephric duct से. So look at this here. Till now, what you're seeing, that mesonephric duct has almost equal role to play both in male and female. Forming the urethra also, forming the ureteric bud also, trigone also, same here. But from this point onwards, the mesonephric duct is main duct for male, because it will give rise to the spermatic pathway, the vas deferens, ejaculated duct, epididymis, and even appendix of epididymis also, which is a remnant only. So spermatic pathway and appendix of epididymis, that is coming from in the male, that is from the mesonephric duct here. Whereas in case of female, we only remnant is present, and that remnant in the female is called as a Gartner's duct, also called as a duct of Epiphoron. So Gartner's duct, guys, Gartner's duct hai, Gartner's cyst nahi, and Gartner's duct is located in broad ligament here. I always emphasize in this question because when you ask any intern or post-intern about the Gartner's duct, they start thinking about Gartner's cyst. Gartner's cyst is present in the upper vaginal wall. Gartner's duct is present in the broad ligament. Don't forget that Gartner's duct is in the broad ligament. I hope that flashing light just stays in your brain. I don't drink beer. Paramesonephric duct, guys. Paramesonephric duct for male and female. If you look at the paramesonephric duct for female, it is a main duct because it is giving rise to the, like you can make out with the shape also, it will give rise to fallopian tube, it will give rise to the uterus, fundus of the uterus, the body of uterus, cervix, and upper part of vagina also. So paramesonephric is main for female, fallopian tube, uterus, and upper vaginal wall, that is in female. Male mein khali only remnants are there, guys. In male, only remnants, that is a prostatic utricle, which is a blind opening present on the prostatic urethra, and appendix of testis. This is appendix of epididymis, guys. This is appendix of testis we are talking about, appendix of testis. This is about the mesonephric and the paramesonephric duct. So guys, this is about the embryology part. So that's the major embryo chunk. Obviously, yaar, one shot hai, to aisa to nahi ki we are going to everything here. But I hope that I'm able to kind of revise the major chunk on the important part of the embryology from you, from where the most likely the questions are asked from there. Okay. Yes. Water. There's nothing like water. As I said, the histology will come in between like some injections only. So thoda histo kar lete guys. Let's take a couple of slides in the let's discuss a couple of slides of the histology also simultaneously, guys. Now I'm going to show you a couple of slides here, like cardiac muscle and the skeletal muscle. Both basic slides हैं, but यार exam में पूछते हैं, तो obviously we should be knowing about them. Now if you look at this picture of the cardiac muscle, now what you're looking at here, guys, cardiac muscle, the one thing about is the branching. When you look at the next slide, which is of skeletal muscle, there are parallel bundles here, but the cardiac muscles, they are profoundly branched. They're like a lot of branches there. And if I just take out a small portion of this cardiac muscle, and if you look carefully here, what you'll notice in the cardiac muscle is that we have the nucleus, we can see oval and round nucleus present somewhere in the center. Like, unlike the skeletal muscle where the nuclear, peripheral, and the flat nuclei, we have more of a like centrally placed nuclei, the single nuclei there. It's not multinucleated like in case of the skeletal muscle. And the most important thing in the cardiac muscle is the intercalated disc here. Now, if you look at this picture only, you can see one intercalated disc over there. You can see one over there. Oh, my hand is being cut over there. I'm going out of the frame. So, like, look at the picture here. Look at this pointers, the arrows over there. They are pointing at the intercalated disc. And intercalated disc are the one which are actually the functional syncytium here. The type of junctional complex which are present at the intercalated disc, we have like zona adherences there. We got gap junctions, we got desmosomes. These are the type of junctional complex which are present at the intercalated disc. And guys, this gap junction, it's very important because gap junction is the one which permits the ionic traffic and which from one cell to another cell. And that provides the functional syncytium. That's how obviously the ions from one cell move to another cell, and that is because of the gap junction only. We say na intercalated disc is a functional syncytium, and that is because of these gap junctions only. And then the desmosomes are the one which are the anchoring filament. They are the one which are anchoring the two cells with each other here. That is the desmosome which anchors the end to end of the cardiac fibers here. इसमें question ये पूछते हैं in the cardiac muscle that okay, which type of junctional complexes is seen or not seen that way here. So zona adherens is there, the adherent junction, the gap junction, and the desmosome is seen. If you compare it to the skeletal muscle, guys, skeletal muscle, it's quite clear. First of all, look at the parallel bundles. No branching there. It's a parallel bundle that you can see in the skeletal muscle. And secondly, if you look at the nuclei are flat and peripheral nucleus. There are a lot of cross striations also. You can all see all these cross striations are there here. You must have read about these striations in your physiology class also, that the actin and myosin filaments are there. A band, H zones are there. So these are all cross striations, and look at the nuclei, the way the nuclei are present, they are all peripheral and flat nuclei. They're multinucleated. You can see multiple nuclei are present over there. They're multinucleated, and we have a flat and peripheral nuclei in case of the skeletal muscle. Chalo, it was just a double dose of the histology in here. I'll keep on injecting slides in between here. Chale, moving on. Histology becomes a little monotonous, and we have to keep talking about that. That's why I just kept in between. Guys, let's start with our next unit here, and we now gonna start with the upper limb here. Now, upper limb, what makes the upper limb important? One, hand will make it very, very important, and the nerve and nerve injuries. When it comes to the clinical question, upper limb is far more important than lower limb when it comes to the nerve injuries question, guys. Okay, so without a further ado, let me just start with some important muscles here. Now, scapulohumeral muscle. Not every muscle is important. There's some muscle which I'm going to discuss with you, and along with their action also. Guys, understand, and this is something which people ask me a lot, that sir, which muscle is to be read? There's so many muscles present in the upper limb, lower limb, head and neck. I'm not going to read those 700 muscles in the human body. Obviously, you need to look at the muscles. And if you're looking at a long bone, especially long bone, I'm talking about femur and humerus. The upper end of the humerus and upper end of the femur, according to me, are the two most important side for the muscle attachment questions to be asked. Look at the history of PGME examination, guys. First of all, you will not find a question asked on the origin. Ab check karna, you will not find a question on the origin. It's always an insertion they will ask you, because the muscle is going to make a movement at the insertion point. And insertions are usually at the upper end of a long bone, whether it's the upper end of tibia, upper end of the femur, upper end of radius ulna, upper end of the humerus, and upper end of humerus and upper end of femur in that category, in that list, becomes the most important. What you're looking at right now, you're looking at the lesser tubercle, which is present in the front here. That is a lesser tubercle. There is a lesser tubercle, and there's a muscle attachment over there. There's a subscapularis muscle. There's a muscle coming from the front of the scapula. That is subscapularis muscle, and that attaches there. Then look at this. This is the bicipital groove. Bicipital groove will give passage to the long head of the biceps, and there are three muscles which are attached over there, which is a lady between two major, right? You know that lady between two major. The lady here is what? Latissimus dorsi, and the two major is pectoralis major and teres major. That is a lady, that is latissimus dorsi, and the two major, pectoralis major is more lateral and teres major is more medially placed here. That is medial to lateral. You're looking at the lateral to medial. That is the three muscle over there. And when you look at the what do you say, the muscle mode? One thing, why I'm discussing these muscles together? Subscapularis muscle is on the lesser tubercle, and then we have the three muscle here. And look at all these muscles have different origin, guys. One of the muscle coming from the anterior surface of scapula. Pectoralis major will come from the anterior surface of the chest wall. Latissimus dorsi तो पीछे से आ रहा है, back से आ रहा है. Teres major is coming from the lateral border of scapula. All different region, but all the muscles are inserted in front of the humerus. Like, doesn't matter the muscle is coming from the front from here, or even if it is coming from back, but ultimately they're coming in the front of the humerus. So all these muscles, they pull the arm inward and rotate inward like this. So adduction and internal rotation is their common function. Whatever muscle you're looking at right now, guys, their common action is adduction and internal rotation. They all help in adduction and internal rotation. What about the lateral side? That is that tubercle over there is a greater tubercle, guys. Greater tubercle or greater, like in the femur we have greater trochanter. That's a greater tubercle. Abhi greater tubercle is giving passage or insertion of three muscles. That is sit muscles, SIT. That is supraspinatus, infraspinatus, and teres minor. Subscapularis is coming from the front, so it is an internal rotator. Supraspinatus comes from above, so it is an initiator of abduction. And teres minor and infraspinatus पीछे से आते हैं. They come from posterior side, so they are external rotator. Muscle सामने है, internal rotator. If the muscle is coming from back, that is external rotator. If it is present on the top of the joint here, it is just helping in the initiation of abduction. So guys, supraspinatus is for the 0 to 15 degree of abduction. Initiation of abduction is by supraspinatus, whereas infraspinatus and teres minor muscle both are responsible for external rotation. They will also help in adduction to an extent, but main action is the external rotation. Adduction, any muscle which is running horizontally will help in adduction, guys. Doesn't matter it is present in front or behind. So adduction तो सामने वाला muscle भी कर रहा है, पीछे वाला muscle भी कर रहा है. But what is different is the muscle present in front is causing internal rotation, and the muscle coming from posterior side to greater tubercle will cause external rotation. Vertebroscapular muscle, one of the recent question again, last year question only. Now the three muscle that you see which is inserted, we just talked about these muscle. We saw that supraspinatus is there, that is infraspinatus there, and that is teres minor, and that's a greater tubercle, guys. It's just that you're looking at the greater tubercle from posterior side. So supraspinatus, look at my finger over there, supraspinatus inserting there. That is infraspinatus. Whole muscle is this big muscle is infraspinatus only here, this one, and that is a teres minor muscle, and all of them are inserted on the greater tubercle. Now let's focus onto the muscle coming from the vertebral column to the scapula, the vertebroscapular muscle. We have a levator scapulae, number one. we got rhomboideus minor, and then look at this big muscle, which was actually the image-based question, that is rhomboideus major. The one common thing about these three muscles is, be it rhomboideus minor, major, or levator scapulae, there is a nerve which is running along them and supplying all three of them. That is called as a dorsal scapular nerve, coming from the root of the brachial plexus. C5 root of the brachial plexus, the dorsal scapular nerve will supply all three of them. Levator scapulae, naam hi bata raha guys, levator scapulae is for the elevation of scapula. Rhomboideus minor and major will help in what? Retraction. And when they retract, now look at this, and understand with this fiber here, when the levator scapula, this rhomboideus minor and major, they will retract the scapula, they will take the medial border of scapula upward and medially, so glenoid cavity will be rotated downward. The question asked in the exam was about the glenoid cavity. What will be the direction of the glenoid cavity when the rhomboideus major will contract? So it will rotate the glenoid cavity downwards. Retraction of scapula and rotation of the glenoid cavity downward is the glenoid fossa, glenoid cavity downward. That is a function of rhomboideus minor and major. So they're pulling the scapula upward and medially, and glenoid cavity is turning downward. Okay. Then coming to some of the important, the humeral fractures and nerve injuries. What are the nerves which are vulnerable to injury in the different end level of the humerus, guys? If you look at the surgical neck of the humerus, the nerve which is passing behind the surgical neck of the humerus is axillary nerve. So the surgical neck of the humerus fracture, that obviously axillary nerve is most likely to injured. The nerve which is passing from the spiral groove, the nerve passing from spiral groove is what? That is radial nerve. So any mid-shaft fracture which is passing through spiral groove, radial nerve is most likely to get involved in that. If it is a supracondylar fracture, now this is some people get it wrong at times here. In supracondylar fracture, it's the anterior interosseous nerve which is most commonly involved. Anterior interosseous nerve is a nerve present in the forearm, and it's a branch of the median nerve. Anterior interosseous nerve is the one which is most commonly involved in the supracondylar fracture. Actually, that's a fibrous band which is connected to anterior interosseous nerve in the supracondylar fracture. That fragment rotates backward. The band pulls the anterior interosseous nerve. So, both indirect injury hai, but if the question is asked, what is the most common nerve to be involved? So, it's an anterior interosseous nerve, branch of median nerve. Both median nerve and anterior interosseous nerve are given in the option. Go with anterior interosseous nerve, guys. Medial epicondylar fracture, no surprises there. It's the ulnar nerve. Ulnar nerve is present behind the medial epicondyle. So that is the nerve most commonly involved. In fact, even in the lateral epicondylar fracture, again, it's the ulnar nerve which is most likely to get involved and not the radial nerve, because tardy ulnar nerve palsy. When there is a the lateral epicondylar fracture, what will happen? There is a cubitus valgus, guys. There's a valgus deformity. Now, if this angle will increase on this side, so there is a stretch on the medial side, and again, ulnar nerve will get affected. Medial epicondylar fracture में direct injury to ulnar nerve, no doubt about that. Lateral epicondylar fracture में it's a cubitus valgus, and that stretch to the ulnar nerve causes the tardy ulnar nerve palsy. The cubitus valgus deformity called tardy ulnar nerve palsy. Chalo, moving on from this to the main point, that is the hand, guys. This is something we have to discuss in detail about the muscles of the hand. Okay, here we go. Hand muscles, the thenar and hypothenars first. Dekho, when it comes, this is a very commonly asked image-based question. Now, first let me give an orientation of this, how this slide is going to come to you. I'm going to use the red color for the ulnar nerve and blue color for median nerve. That this is going to be universal color in the next 3-4 slides. So ulnar nerve will be showing with the red and median nerve with the blue, just to show you that what muscle is supplied by what here. These are thenar muscles here. On the other side, these are hypothenar muscles, and then lumbricals are also visible in that here. Okay, what muscle is visible? The muscle which is visible very much outside here, that is abductor pollicis brevis, pollicis of the thumb, abductor pollicis brevis, and we have a muscle which is more inside, that is a flexor pollicis brevis. Unless we remove these two muscles, I will not be able to see the muscle opponens pollicis. So opponens pollicis is not visible now, guys. So abductor pollicis brevis and flexor pollicis brevis is visible. Opponens pollicis is present more deep to that here. So image-based question may don't expect to get the opponent's pollicis, because they have to remove these muscle and then this picture become very distorted here. So in the image-based question, it is going to be this image. It is going to be this image, guys. So they will be asking you the muscle which are visible right now to you. So abductor and flexor pollicis brevis. And look at that, and look at, I'm drawing with the blue color over there, they're supplied a median nerve. And there is one odd muscle here that is called as adductor pollicis, and adductor pollicis is supplied by the ulnar nerve. Actually, ulnar nerve will come from medial side like this, will make an arch like this, and ultimately ends by supplying adductor pollicis. It is the last muscle to be supplied by the ulnar nerve, also called as a graveyard of the ulnar nerve. So adductor pollicis. Adductor pollicis muscle is very, very important. The reason being, guys, if let's say if I remove these tendons, now you're able to see the entire adductor pollicis. All these long tendons are being removed. All these flexor digitorum superficialis and profundus tendons are removed. And now I can see adductor pollicis muscle completely. Coming from the shaft of third metacarpal, running very much horizontally. It's a big, big muscle over there. And obviously you need a very strong adductor, guys. To hold the objects in between your palm and the thumb, you need a very strong adductor here. Let's say if I want to hold the case here, so obviously let's say if I'm trying to pull this away from my hand and I need to hold this here, so I need a very strong adductor pollicis muscle here. Look, all the fingers are working on the other side and thumb is working opposite to them, so I need a strong adductor pollicis muscle there. But let's say if the ulnar nerve is injured and adductor pollicis is not working, so what the patient will do, they will curl the thumb like this to try to do a trick movement here, because the adductor pollicis is not working. So now they're curling the thumb and using the interphalangeal joint to try to hold the object in between. And this is called as the book test which is done, and this sign is called as a Froment sign. When you see a patient curling his thumb to hold the object between the radial side of the hand and this thumb, that is a Froment sign, guys. That is a Froment sign. It is seen in the book test here, right? It's a book test for the ulnar nerve palsy, and the Froment sign, you will see the thumb is being curled. Yeah. Okay. If I look at the other side here, this was an abductor, this was a flexor. The same story on the other side, guys. The muscle which is more outside is abductor digiti minimi, and that is flexor digiti minimi. Ulnar nerve obviously is the main nerve supplying them here. So as of now, out of the 4 thenars and 4 hypothenars, opponents to nahi dikhai dega. So forget about opponent's pollicis muscle because that is not visible unless you remove these muscles there. Adductor pollicis muscle is another important muscle you need to remember. So abductor, flexor, abductor, flexor, and one strong adductor of thumb, that is adductor pollicis. Coming to the second group of muscle, that is lumbricals. The property of lumbricals, whether the lumbricals are present in the hand, that's why yeah, Eklavya has to he need to shot the arrows with the thumb at least. We have to, initially we have to use the thumb to mark those OMR sheets. Now, if you have to mark answers, you can just do it by the foot also. I know this. So we don't need the thumb. So you can also give away your thumb to me. Chalo. Guys, long tendons, lumbricals. What's the property of lumbrical muscle? Whether lumbricals are present in hand or lumbricals are present in the foot, lumbricals are called as tendon to tendon muscle. They originate on tendon and they insert on tendon. That's the property of lumbrical. Whether hand or foot, lumbrical are tendon to tendon muscle. In the hand, they originate from the tendon of flexor digitorum profundus and they insert on the extensor digitorum tendon here. So flexor digitorum profundus se start hoga or extensor digitorum pe insert hoga. Now people often ask me, sir, we do get confused between the lumbricals and in between the interossei. Nahi yaar, chance hi nahi hai. You cannot get confused with the lumbricals and interossei. Lumbricals are originating from tendons. Unless you're looking at tendons, you cannot see lumbricals. And interossei from the bones. Unless you're looking at the metacarpals, how will you identify interossei? So lumbricals and interossei mein confusion hone ka chance hi nahi. There is no chance. Okay. 4 lumbricals are there. The first 2 lumbricals that you can see, this is first one, this is second one. These are unipinnate lumbricals. They're toward this side, lateral side. They're supplied by median nerve. The first and second unipinnate supplied by. Third and fourth lumbrical are bipinnate lumbricals and they are supplied by the ulnar nerves. So lumbricals are divided. Lumbricals are divided in median nerve and ulnar nerve. 2-2. बेटा इसका अंगूठा देना नहीं कहते, इसका अंगूठा दिखाना कहते हैं. Okay, chalo. Interossei, guys. Palmar interossei and dorsal interossei. Now, palmar interossei, all palmar interossei are unipinnate. All dorsal interossei bipinnate, guys. Palmar interossei, I know, I'm sure you all know the rule pad and dab. Palmar interossei for adduction and dorsal interossei is abduction of fingers. Adduction karna is the palmar interossei, abduction karna dorsal interossei. Now, first of all, look at the palmar interossei. Palmar interossei are the one which are for adduction, and whether it is hand or it is foot, for the interossei muscles are supplied by the dominant nerve. The dominant nerve in hand is ulnar nerve. Similarly, dominant nerve in the foot is a lateral plantar nerve, and all interossei are supplied by the dominant nerve. Whether they're unipinnate, they're bipinnate, doesn't matter. So they're all supplied by the ulnar nerve. Okay. Now, middle finger is the one which is the principal digit. When we talk about the adduction and abduction in hand, middle finger is a main finger here. So middle finger is a principal digit there, as you can see. So as you can see, palmar interossei job is adduction. So they are all pulling the fingers toward the middle finger. So the one finger which is not having a palmar interossei is middle only. When you do adduction, we are coming close to middle finger. We are not moving middle finger here. So we need palmar interossei for these 4 fingers, but not for the middle finger. So guys, it's the middle finger which is devoid of the palmar interossei. They're unipinnate, and middle finger is devoid of palmar interossei, absent on the middle finger. thumb may not have palmar interosseum. Thumb वाला palmar interosseum, it may be or may not be present because thumb को palmar interosseum का जरूरत नहीं है guys. Palmar interosseum is for adduction. We already have a muscle called as an adductor pollicis. And that's why we don't need a palmar interosseum for the thumb. So it may be present or it may not be present. So it's a variation which is very much possible, guys. Thumb palmar interosseum may not be present. And yes, right, the test which is done for the palmar interosseum is called as a card test. I always say that the picture given for the card test, most of the pictures are incorrect here. This is also not a correct image. Card test is done from the corresponding fingers here. If you're doing the card test between this middle finger and the index finger, then obviously you need to pull it from these two fingers only. अभी ऐसे thumb से खींचेंगे तो card निकल ही आएगा ना यार, फिर तो no matter who is holding the card. So card test is done. You should also be holding the card with the corresponding fingers only. ऐसे thumb से नहीं पकड़ के खींच लेना उसको. Dorsal interosseum, all dorsal interosseum are for abduction, all dorsal interosseum for abduction. Now look at this. First of all dorsal interosseum are bipinnate. If you look at the first, second, third, fourth, all are bipinnate. I don't need a dorsal interosseum for thumb. I don't need a dorsal interosseum for little finger because my thumb and little finger is already having thinars and hypothinars and they are causing abduction. So we have a muscle called as abductor pollicis. We have an abductor digiti minimi. So obviously they don't need it. So इनको अलग कर देते हैं. So now we have 4 dorsal interosseum attached to 3 fingers. The first one goes to index, the last one goes to ring, and the remaining 2 goes to middle finger. Now the middle finger, which was devoid of palmar interosseum, is having double dorsal interosseum. Palmar interosseum एक भी नहीं है, but dorsal interosseum are 2 in number. So they are bipinnate, number 1. And we said absent on thumb and little finger. There is no palmar dorsal interosseum on thumb and little finger. And middle finger is having second and third. Double dorsal interosseum is present on the middle finger. And yes, the test which is done for the dorsal interosseum is what? It is an Igawa test, guys. You ask the patient to place the hand on the plane surface and you just ask him to move the middle finger in both the directions. That test is called as an Igawa test. Look at this here. That test is called as Igawa test. The test is called as Igawa test. नहीं बेटा, ऊपर वाले ने कुछ दिल खोल के नहीं दिया हुआ. The middle finger is having a double dorsal interosseum is not to show the middle finger to the world. It is actually the only muscle which is going to the middle finger is dorsal interosseum only. So middle finger need to move in both the direction, and that is radial deviation and ulnar deviation, and that is done by the dorsal interosseum. Palmar interosseum है नहीं. So whatever movement you do for the middle finger, whether it's toward the lateral side or medial side, that is done by the dorsal interosseum only. चलो. So I hope you understood this hand thing, guys. Thenar muscles, hypothenars, the lumbricals, the palmar interosseum, and the dorsal interosseum. But see, that's what I told you. You asking, what's you asked me the same question which I was trying to clarify you. You will not be seeing the interosseum and the lumbricals together. Lumbricals are coming from the tendon. So when the tendons are intact, you will not be able to see interosseum. And once you remove the tendon, lumbricals are gone. So only interosseum are visible here. So there is no a good quality specimen. अगर छोड़ दो अलग बात है, but there is no. I don't think they will give you a picture or that's a specimen in which the lumbricals and palmar and the dorsal interosseum are present together, and you have to differentiate between them because you have to remove the tendon to see the interosseum muscle. Okay. चलो guys, 30 seconds break. तब तक मैं आपके मैसेज देखता हूँ क्या क्या लिख रहे हो. Okay. Break over. Chali sir. Next, moving on to the clavipectoral fascia. Again, a question which is asked repeatedly in the exam. How do I stay motivated? Look, everything is there in front of me to stay motivated. You people are there to keep me motivated all the time. What is there not to be motivated here? Tell me one thing which is not there to be motivated here. I am living dream life. ना I don't set any NEET PG exam or something. ये सब मत बोलो यार please. ऐसा कुछ नहीं. चलो come back guys. Clavipectoral fascia. देखो, clavipectoral fascia, the reason we call it a clavipectoral fascia because it is extending from the clavicle and it is covering the pectoral muscle. The two muscles which are enclosed in the clavipectoral fascia, one is the subclavius muscle, which is just below the clavicle, and the next muscle which is present coming from third, fourth, and fifth rib, that is the pectoralis minor muscle. So subclavius and pectoralis minor muscle, these are the two muscles which are enclosed in the clavipectoral fascia. The main question asked on the clavipectoral fascia is that what structures are piercing it. And structures piercing clavipectoral fascia में we have one vein, one artery, one nerve, one lymphatic. सब कुछ one. It's all one. Vein you can already see, guys. Look at the vein coming from the lateral side. That's a cephalic vein there. Artery is thoracoacromial artery. Nerve is lateral pectoral nerve which comes out to supply pectoralis major, and some lymphatics which drains into the apical lymph node are also there. So structure piercing clavipectoral fascia, cephalic vein going inside, lateral pectoral nerve comes outside. If I just go with that, lateral pectoral nerve बाहर आएगा to supply pectoralis major. Thoracoacromial artery will also come outside, piercing it and supplying the structures. And the two structures will go inside, that is cephalic vein will go in, and the lymphatics will also go in here. So there are four structures which are piercing the clavipectoral fascia, two to come out and two to go in. Thank you, guys. Thank you. I know that I have also put an effort in making all these slides and everything, but definitely it needs some more effort from your side because it's you who need to put in a brain right now. You need to remember the stuff. You need to kind of understand everything. And even despite after the class, I'll go back and I can relax after that here. But obviously, you need to go back and again read this thing. You have to solve some questions from here and there. So I know it's more of your hard work in this here. But if I can be of any help, like if you're finding this presentation or this, this discussion fruitful, nothing will make me more happy. Chalo. And the one more thing about the clavipectoral fascia, that beyond the pectoralis minor muscle, it is extending as a ligament called a suspensory ligament of axilla, guys. When you touch your floor of axilla, you see there's a depression over there. It's not flat. The reason it is not flat, it is slightly dome-shaped because the suspensory ligament of axilla is pulling it. The suspensory ligament of axilla is pulling it, and that is an extension of the clavipectoral fascia only. A little about brachial plexus and the injuries also. Now, what you're looking at right now, guys, it's a brachial plexus. We all know that brachial plexus is formed by the ventral primary rami of C5, C6, C7, C8, and T1. They are all forming the brachial plexus, C5 to T1. C5 and C6 root, look at that C5 and C6, roots of the brachial plexus comes out between scalenus anterior and scalenus medius, which we will see in the head and neck part. So, bhulna nahi isko. Anterior and scalenus medius. So, C5, C6 is forming the upper trunk, C7 forming the middle trunk, and C8 and T1 together forming the lower trunk, the three trunks of the brachial plexus. And after the trunk, if you see, go further, you can see upper trunk is giving a contribution toward the middle side. Lower trunk is also giving contribution to middle side, but middle one is returning the favor only to the upper one, and this is called the division part of the brachial plexus, and the only part of the brachial plexus which will not give any branches. I mean, they are branching with each other, but it is not giving any branches as such. I mean, there is no nerve coming out from the division part which is supplying any skin or muscle or anything like that here. And that was an INICT question, guys, that which portion of brachial plexus gives no branches, that is a division part. And then finally, we have a cords of the brachial plexus, and the nomenclature of the cords of brachial plexus is based on axillary artery. Lateral to axillary artery, lateral cord; posterior to axillary artery, posterior cord; medial to axillary artery, medial cord of brachial plexus. So the brachial plexus cords will be seen there. I can be very, very sure about that they will not be asking you that identify the branches of brachial plexus. Not happening, guys. And not happening at least in the next 5-10 years, I can tell you, unless they start giving very high definition images, जो नहीं होने वाला है. But what they can ask you in image-based question in brachial plexus, although this is still a little extreme question to be asked, but still they can ask you how this brachial plexus is ending. Lateral cord, posterior cord, medial cord ka terminal branch they can ask you in the image-based question. So that ways, if you look at this, the lateral cord branch, which looks like a continuation of the lateral cord, is a musculocutaneous nerve. That is a musculocutaneous nerve. Posterior cord will continue as the radial nerve, and medial cord will continue as the ulnar nerve. And then lateral cord and medial cord both together will give rise to the median nerve. Median nerve is formed by both lateral cord as well as medial cord. We have a lateral root of median nerve and we got a medial root of median nerve also. I'm going to have good time like reading all your comments after the class. But as I said, now right now we need to stay on track. So guys, this is just a formation of the brachial plexus. The division gives no branches, and if you ask me personally, my suggestion is that look at the terminal part of the brachial plexus and try to identify these nerves: musculocutaneous, radial nerve, median nerve, and ulnar nerve. The two injuries of the brachial plexus, the one which is affecting the upper trunk and the one which is affecting the lower trunk, the Erb's palsy and the Klumpke's palsy, we all know that. Now in the Erb's palsy, the injuries to the upper trunk, so obviously the root value which is affected in the Erb's palsy is C5 and C6 because upper trunk is formed by C5 and C6 here. Upper trunk root value is C5 and C6. And C5 and C6 is a major component of the axillary nerve which is supplying deltoid muscle and musculocutaneous nerve supplying the biceps and brachialis and coracobrachialis. But if I just take the important one, axillary nerve that is supplying deltoid, musculocutaneous nerve supplying biceps. Let's just take the important one. Agar aapka deltoid is gone, guys, deltoid is gone, so your shoulder will come into adducted position. And if your bicep muscle is not working, your elbow will come into extended position. And I hope you know that bicep is a very strong supinator also. Bicep is also for the supination also, guys. Supination movement is by the bicep brachii. Agar bicep nahi kaam karega, to your forearm will go into pronated position as well. So your arm is adducted, your elbow is extended, and obviously your forearm is pronated like this, and you know that is called as a policeman's tip hand. Adducted shoulder, extended elbow, pronated forearm, and that is called as a policeman's tip hand. That is a policeman's tip hand. Policeman's tip hand or porter's tip hand or waiter's tip hand, various names are given to that. About the Klumpke's palsy, which is more of a stretch injury, guys. Hyperabduction or hyperextension can lead to that. In the Klumpke's palsy, the injury is to the lower trunk of the brachial plexus, and this time the root value affected is the C8 and T1. Klumpke's palsy mein root value is affected C8 and T1, lower trunk hai. And C8 and T1 is a major root value. It's a major root value for the ulnar nerve also and for median nerve also, which are supplying the intrinsic muscles of hand. So basically, I can say hand muscles are supplied by the C8 and T1. Mainly by ulnar nerve, but some of them are median nerve only. But the intrinsic muscle of hand innervation come from C8 and T1. And if the intrinsic muscle of hand are gone, what will happen, guys? The one common function of intrinsic muscle of hand is what? They cause flexion at metacarpophalangeal joint and extension at interphalangeal joint. Flexion at MCP and extension at IP joint. If this function is not working, then there will be extension at the metacarpophalangeal joint and flexion at the interphalangeal joint, and everyone knows that is what? The claw hand. So there will be hyperextension at metacarpophalangeal and there is a flexion at the interphalangeal joint, and that is nothing but the claw hand. Look at the MCP joint, guys. Sorry. Look at the metacarpophalangeal joint over there. That is showing the hyperextension. It's not only extended, it's hyperextended. And look at the interphalangeal joint in this case, they are flexed. The flexion. That is the claw hand here. That is the claw hand. Horner syndrome can also be there in the Klumpke's palsy because the injury is to C8 and T1 is a sympathetic nerve. T1 is the first sympathetic nerve. So Horner syndrome ho bhi sakta hai, nahi bhi. Horner syndrome is like something which is not always seen, but claw hand. If you have to choose between the claw hand and Horner syndrome, which was actually an INICT question, they gave both in the option, but you have to choose one out of the two. Claw hand is your best answer, no doubt about that. Horner syndrome may be seen if the sympathetic root value is also affected. Chali. Moving on to the three major nerves and their injuries to wrap up this upper limb part, guys. Radial nerve, ulnar nerve, and median nerve. So first, the radial nerve. Look, I want all of you to look at the screen here and just look at this little animation there. See, radial nerve, guys, it starts from the axilla. It goes behind the spiral groove, comes in front of the lateral epicondyle, and then it divides into two branches. One is called as a posterior interosseous nerve because running behind the interosseous membrane. And then there is a superficial branch of radial nerve, which is a cutaneous nerve. That is a radial nerve. It is running behind the spiral groove and then coming in front of the lateral epicondyle, dividing into two branches. Posterior interosseous nerve, which is purely a motor nerve, and superficial branch, which is a purely the sensory branch. Radial nerve supplies the triceps in the axilla. Radial nerve supplies triceps in the spiral groove. Radial nerve supplies one wrist extensor called as ECRL, extensor carpi radialis longus, above lateral epicondyle. Dekho, most of the wrist extensors are supplied by posterior interosseous nerve, but there is one major wrist extensor, that is ECRL, is supplied by the main radial nerve only, and that too above the elbow only. So that is remember that is one of the wrist extensor. Then the posterior interosseous nerve will supply remaining all extensors. Whatever extensors are there, again names are not important, function is important, guys. Extensors of the fingers, extensor digitorum, extensor digiti minimi, extensor pollicis longus, pollicis brevis, jo bhi hai, all extensors are supplied by the posterior interosseous nerve. And superficial branch, obviously the name says superficial branch, it is a cutaneous nerve supplying the skin on the lateral 3.5 of the dorsum of the hand. Lateral 3.5 of the dorsum of the hand. Radial nerve injury could take place in the axilla, that is a crutch palsy. In the spiral groove, that is a Saturday night palsy. in front of the lateral epicondyle, could be because of the lateral epicondylar fracture, though it's not the most commonly involved of the lateral epicondylar fracture, but yeah, it can be involved in the lateral epicondylar fracture also. And the posterior introtious nerve, which can be involved sometime because of the radial head fracture also. But again, there could be various reasons for that. So the four common site for radial nerve injury, guys. If the radial nerve is injured as high as this point, this point here, that is in the axilla, the crutch palsy, then everything supplied by radial nerve is gone. That means all the extensors are gone. That means every joint will come into flex position. Tricep is gone, elbow is flexed, wrist is flexed, fingers are flexed, and sensory loss is there. Look at me, guys. So flexed elbow, wrist drop, finger drop, and sensory loss is also there because superficial branch is involved. That is in case of the crutch palsy. Flexed elbow, basically every joint is flexed because all extensors are supplied by radial nerve only. So सारे joint flex हो जाएंगे यहाँ पे. Flexed elbow, wrist drop, finger drop, and then we have sensory loss. But if radial nerve is injured at point B, then some part of tricep will be spared. Tricep is not completely involved now. Some part of tricep will be spared, and because of that, what will happen? Now, there is a weakness in elbow extension. There will be weakness in elbow extension, and rest everything is still the same. We still have wrist drop, we still have finger drop, we still have sensory loss, but there is this weakness in the extension of elbow. If the nerve is injured in front of lateral epicondyle, then tricep is perfectly all right. So tricep is perfectly all right. So Zindabad, elbow is fine. ECRL is also spared, and guys, ECRL is one of the wrist extensor. If one of your wrist extensor is spared, you will not have a wrist drop. Weakness hoga, definitely weakness will be there, but wrist drop is not there because ECRL is still working. But rest everything will be seen. That means finger drop will be there and sensory loss will be there. So no wrist drop this time, but finger drop and sensory loss is seen. Finger drop and sensory loss. And if posterior introsious nerve is involved, then in this case, sensory loss bhi nahi hoga because sensory branch will be spared. If the injury is to this posterior introsious nerve, then only finger drop will be seen and nothing. No sensory loss on the dorsum of hand because superficial branch is spared. That's the radial nerve injury and the level of the radial nerve injury and what will happen here. And again, it's, because as a traditional question, guys, they can ask you a question by just formulating anything new. They'll ask you, okay, the nerve is injured at this point, nerve is injured at that point here. So knowing that what major muscles are supplied by radial nerve and what is their function, more than the name of the muscle, the function is important. For you people, it's not extensor carpi radialis longus, extensor carpi radialis brevis. Usse zyada important ye hai ki you should know that the muscle says extensor carpi. It's a extensor of the wrist. The action is more important. The patient will not come to you saying that my tricep ka long head is not working. वो तो simply कहेगा, obviously my tricep is not, like I'm not able to extend my elbow. No patient is going to complain of an individual muscle that I'm not able to use my flexor carpi ulnaris, so that's I'm not able to do the ulnar deviation. So you have to look at the clinical question based on that ability and inability of the movement here. So remember the muscle and their action in a group rather than remembering the individual name of the muscle. That will not serve you much. Chali sir, moving on to the next one, that is median nerve. Guys, median nerve root value is C5 to T1. Again, just like radial nerve, the root value is C5 to T1. So median nerve, it starts in the axilla by lateral root and medial root, but median nerve doesn't supply anything in the axilla and anything in the arm. Nothing is supplied by median nerve in axilla and arm. So median nerve, guys, if this is a median nerve coming down, as you can see, it is one of the most medial content of cubital fossa. And after crossing the cubital fossa, you can see it runs in the forearm and then it passes deep to the flexor retinaculum. That's a flexor retinaculum, the green one over there, and the nerve is passing deep to it. That's why it is involved in carpal tunnel syndrome also. Let me start from the distal end, guys. The median nerve in the hand, when we discuss the thenar and hypothenar muscle, median nerve was supplying the thenar muscles except adductor pollicis. It was supplying the thenar muscle except adductor pollicis, and this was also supplying the lateral two lumbricals, the first and second lumbric. That's exactly the thing. Thenars and lateral two lumbricals except adductor pollicis, which is supplied by ulnar nerve. Then this median nerve, before the median nerve passes deep to the flexor retinaculum, there is a nerve which passes superficial to the flexor retinaculum, and that is called as the palmar cutaneous branch of the median nerve, guys. Palmar cutaneous branch. In fact, the speciality of this nerve is this is the only branch of the median nerve passing superficial to the retinaculum. That's why when there is a carpal tunnel syndrome and the nerve is compressed at this point here, then obviously everything supplied by the median nerve in the hand will be gone. But the palmar cutaneous branch will be spared. And that's why in the carpal tunnel syndrome, patient may not have a sensory loss on the palm. Finger pe to hoga, but on the palm you may not have a sensory loss because palmar cutaneous branch is not passing deep to the retinaculum, it is superficial. Let's go further above. Median nerve is the main nerve of the forearm, And one nerve, it is not possible for one nerve to supply everything, guys. Median nerve is supplying the superficial plexus, and there is a branch of the median nerve called as anterior interosseous nerve, which is supplying the deep muscles. Posterior interosseous nerve was the branch of the radial nerve. It was a continuation of radial nerve. Anterior interosseous nerve is the branch of median nerve, which is supplying some of the deep muscles. So the main median nerve job is to supply what? Superficial plexus, like flexor digitorum superficialis, flexor carpi radialis, pronator teres. Don't have to write every name. Flexor digitorum superficialis is good enough. Anterior interosseous nerve will supply the deep muscle, and the two very important deep muscle, guys. One is flexor digitorum profundus, lateral half, flexor digitorum profundus, lateral half, and also flexor pollicis longus, FPL, flexor pollicis longus here. And I'll tell you what is the specialty, guys. Flexor digitorum profundus is for the distal interphalangeal joint flexion. That's the only muscle reaching the distal interphalangeal joint. If you want to do the distal interphalangeal joint flexion, that is done by FDP, flexor digitorum profundus. And same for the thumb also. Interphalangeal joint of the thumb is flexed by the flexor pollicis longus. Flexor pollicis longus. That's the important. Anterior interosseous nerve now काम नहीं करेगा, so you will not be able to flex this distal interphalangeal joint, and you cannot flex the distal interphalangeal joint of thumb also. That's more important, right? Well, one shot is a program, guys, where I have to tell that what not to study, of course. I mean, if I keep telling you this to study, that to study, wo to obviously anyone can do that here, but I need to tell you certain topic which, and I do feel responsible about it when I say, okay, you can leave that part. I'm not the creator of paper or anything like that. Obviously, there could be something which I say, don't read that, and they might create a question from there. My motive here is to tell you that what is the proportion of time you need to invest for which the returns are good. If let's say you are spending 5 hours on one topic and you're spending 1 hour on another topic here, and if I say that chances of getting a question more from that 1 hour topic here, then I would say chuck that 5 hour wala. Leave that part here. Why to do that? In fact, my main motive of this one shot today is I thought I'll give it a name also, give it a theme or some name only, and the question is, why would I do that? Like, the things are not required, why would I do that here? And you probably will find some of the meme in between that which says that why would I do that? Okay. Yes, but a pronator quadratus also. But I did not write the pronator quadratus because that is not required. Again, my point is to tell you the just major muscles only. Look, median nerve can get injured here at the cubital fossa level. That is higher injury. Median nerve can get injured at the carpal tunnel, the carpal tunnel syndrome. And there could be the direct trauma to anterior interosseous nerve. Remember, supracondylar fracture, anterior interosseous nerve can get involved. So let's talk about the 3 level of median nerve injury. If median nerve is injured here, that means everything supplied by median nerve is gone. Especially thenar muscles are gone. Doesn't matter injuries here or the injuries here. Thenar muscle dono mein jayega. So there will be ape thumb deformity. Now, along with ape thumb deformity, what will happen? Because FDS, now guys, please look at the screen here. Because the injury is here, so FDS is not working, and FDP lateral half is also not working. So I cannot flex these two fingers at all. Neither FDS nor FDP of the lateral side is working, so no chance I can flex these two fingers. In some people, they can flex middle finger, but index finger to definitely nahi hoga. So when you ask these patients to make a fist, they will make a fist like this, that is called as a pointing index finger, or they will make a fist like this, just by flexing these two fingers, and that is called as hand of benediction. That depends from person to person. Some people will have a pointing index finger, and some people will have a hand of benediction while making fist. Ye nahi bhulna beta. While making fist, the patient will not come to you with a pointing index finger leke aa raha hai aise aapke maan mein. He's just having ape thumb deformity only. The moment you ask the patient to make a fist, then only you will see a pointing index finger or hand of benediction, and that's the indication of higher injury here. So there is ape thumb deformity and there is a hand of benediction, like see, it's a hand of benediction over there. If only index finger is like, we call it like pointing index finger. That is the higher injury. If the injury is lower at the carpal tunnel, then obviously there is no hand of benediction because FDS is working, FDP is working. So when you ask the patient to flex the finger, wo kar lega. He will be able to make a fist. So ape thumb deformity will be there, but there is no hand of benediction. But what will you see? The palmar cutaneous branch is spared, and because of that, there is no sensory loss on the palm. The sensory loss on the palm will not be there. So ape thumb deformity is there, but there is no sensory loss on the palm. Sensory loss will be seen on the fingers, but palm pe nahi hoga, and that is just an indication of it's a carpal tunnel syndrome. Obviously you do so many tests and everything for carpal tunnel syndrome, Tinel sign and Fallon's test and all that. It's just about observation I'm talking about. And then coming to anterior interosseous nerve, if anterior interosseous nerve is injured, then what is the case, guys? In the injury to the anterior interosseous nerve, what will happen? The patient will not be able to flex the distal interphalangeal joint of index finger. If I just take the index finger as an example, and the index interphalangeal joint of thumb, so you cannot make a circular OK like this. Or these patients have a difficulty in picking up the object. Like if you just leave a button on the table and you ask them to pick up a button pick करने के लिए obviously you have to flex these joints like this, and the patient is not able to flex this. That's the positive OK sign. You ask them to make a OK like this, the weak OK sign here. Look at this. That's a positive OK sign. If you look at that hand on the other side here, that is circular OK. Perfect. But if my anterior interosseous nerve is injured, I will not be able to make a OK sign. So my OK will be more like a flattened or oval OK like this here. That is a weak OK sign. It's an indication of anterior interosseous nerve injury. First year वापस नहीं जाना है, first year को यहाँ पर लेके आना है, and we have to nail down that first year in these couple of hours only. Chalo guys, coming to the last thing, that is ulnar nerve. I mean last thing in the upper limb, that is ulnar nerve. Ulnar nerve root value is C7, C8 and T1. C7, C8 and T1. Guys, ulnar nerve is the one which passes behind medial epicondyle. It runs on the medial side and then it passes superficial to the flexor retinaculum. Look at the ulnar nerve. It is passing behind the medial epicondyle and then it passes like superficial to the flexor retinaculum only. Now it passes through a canal here and it passes through a canal here also. The flexor carpi ulnaris is the muscle between the two heads of flexor carpi ulnaris. It is passing and that is called as a cubital tunnel. Between the heads of the flexor carpi ulnaris muscle, that tunnel is called as a cubital tunnel. So compression of the ulnar nerve in this tunnel is called as a cubital tunnel syndrome, and compression of the ulnar nerve here in this Guyon's canal is called as a Guyon's canal syndrome. Higher injury, lower injury. Ulnar nerve obviously supplies flexor carpi ulnaris. That is a muscle it is passing through. Guys, एक गलती नहीं करना. Cubital fossa syndrome. Cubital fossa syndrome is a median nerve injury because it is a content of cubital fossa. Cubital tunnel syndrome, it's the ulnar nerve palsy. So ulnar nerve is cubital tunnel, median nerve is cubital fossa. So it passes through flexor carpi ulnaris, and in the forearm, apart from flexor carpi ulnaris, there is only half muscle left there to be supplied by this nerve, and that is flexor digitorum profundus, medial half. It supplies the medial half of flexor digitorum profundus there. Okay. So, we're going in the reverse manner here. So, there's a branch of the ulnar nerve which goes inside after crossing the Guyon's canal. That is called as a deep branch. That's a main branch here. And there is a superficial branch also. A small superficial branch is there. So, as I said, flexor digitorum profundus, medial half of flexor digitorum profundus is supplied by the ulnar nerve in the forearm. So, only 1.5. Flexor carpi ulnaris is 1.5 of FDP. Only 1.5 muscle are supplied by the ulnar nerve in forearm. और हैंड में तो इसने ऑब्वियसली तबाही मचाई हुई. हैंड में तो ऑलमोस्ट एवरी मसल इज सप्लाइड बाय अल्नर नर्व ओनली. ऑल हाइपोथेनार्स, ऑल इंटरोशियाई, two lumbricals also, even one palmar one adductor pollicis also. So ulnar nerve deep branch, guys, this deep branch over there, it is supplying most of the muscle. It supplies hypothenars, it supplies interossei, it supplies third and fourth lumbrical, and it even supplies one thenar muscle also, and that is the last muscle, that is the adductor pollicis. That is adductor pollicis. I told you it is also called as a graveyard of the ulnar nerve. Now, ulnar nerve injury can be higher, ulnar nerve injury can be lower. It can be a, as I said, cubital tunnel syndrome, it can be a Guyon's canal syndrome. Whether it's a higher injury or lower injury of the ulnar nerve, guys, the point is ulnar claw hand to hoga. Because intrinsic muscle of hand are involved, so obviously claw hand will be there, ulnar claw hand will be there. The only thing is that if the injury is lower, like in Guyon's canal syndrome, you have a we have more prominent claw hand in this case. But if the injury is higher, you have a less prominent claw hand, and that is called as the ulnar paradox. And the one which is responsible for this ulnar paradox is the flexor digitorum profundus muscle. This muscle is the one which is responsible for that. Because if the injury is lower, here, then what will happen? FDP will be working. You already have a claw hand because the injury is lower, and your FDP is working. Working FDP means it will flex the distal interphalangeal joint even more. That causes more flexion, and that's a very severe claw hand. But if the injury is higher, then FDP is also gone. So claw hand is there, but distal interphalangeal joint cannot be flexed, so it looks like a less severe claw hand in that case. So that is called as the ulnar paradox, and the muscle responsible for that is a flexor digitorum profundus. Everyone knows the ulnar paradox here, but if you ask which muscle is responsible for the ulnar paradox, it's the flexor digitorum profundus. It's a flexor digitorum profundus. So guys, this is about the upper limb part. The histology shots is coming. Give me 30 seconds. I need to use this throat after today also. So I'll give you a break after the lower limb only. I hope that you don't mind that. Chalo guys. The break is over. Lymph node, spleen, palate and tonsil, thymus. Histologically, some important differences, guys. Lymph node is something which you can divide into cortex and medulla. I'll show you the slide after that. I'm just tell you a basic difference first. Lymph node can be divided into cortex and medulla. Thymus can also be divided into cortex and medulla, but medulla is like common medulla is there. We have like a common cortex is there, and then we have the medulla in between. Spleen के अंदर there is no cortex medulla, no differentiation. When you look at the section of the spleen, there is no cortex, there is no medulla, सब कुछ mix है आपस में. That there is no cortex and differentiated cortex medulla is there. And palatine tonsil, it is differentiated basically by on the basis of stratified squamous epithelium. One of the main feature will be the lining surface पे. Again, no cortex medulla there. It's a stratified squamous epithelium that you will see on the surface. Lymphatic nodules are present where? Lymphatic nodules are present in the lymph node. We have lymphatic nodules there in the cortex part. Spleen में we have lymphatic nodule, and the speciality of the lymphatic nodule in spleen that they have an artery inside. Splenic artery उसके अंदर मिलेगा आपको. You have a splenic arteriole inside. Palatine tonsil में lymphatic nodules are present, and again I said by looking at the stratified squamous epithelium you can identify them. और thymus में तो lymphatic nodule होता ही नहीं है. There is no lymphatic nodule as such in this. Subcapsular sinus, there is something called as a subcapsular sinus which is present. I'll show you where the subcapsular and subtrabecular sinus are. I'll show you in the picture, guys. That is there in the lymph node. Spleen ka one of the main features of spleen is a red pulp and white pulp. We have a red pulp and the white pulp, which is an indication of closed circulation and open circulation in the spleen. And palatine tonsil mein tonsillar crypt. You may be able to appreciate the tonsillar crypt in that. You will see the stratified squamous epithelium dipping inside, forming the tonsillar crypt in that case. And thymus ke andar we have in the medulla part we have Hassel's corpuscles or thymic corpuscles. Okay, let me show you the slide for the lymph node, spleen and palatine tonsil because they all have lymphatic nodules, so you should be able to differentiate them with each other easily. Guys, this is a picture of a lymph node right now. Now, why I'm saying it's a picture of a lymph node? First of all, you can divide it into the cortex and medulla. See, outer part there is a cortex here, and the inner part is medulla. And look at the lymphatic nodule are present only in the outer part. Bahar wale part present, that is a cortex. They are present. Isolated lymphatic nodules are present only in the cortex. You can see capsule there, and the space that you see deep to the capsule and trabeculae, this is called a subcapsular and subtrabecular sinus. Look at that space here, and that's a very unique feature of the lymph node. They have a sinus or space deep to them called a subcapsular or subtrabecular sinus. Subcapsular or subtrabecular sinus. Then we have what do you say? Just like capsule, we have a trabeculae also, guys. That is a trabeculae is also present. Okay. And lymphatic nodule, which is mainly having the B lymphocytes. The lymphatic nodules have B lymphocyte. But a T lymphocyte, you're asking, T lymphocytes are present mainly in this area, that is paracortex here. The junction between the cortex and medulla, there is a paracortex region. This is some thymus dependent zone we bolte. That's why it is called as thymus dependent zone, because it's a paracortex here. And this is where the T lymphocytes are present. This is also called a thymus dependent zone of the lymph node. Lymph node. So that is a lymph node, guys. Capsule is visible, subcapsular sinus dikh rahe hain. You can see lymphatic nodules without artery present only in the cortex part. That is the lymph node. When you look at this picture here, you can first of all you can clearly make out it is a palatine tonsil. Well, guys, lymphatic nodule is there. You can see those lymphatic nodule there. Lymphatic nodule is there. But the main thing is one is that's the tonsillar crypt. The big crypt can be seen over there. And major point is the stratified squamous epithelium. That's no capsule there. That's a stratified squamous epithelium. In fact, I believe that when they give the question, when they give the picture of this, the palatine tonsil, they will show you a more magnified picture. So you may not be able to see the tonsillar crypt, but you should be able to see the stratified squamous epithelium here. Because otherwise, there are other slides you can confuse it with here. So I feel that if the palatine tonsil is asked as an image-based question, they need to magnify more toward the stratified squamous epithelium just to confirm you're looking at lymphatic nodule, you're looking at stratified epithelium. ठीक है यार, this is what? This lymph node. This is palatine tonsil, I'm sorry. And spleen. Look at this. First of all, it's a low magnification picture. You can see lymphatic nodules, and these lymphatic nodules are present everywhere, guys. There is no differentiated cortex and medulla. I cannot differentiate cortex and medulla. You can see the lymphatic nodules are present everywhere. That is what is there in the spleen here. And if I just magnify a picture toward one lymphatic nodule, you also see the blood vessels inside. The blood vessels are seen inside. As you can see, this is a lymphatic nodule there. There's a lymphatic nodule. Look at those arteries, guys. You can clearly see one artery inside that. You can see one artery over there. You can see the artery here also. These are all splenic arteriole. And that's a unique feature of the spleen, that the arterioles are passing through the lymphatic nodule. There is no arteriole in the palatine tonsil, there is no arteriole in the lymph node, but in spleen there are arterioles which are present in the lymphatic nodule, which is a feature of that. Lymphatic nodule is having WBC, so this is called as the having all those lymphocytes and white blood cells are there. So this is a white pulp. And when these arteries they come out, they splay their blood into parenchyma. So you can see all this red tinge over there. It's because the RBC is present over there, and that is called as a red pulp, guys. That's the red pulp and the. So that's a slide of a spleen here. That's a white pulp over there. Lymphatic nodule is a white pulp only, and that red tinge in between here, where the RBCs can be seen, that is the red pulp. And as I said, the main thing is in the lymphatic nodule, you will see what? Eccentrically placed splenic arterioles. Splenic arterioles are present in them. Chali sir, so that was about the how to differentiate between the lymph node with the palatine tonsil and the spleen. If I just very quickly recap that part here, if you're looking at the lymphatic nodules present in the cortex, only in the cortex, and you can see subcapsular or subtrabecular sinus, lymph node. If you're looking at the lymphatic nodule, and along with that you can see stratified squamous epithelium, palatine tonsil. If you can see lymphatic nodule present everywhere, no differentiation, and you can see artery inside, spleen. Thus, if you just remember this much also, you still will be able to identify these slides here. And what I've seen from guys from last 4 or 5 years, they do not ask you any detail about the slide, they just ask you to identify. Like they are also fed up with us, like the kind of histology we read in first year. Now examiner just say, okay, bas, bhai, identify kar do ki kaun si slide diye, but that's all we want from you here. So no detail or nothing is asked. Okay, sir, that takes us to our next unit, and that is lower limb. चलो जल्दी से lower limb को खत्म करते हैं, then we'll take a break after that. Okay, so guys, to start with the lower limb, I'm gonna start with the plexus, that is the lumbar plexus. Let's look at the muscle that is a psoas major and iliacus muscle, and based on that, let's identify the lumbar nerve, because there's some really good clinical question, and it's more like a surgical based question asked on those nerves here. Yeah. Thank you, guys. You stay motivated, and you just better keep me motivated also. I also need a lot of energy to go with this. Okay. Because when you're writing, you're kind of taking a rest in between while writing. But when if it is everything is written over there, I have to speak continuously. Guys, psoas major and iliacus. Now look at the muscle, the psoas major muscle. You can see it's coming from the lumbar vertebrae. The psoas minor is also visible there, but that's a psoas major muscle, and that's a psoas minor muscle present on it. And this muscle is coming from the iliac fossa, that is iliacus. Just focus on these two muscles. Baki sabko bhul jao. So it's psoas major muscle and iliacus, and both psoas major and iliacus, if you look at them, they are converging together to form a common tendon called as the iliopsoas tendon, which is inserted to the lesser trochanter. Inserted to the lesser trochanter. That's a lesser trochanter. Okay, chalo, keep these two muscles in mind, and let's identify the branches of lumbar plexus. Psoas major muscle is the one which is hiding the lumbar plexus. The entire lumbar plexus is hidden by the psoas major muscle, and I maybe some of the people from that batch is in this what do you say, might be attending this class right now. Just few days back I was taking a class in Hyderabad, and I came to know that I think 2018 or 2019 batch, they had psoas major muscle as a long question in their exam. And I was like taken back, like, what, yeah, long question? I mean, who was that distorted examiner who asked a long question? Psoas major mein kaun long question पूछता है यार? But ठीक है, that was asked. And since that time, this year, all the batches in Hyderabad and Vizag and Vijayawada, I'm naming those batches as psoas major batches only. So I call them psoas major 1, psoas major 2, psoas major 3. So I'm done with psoas major 3 batch till now. After 4 or 5 days, I'm going again for the next batch there. So psoas major, guys. So that reminds me more of this muscle. This muscle is hiding the psoas major muscle is hiding the lumbar plexus. The lumbar plexus all behind that. L1, L2, L3, L4 nerve, वो सब इसके पीछे present है. So for the lumbar plexus nerves to come out, now they have 3 options. Either they will come out from the posterior side of psoas major, or they will pierce the psoas major, or they will come out from medial side of psoas major. Yeah, 18 batch. Yes, that was the 18 batch. Yeah, I hope that some of you are there. Okay. Okay. Now look at, guys. Please look at this picture, because when you look at the final picture, this will be like there's too many things on that. So I want all of you to please focus and look at this picture very carefully, guys. What you're looking at right now, it's a lumbar plexus present on the psoas major muscle and psoas minor. Now look at the nerves, guy, over there. You have multiple nerves. If I start from the topmost nerve, I want for all of you to look at these nerves based on the psoas major muscle. Look at the nerves which are coming out from posterior side or lateral to psoas major. हम फिर देखेंगे nerve piercing it, then we'll see the nerve medial to it here. Just look at the nerves which are lateral to it. This nerve is coming out just below the medial lateral arcuate ligament. Its arcuate ligament is a part of diaphragm only. So it is basically coming out between the 12th rib, and that nerve is a subcostal nerve, the T12. That is subcostal nerve, the T12 nerve. Just below that, we have a nerve, two nerves which is coming from L1. One is iliohypogastric and then ilioinguinal nerve. Iliohypogastric ऊपर वाला है, उसके नीचे वाला ilioinguinal. Iliohypogastric, ilioinguinal nerve. Ilioinguinal nerve is a content of inguinal canal also. Iliohypogastric, ilioinguinal nerve. And then look at the another nerve which is coming out from the inner aspect of this iliacus muscle, from the iliac fossa. That is a lateral cutaneous nerve of the thigh. That is a lateral cutaneous. I'll tell you more about this nerve here. That is a lateral cutaneous nerve of thigh. So guys, focus on the psoas major muscle and look at the three nerves, the four nerves in fact, which are actually present coming out lateral to psoas major. या पीछे से आ रही है, ऊपर से आ रहे हैं, but they're outside or lateral to psoas major. So subcostal nerve, iliohypogastric, ilioinguinal nerve, lateral cutaneous nerve thigh, and you'll identify the lateral cutaneous nerve thigh by looking at the iliac fossa. The nerve is running within the iliac fossa only like this. Then you look at the nerve which is piercing the psoas major muscle and coming out, and that is the genitofemoral nerve, the nerve which pierces and comes out. So sorry, femoral nerve is also there. I forgot to tell you here that look at that nerve which is coming out between psoas major and iliacus. That small nerve over there, not small nerve, actually nerve is big, but you can just see a very small part of that. The nerve present between the iliacus and psoas major, that is a femoral nerve. So all these nerves are present lateral to psoas major. One nerve which is piercing the psoas major and coming out, that is what, guys? Genitofemoral nerve. That is genitofemoral nerve. It is piercing and coming out. And one nerve is medial to the psoas major. Look at my finger over there. That nerve over there is the obturator nerve. The nerve supplying the medial compartment of the thigh, obturator nerve is present medial to it here. So identification of the lumbar plexus is based on this psoas major muscle here. Psoas major batch, if you're there, you at least should be able to identify them all the time. Okay. Subcostal nerve, guys, please stay on this. Subcostal nerve, iliohypogastric nerve, and ilioinguinal nerve. Look at these three nerves here. What makes them so important? Because they are present just behind the kidney. They are forming the posterior relation of the kidney. On the other side, look at that animation, guys. There's a kidney over there. I just pasted the kidney over there. So kidney के पीछे तीन nerve present है. Subcostal, iliohypogastric, and ilioinguinal nerve. So that's why in the renal surgeries, when you approach the kidney from the posterior side, then obviously the three nerves which are vulnerable to injury is subcostal, iliohypogastric, and ilioinguinal nerve. Similarly, genitofemoral nerve, lateral cutaneous nerve of thigh, and femoral nerve. Look at these nerves, guys. Let me point out here. Look at this area here. Actually, I should have pointed out on the other side, but my hand will cut. I'll go out of the frame. Look at these three nerves in this region. On the right side, obviously, the cecum is present there. So these three nerves are forming the cecal bed. The surgeries of the cecum or retrocecal appendix, the nerve which is vulnerable to injury are these three. Look at the cecum over there, guys. I put that. And the nerve vulnerable to injury are what? Genitofemoral nerve, lateral cutaneous nerve of thigh, and the femoral nerve. An obturator nerve, when it runs from the inner aspect, from the pelvic cavity, it is in very close relation to the ovary. So it's in close relation to the ovary here. So you should know that, okay, what nerve can get injured in these surgeries here? Any renal surgery, the subcostal, iliohypogastric, ilioinguinal nerve. Cecal surgeries, the three nerves over there. Again, the nerve in close relation to ovary, that is ovarian carcinoma, can involve the obturator nerve. And if obturator nerve is involved, there will be the issue with the adduction, because obturator nerve supplies all the adductors and also supplies the skin on the inner aspect of the thigh. Last year, I think 22 or 21, there was the question on the psoas abscess also. If you've seen the psoas major muscle, you will not miss the psoas abscess, guys. Psoas abscess, that's a picture of the psoas abscess. You can see the lumbar vertebrae. You can see psoas major muscle. That's a psoas abscess here. It is trickling downward. That's the iliacus muscle here that I'm pointing at. That's the iliacus muscle. That is psoas major muscle. And this psoas major muscle will trickle down and goes downward, and it will reach the lesser trochanter. And lesser trochanter is the point. I mean, if imagine if the abscess will go toward the lesser trochanter, it will accumulate there. It may give a false appearance of the inguinal hernia also. So when you do the differential diagnosis of the inguinal hernia, the psoas abscess also is to be counted in that. Couple of muscles to be involved in that, guys. Couple of muscles to be involved in this. Like couple of important nerves which need to we discuss here. Like what is that nerve, guys? The nerve which is piercing the psoas major muscle, that is genitofemoral nerve. That important nerve is genitofemoral nerve. Ab the next two nerve which I'm going to discuss, guys, they are very, very commonly asked question in the exam, so don't miss out on them. Genitofemoral nerve, which is piercing the psoas major muscle and coming out, it is dividing into two branches. The lateral branch is called as a femoral branch, and the speciality of the femoral branch is that it is supplying the skin over the femoral triangle. You can see the nerve coming out there, and it is supplying the skin over the femoral triangle. Look at the triangle over there, guys. So skin over the femoral triangle is supplied by the femoral branch of genitofemoral nerve. Whereas the branch which is present on the medial side, that's a genital branch of genitofemoral nerve, and the genital branch of genitofemoral nerve, it supplies the cremastric muscle. It supplies the cremastric muscle. And that gives rise to some very important questions. When you test the cremastric reflex, you scratch along the medial aspect of thigh. So you are stimulating the femoral branch of genitofemoral nerve, and the efferent of the cremastric reflex will go from the genital branch of genitofemoral nerve. आप इसको स्टिमुलेट करेंगे, रिस्पॉन्स ऑब्वियसली इस मसल के ऊपर आएगा. सो आई कैन से genitofemoral nerve is the main nerve for the cremastric reflex. Afferent will go from the femoral branch, and efferent will come from the genital branch of genitofemoral nerve. Secondly, because femoral branch of genitofemoral nerve is supplying the skin exactly over the femoral triangle, and this was a last year question again, guys. If you're doing the femoral vein cannulation, abhi femoral vein cannulation mein we have to anesthetize the femoral triangle skin only, and that is supplied by what nerve only? The femoral branch of genitofemoral nerve. So the two very, very important point, that the afferent and efferent limbs of cremastric reflex, that is by the genitofemoral nerve, and the femoral branch of genitofemoral nerve, it is anesthetized in femoral vein cannulation. In femoral vein cannulation. Okay. The next important nerve which I want to show you here, I hope you are identifying this nerve, guys. Look at the nerve which is running within the iliacus muscle and then coming out. That is the lateral cutaneous nerve of thigh. Actually, there are three cutaneous nerves which are supplying the thigh, anterior compartment of thigh. I mean, thigh is supplied like we have a nerve which is present on this side, that is called as the lateral cutaneous nerve. Then we have intermediate, and then we got a medial cutaneous nerve. So intermediate and medial cutaneous nerve of thigh are the branches of femoral nerve. Only lateral cutaneous nerve of thigh is directly coming from the lumbar plexus. And that's the thing, because this nerve is coming directly from lumbar plexus, so you see the nerve is very, very, like when it leaves the, the iliac fossa and enters the thigh, it sometimes pierces the inguinal ligament or passes deep to inguinal ligament, and this is the point where the nerve can get injured also. Extreme flexion, guys. If you go in the lithotic position, there is a flexion of the knee joint, this hip joint here. If you do heavy squatting, if you take very heavy weights on the shoulder and you go for the squatting, then again the lateral cutaneous of thigh can get compressed or injured in that case, and in that case that will lead to the meralgia paresthetica. That will lead to meralgia paresthetica. The compression to the deep to the inguinal ligament, it caused this burning sensation and tingling sensation lateral side of thigh, and that is called as a meralgia paresthetica. That is a meralgia paresthetica toward the lateral aspect of thigh. I wanted to show the lateral aspect of thigh. The Bradley Cooper looks something else only. Like he doesn't look like having a meralgia paresthetica. It is like he's taunting someone. So I love Bradley Cooper, but this picture may not be appropriate for the meralgia paresthetica. Okay, let's move on. So guys, hip bone and femur, just couple of muscle attachment there. If you look at the two circle over there, one is at the ASIS, that is anterior superior iliac spine, and one is at the, okay, let me give you a few seconds to laugh about it, because I know otherwise you will not be in the frame of mind. He's seducing himself. No comments. Yes, 30 seconds break, correct. Don't worry, guys. I'll give you a break of 20 minutes in between when we are done with that, because that 5 minutes wala break mujhe nahi samajh mein aata hai. So 20 minutes break we'll have. So just grab your cup of coffee or tea or something, and then only we'll start exactly in 20 minutes once we're done with this part here. So abhi don't move your ass from there. Okay. So guys, ASIS and AIIS, anterior superior iliac spine. That is the anterior superior iliac spine there, right? And it is giving attachment to two important structures. One is inguinal ligament, and one is sartorius origin, guys. Inguinal ligament and sartorius ka origin is from the ASIS, that is anterior superior iliac spine. And anterior inferior iliac spine, it is giving origin to the rectus femoris muscle. Quadriceps muscle ke four parts, and the rectus femoris is the only portion which is coming from the hip bone, that is from anterior inferior iliac spine. Okay. Sartorius muscle and rectus femoris muscle, they're starting from the hip bone, from the front of the hip bone, one from AIS, one from AIIS, and both will come in front of the hip joint. Dono hip joint ko samne se cross karenge. And that's why both these muscles are responsible. They have a common function, guys. Both these muscles are responsible for the flexion of the hip joint. They will both be responsible for the flexion of the hip joint. Both rectus femoris and sartorius, they will be responsible for the flexion at the hip joint. I know you people are very tempting and interesting people to talk to, but अगर मैंने तुमसे बात करनी शुरू करी ग्रुप के अंदर, तो this session will go till morning only. So I want to finish it on time. So let me focus, guys. Flexion at hip joint, that is done by sartorius and rectus femoris muscle. Okay. If you look at the greater trochanter and lesser trochanter, I'll be able to show you the lesser trochanter better from the posterior side. Greater trochanter, one of the muscle that you can appreciate attached to the greater trochanter, that to the anterior side of the greater trochanter, that muscle will be the gluteus medius muscle. Minimus, I'm sorry. Medius is more toward the lateral side. It's a gluteus minimus more anteriorly placed here. And gluteus minimus muscle is even gluteus medius also, that will show from the posterior side, that is responsible for abduction and internal rotation, guys. Don't forget that. It is for the internal rotation and abduction at the hip joint. Abduction and internal rotation. I am trying very hard. If you turn this entire thing posteriorly, guys, look at this. If you turn this entire thing posteriorly, now I'm looking at the greater trochanter and lesser trochanter. And lesser trochanter is giving attachment to the iliopsoas, and greater trochanter, which is to be appreciated better from this side, although the muscle is attached on the lateral surface, and that is a gluteus medius muscle. That's a gluteus medius. Minimus was more anteriorly placed. And this obviously on the lesser trochanter is the iliopsoas muscle. Gluteus medius muscle, just like gluteus minimus, it is also responsible for abduction and internal rotation. It is for abduction and internal rotation at the hip joint. Whereas, and you know, any fracture of the greater trochanter, guys, obviously that will be a positive Trendelenburg test here. Look at this picture, the radiograph over there. You can see the fracture of the greater trochanter, and the fracture of the greater trochanter, obviously the two muscle will get affected in that. Gluteus medius or gluteus minimus, dono jayega. Gluteus maximus muscle is not attached to the greater trochanter. Don't forget that, guys. Gluteus maximus is attached to this area. Look at that here. That tuberosity is called as a gluteal tuberosity, and this is where the gluteus maximus muscle is inserted. One of the main attachment of gluteus maximus muscle is to the gluteal tuberosity, onto the gluteal tuberosity, and gluteus maximus is a main muscle for extension and external rotation. External rotation. Please don't forget, gluteus minimus and medius hip को internal rotate कराते. They rotate the hip inwards. Okay. And external rotation of hip is done by the gluteus maximus. Other muscles also, but I'm talking about gluteal muscle. It's the gluteus maximus which is for the external rotation and the extension. Whereas the lesser trochanter, it gives insertion to the iliacus and psoas major. Both the muscles will come from the front like this, attached to the lesser trochanter, and they're very, very strong flexor of the hip joint. Look at this picture here, that's a lesser trochanter there. So muscle, iliopsoas muscle will come from the front here, and they will insert on this lesser trochanter, on the posterior side of lesser trochanter, and they are the strong flexors of the hip joint. Both iliopsoas are the strong flexors of the hip joint. That spine that you're looking at over there, guys, if my finger can reach there, yeah, somehow, that is called as the ischial spine. This is the one which is separating the greater sciatic notch and lesser sciatic notch. That spine is called as the ischial spine. And guys, this ischial spine is giving passage to, or there are three structures which are running on the ischial spine. That is the pin structures. P is pudendal nerve. There is internal pudendal artery or vessels, and the nerve to obturator internus. So there are three structures. They are actually going from the greater sciatic notch to lesser sciatic notch. These three pin structures are running on this ischial spine. So pudendal nerve, internal pudendal vessel, and nerve to obturator internus. And they ask this question that the fracture of the ischial spine or injury to the ischial spine, the main nerve which can get injured over there is a pudendal nerve. And guys, what makes pudendal nerve so important? That the nerve supplies the muscles of the perineum. The perineum, we'll be discussing the perineum at the end here. All the muscles in the perineum, guys, bulbospongosus, ischiocavernosus, superficial transverse, deep transverse perineal muscle, external anal sphincter, ये जितनी perineum की muscles हैं, they are supplied by this pudendal nerve. So it is not wrong to say that if there is a fracture of the ischial spine, the pudendal nerve will get involved and there will be paralysis of the muscles of the perineum, because pudendal nerve will get injured in that case. Another picture to tell you something. This is an image which is again shown from the posterior side. You can see the big gluteus maximus muscle here. But this image is mainly to show you this band here, which is called as, guys, iliotibial band here. It's a tough fibrous band present on the lateral side. It starts from the iliac bone above and attaches to the lateral tibial condyle. That's the name is iliotibial band. It is a modification of D fascia of thigh. Fascia lata ki modification hai iliotibial band. This iliotibial tract or iliotibial band, what makes it so important? The iliotibial band, first of all, it receives the insertion of two main muscle. It is modification of fascia lata. It receives the tensor fascia lata muscle, that is one TFL, tensor fascia lata. It's a gluteal muscle only, and even gluteus maximus. I already told you, gluteus maximus muscle, one of the attachment was to the gluteal tuberosity. You can see that. My finger again will be cut actually if I go there. Just look at that side, guys. You can see the gluteus maximus muscle attached there on the bone also, and it is attached to the IT band also. So gluteus maximus is attached to both. So iliotibial band is giving attachment to the gluteus maximus as well as to the tensor fascia lata. When there is a contracture of the iliotibial band, like in case of poliomyelitis, there is a contracture of the IT band. So when there is a contracture of iliotibial band, look at what is the position of the hip joint and knee joint, because the IT band is contractured. So what is the position of the hip joint? The hip joint position can be remembered as Faber, F-A-B-E-R, Faber, flexion, abduction, external rotation. Your hip joint will come into what? It will come into flexion, abduction, and external rotation. Flexion, abduction, external rotation. And knee joint will also come into flexion, and there could be external rotation of tibia also. So knee joint also comes into the flexion, and there is an external rotation of tibia as well. Right? Babinski-Proxy. There is hip joint, that is a Faber position, and knee joint, it is a flexion and external rotation. This is about the iliotibial band and IT band. Okay. Now, next picture that I'm going to show you guys, this is a picture. No, Ankur, there's nothing like that. You have to choose any one. You don't have to choose between the two attachments. This is not it's not a clinical question, okay, that I should give this to this patient or I should give that to the patient. Abhi dono jagah pe attachment hai, to both are attachment of this gluteus maximus. But if you still ask me, I would still say iliotibial band, because the major attachment, the most fibers of the gluteus maximus are attached to the IT band. But I don't think they will ask you a question like just choose between the iliotibial band and the gluteal tuberosity where maximus muscle is inserted. Aisa nahi hoga. That I can assure you. You're looking at the anterior compartment of thigh. Now, let's do one thing, guys. Let's look at the anterior compartment of thigh in the atlas image also and in one of the cadaveric picture also. The two pictures, let's compare them side by side here. The most landmark muscle here is the sartorius. The sartorius is the main muscle that you're looking here. Now, look at the sartorius muscle, and first of all, the reason it will be good to discuss the sartorius action right now, because sartorius action is just like a TFL. What tensor fascial, iliotibial band contracture can do at the hip joint and knee joint is a normal function of sartorius muscle. वो तो contracture था. The normal function of sartorius is to cause the flexion, abduction, and external rotation at the hip, and flexion at the knee joint. And flexion at the knee joint here. Flexion, external rotation and abduction at the hip, and flexion at the knee joint. Again, last year, November INICT question, they asked that this is the action of which of the marked muscle, and sartorius को mark करना था उसके अंदर. So sartorius is a muscle for the flexion, external rotation and abduction at the Faber, and flexion at the knee joint. It's a normal action there. Okay, let me just tell you how to look at the anterior compartment of thigh. When you're looking at the thigh, anterior compartment of thigh, guys, look at the sartorius muscle first, which I'm sure everyone will be able to identify, and then just divide the thigh in two parts. Medial to the sartorius, everything that you see medial to sartorius here, it is all femoral triangle, and everything lateral to sartorius, it's quadriceps. So sartorius ko dhoond lo, sir. Lateral to sartorius is quadriceps, medial to sartorius, it's femoral triangle. So let me just go toward the lateral side first. Look at that muscle over there, that is a rectus femoris muscle. In this case, the rectus femoris part is cut over there so that they can show the vastus intermedius. Rectus femoris muscle is also a two joint muscle. If you remember, rectus femoris and sartorius both were originating from the iliac crest. One from the anterior superior iliac spine, one from anterior inferior iliac spine. So, and both rectus femoris and sartorius, they are crossing the knee joint. But look guys, what's the difference now? I want to demonstrate this to you. Sartorius muscle is crossing the hip joint, and even rectus femoris is crossing the hip joint from the front. So both these muscles at the hip joint, they're causing flexion. But rectus femoris, unlike sartorius, is not moving backward. Rectus femoris is running in front, and it is going in front here. It is attached to the tibial tuberosity by the ligamentum patelli. So it is a major extensor at the knee joint. Sartorius is causing the flexion at the hip and flexion at the knee joint because muscle पीछे turn करके चला गया. But rectus femoris stays in front only, so it is causing flexion at the hip, but the main function is the extension at the knee joint. We know the quadricep muscle is mainly for the extension here, so it is for the extension at the knee joint. It is a muscle is for the extension at the knee joint. That's the function of the rectus femoris muscle. Okay. Look at the muscle over there, the muscle that you see inside. You already know the iliacus muscle. That is the iliacus muscle in the cadaveric picture. You can compare it to the other side. That is the psoas major muscle that you can see again. And if I go further beyond that, that's a pectineus muscle. Look at it in both the picture, pectineus. And then the adductor longus. Though adductor longus is not the muscle of anterior compartment, but it formulates the floor of the femoral triangle. These four muscles in the sequence from lateral to medial side: iliacus, psoas major, pectineus, erector longus. They are all forming the floor of the femoral triangle. They are all forming the floor of the femoral triangle. Okay. Gluteal region may, I mean, there's not much of a question in the gluteal region. The main question is here is a Trendelenburg test only, guys. Gluteus medius or gluteus minimus. Injury to the gluteus medius or gluteus minimus. Now, when I talk about the normal, like that marked muscle, this is the gluteus maximus muscle there. And on the other side, the muscle which is marked over there is a gluteus medius muscle. Gluteus medius or even minimus if it is marked. The muscle action is like this. The normal action is abduction. If your gluteus medius is intact, let's say that if this is the right side, guys. It's a picture from the posterior side. So it's a right side. Right gluteus medius is intact. Then obviously when you lift this left foot off the ground, your pelvis is still leveled. But if gluteus medius is injured or superior gluteal nerve is injured, so gluteus medius muscle will not work or gluteus minimus will also not work because both are supplied by superior gluteal nerve. So in that case, if you lift this leg off the ground here, this pelvis will not stay like this. It will drop down something like this. Look at this. In this case, the lift, you can see the foot is lifted off the ground here. As Turanti, you can see pelvis is dropping from that side here. And that is because of the gluteus medius of the right side. It's a right side Trendelenburg test. Right side gluteus medius muscle. Right side superior gluteal nerve involvement. But pelvic drop on what side? Left side. Everything is of the ipsilateral side except for the pelvic drop, which is on the other side here. Even the gait of this patient will be, because his left pelvis is dropping. So every time he walk, he will just sway like this. He will go toward the right side so that he can lift the pelvis here. Look at this, guys. Look at this gentleman. When he's walking, he is swaying toward what side? Right side with sway kar raha hai. So he can lift the left pelvis up here. He's doing it because his, let me tell you, his this side gluteus medius is not working. He wants to lift this pelvis and that's why he's swaying on that side. I will sway toward the right side to lift the left pelvis off the ground here. In simple language, in Trendelenburg test, right side gluteus muscle, right side gluteal nerve, right side, lurching will be there. It's a ipsilateral lurching is there, but pelvic drop is seen on the opposite, on the contralateral side. So if you see the pelvis is dropping on the left side, it is a right side. Everything is right side. The Trendelenburg sign is positive on the right side. Coming to the one important nerve in the lower limb, that is the sciatic nerve, guys. Sciatic nerve and the injuries. Look, when you talk about the sciatic nerve, first of all, sciatic nerve passes deep to the piriformis muscle. In some cases, it is piercing the piriformis muscle, and that is called as the piriformis syndrome when the nerve is compressed between them. One of the higher sciatica, that is the piriformis syndrome. So it is not supplying piriformis, it is passing deep to piriformis usually, not supplying anything in the gluteal region. Then sciatic nerve in the hamstring compartment supplies all hamstring, guys. All hamstrings are supplied by sciatic nerve. And now look at this. After that, the sciatic nerve divides into two branches. One is the tibial nerve. This is the tibial nerve here, the one which continues straight, and that is a common peroneal nerve. The common peroneal nerve is the one which will go and wind around the neck of fibula. That's a fibula over there. You can see tibia and fibula I put there, and that's a neck of fibula. The common peroneal nerve will wind around the neck of fibula, as you can see, and then divides into two branches. That's a very common point of injury for the common peroneal nerve also. Let me do that animation again. So that's the tibia and fibula, the neck of fibula. The common peroneal nerve winds around the neck of fibula from the popliteal fossa. It comes like this and then divides into two branches. The one which is toward the lateral side, it's a superficial peroneal nerve, and the one supplying the anterior compartment of leg, that is a deep peroneal nerve. SPN and DPN, superficial peroneal nerve and deep peroneal nerve. Superficial peroneal nerve and deep peroneal nerve. Now, what are they supplying? Again, names of muscles are not important. The function is important, guys. Tibial nerve is supplying the calf muscle, posterior compartment muscle. That means it is supplying the plantar flexus. It is supplying the plantar flexus. Plantar flexus, including tibialis posterior, which is an inverter also. That's the reason I wrote the name here. That plantar flexus is supplied by the tibial nerve, and it supplies the tibialis posterior also, which is an inverter. It is definitely a plantar flexor, but it is an inverter also. Then this nerve, it goes into the foot, divides into medial plantar nerve and lateral plantar nerve. Not very important, but lateral medial plantar nerve supplies the muscles in the sole of foot. Whatever muscles we have in the sole of foot are supplied by this medial plantar and lateral plantar nerve. Superficial peroneal nerve, it supplies the everters, peroneus longus and peroneus brevis. This pay attention to superficial peroneal nerve, guys, on that side here. That superficial peroneal nerve, it supplies peroneus longus and peroneus brevis, and both are everters. Whereas deep peroneal nerve, it supplies the muscle of the anterior compartment, and the muscle of the anterior compartment leg are what? They are dorsiflexors. They are all dorsiflexors. It supplies the dorsiflexors, including tibialis anterior, which is an inverter also. See, the problem is, guys, in the leg, We have three compartments. Look at anterior compartment of leg is for dorsiflexion. There's a limitation of the camera. I can't do this. So that I want to do so much for you. Like here we have dorsiflexor, that is by the anterior compartment. Posterior compartment is doing the plantar flexion. Lateral compartment, the one which are outside, are doing everter. And we have compartment for these three. So there is no compartment for inverters. Abhi inversion kaise hoga? Any muscle of anterior compartment or posterior compartment, if they're entering the foot from medial side, they will cause inversion also, guys. Tibialis anterior, tibialis posterior. They're entering the foot. They're definitely dorsal and plantar flexors, but they're entering the foot from medial side. So they are inverters also. They help in the inversion. The inverter also. So you can see inverter written here also, and you can see inverter written here also, supplied by deep peroneal nerve. And then what is the fate? The superficial peroneal nerve and deep peroneal nerve. The superficial peroneal nerve supplies the skin on the dorsum of foot, major part of dorsum of foot, and deep peroneal nerve, very very important question पूछते हैं इसके ऊपर. Deep peroneal nerve supplies the skin of the first web space. It supplies the skin of the first web space. Okay. Tibial nerve injury and common peroneal nerve injury. What will be the case, guys? Let's start with the tibial nerve injury first. That एक tibial nerve injury का case. In case of tibial nerve injury, what you will see, what muscles are gone? Plantar flexors are gone. If plantar flexors are gone, then obviously, and major inverters are also gone. If your plantar flexors are gone, your foot will come into what position? Dorsiflex position. And because major inverters are also, foot will also come into what? Everted position here. So your dorsiflex foot and everted foot, that is a calcaneovalgus, guys. Look at the picture here. That's a calcaneovalgus foot here. Your foot is like dorsiflex like this, and it is everted also. Okay. And the type of gait these patients will have are called as a calcaneal gait. They're walking on the heel only. That is called as a walking on heel. That is a calcaneal gait itself here. What will happen in case of the common peroneal nerve injury? That's the very, very commonly asked question, guys. What is the scenario in the common peroneal nerve injury? In common peroneal nerve injury, what will happen? Both superficial peroneal and deep peroneal nerves are gone. Look, in common peroneal nerve injury, generally around the neck of the fibula, first of all, dorsiflexors are gone and everters are gone. Abhi dorsiflexors are, इस बार dorsiflexors चले गए, तो foot will come into what position? Plantar flex position, that is a foot drop. And everters are gone, so foot will be inverted. So this time the foot is plantar flexed and inverted, and that is a equino-varus position of the foot. Foot drop is there and inverted foot is there. That is a equino-varus position of the foot. Look at that. That's a equino-varus position of the foot here. And the type of gait these patients will have a high steppage gait. If they will not take the high steppage gait, then obviously they will drag their toes on the ground. So they have a high steppage gait in case of this, the common peroneal nerve injury. So बहुत simple questions आते हैं. It's like tibial nerve injury and common peroneal nerve injury. Common peroneal nerve is the one which is commonly asked here. Tibial nerve injury is not very commonly asked question here, but you know that what will be the scenario if there is the case of the CPN injury and the common peroneal nerve injury. Okay. Short saphenous and great saphenous vein. The only thing you need to remember here, mainly from the question point of view, the great saphenous vein, which is running on the medial side, it's the branch of the femoral nerve, guys, which is accompanying them. Look at that femoral nerve over there. And femoral nerve is the one which accompanies the great saphenous vein with the name of saphenous nerve. So if you're taking the graft from the great saphenous vein, the saphenous nerve is likely to get injured. And sural nerve is the one which is running with the short saphenous vein. So if you have short saphenous vein se graft liya hai, then sural nerve will like to get injured. This is all I want you to remember from this picture here. That when you take a graft, in case of CABG, when you take a graft from great saphenous vein, the sural nerve will get, saphenous nerve will get injured from the femoral nerve. And if you take a graft from the short saphenous vein, then sural nerve will get injured. And sural nerve is coming from both common peroneal and tibial nerve. It's a combined branch coming from both common peroneal and tibial nerve. Chalo. Just quickly through few ligaments here, and then we're done with the lower limb part. The break is coming, guys. Look, you're looking at the ligament of the foot and ankle from the medial side. Now there's a medial arch. The main ligament which is supporting the medial longitudinal arch is a spring ligament. I just need your 5-7 minutes only, and then I'm giving the break, guys. I know that you might be needing a break right now. So this is a spring ligament here. The spring ligament is the one which is also called as a plantar calcaneonavicular. It's from calcaneum to navicular bone. That's a calcaneum bone and that's a navicular bone. Plantar calcaneonavicular ligament. And this ligament is the major ligament which supports the head of the talus here. If this ligament is broken, the head of the talus will come down, will touch the floor, and that will be a flat foot. The main ligament supporting the medial longitudinal arch, and that is the spring ligament. Whereas the lateral side arch is supported by the ligament stretching between the calcaneum and cuboid. Look at that, guys. That's a bone toward the lateral side. That is the ligament long and short. This is the long one and that is a short one. Long and short plantar calcaneocuboid ligament. Plantar calcaneocuboid ligament, and called the long and short plantar calcaneal. See, that's a long one. The one which is below is long. The one which is above is short, and they're called a plantar calcaneocuboid ligament. Calcaneonavicular ligament obviously medial side पे होगा, calcaneocuboid ligament lateral side पे होगा. So that is the main ligament of medial arch, and these are the main ligament of the lateral arch. That's a main ligament supporting the lateral longitudinal arch. So if you look at the foot from the plantar aspect, you can see these two ligaments. Just another picture to show you guys. The calcaneum bone is visible. If you look at the calcaneum bone, and that's a cuboid bone, that is a calcaneocuboid, and so calcaneonavicular is calcaneonavicular. A spring ligament ho gaya, and that is the plantar calcaneocuboid ligament. If you look at the ankle from the medial side, when you look at the ankle from the medial side, this deltoid ligament is there. And anatomically, what is the main question in the deltoid ligament? Deltoid ligament is such a strong ligament, guys, that it is attached to multiple bone. It is attached to the medial malleolus. It is having attachment to the calcaneum, to the talus, to the navicular, and it is even attached. It is attached to like these four bones here, to the medial malleolus, that is the tibia only, medial malleolus, to the navicular, to the calcaneum, and even to the talus also. These are the four attachment for the deltoid ligament. I remember this question, though it's an old question asked like this, that which of the following bone is not giving attachment to the deltoid ligament, or also medial cuneiform was also given in the option. So no attachment to medial cuneiform. It's a medial malleolus, navicular, calcaneum, and talus. And see, this deltoid ligament, the thing about this deltoid ligament is it is such a strong ligament that doesn't allow the eversion of the foot. Like if you look at the inversion and eversion of the foot, it's the eversion of the foot which is like very less possible. Inversion you can do a lot, but eversion zyada nahi ho pata. It's a very strong ligament which will do that. And any injury to this ligament, it's such a strong ligament that generally ligament is not broken. Such a strong ligament, when it breaks, it either will cause the fracture of medial malleolus, or it can also cause sometimes the chip fracture of the navicular bone and even the calcaneum bone as well here. So you can imagine how strong this ligament is, that if the eversion injury of the foot, the ligament can be broken. Like this. Look at that. That's a eversion injury here. Combination with a fracture of the lateral malleolus. Now, when there is a eversion injury, obviously the lateral malleolus will get fractured here. The malleolus on the lateral side, that will get bent on the other side, that get fractured here. And fracture of the lateral malleolus and the injury to deltoid ligament, they are seen together generally. So if there is a eversion injury, the lateral malleolus will be broken, and the stretch on the medial side will cause the injury to the deltoid ligament also. Whereas when you look at the foot from the lateral side, that's more important actually. The ligament which is present on the lateral side, we have three bands over of this ligament, all coming from fibula. Now you can see one is anterior talofibular, there is a posterior talofibular attached to talus bone, and the middle fiber is attached to calcaneofibular, guys. And out of this anterior talofibular, posterior talofibular, and calcaneofibular, it's the anterior talofibular ligament which is most commonly injured in the inversion injury of the foot. It is most commonly injured in the inversion injury of the foot. If there is an inversion injury of the foot like this, so that's most commonly, because generally inversion injury of the foot is in the plantar flex position. And in that case, anterior talofibular ligament is more in the line with the fibula, and that is most commonly injured ligament in that case, in the inversion injury. Just a couple of more slides and then we're done with this lower limb part. Now there's another ligament which I need to tell you guys. Just look at the circle on that picture, because there are multiple ligaments, intrinsic ligaments are there, not important. And that ligament over there is called as a bifurcate ligament. Well guys, why do we call it a bifurcate ligament? The bifurcate ligament is having its furcation. The stem of that ligament is attached to the cuboid calcaneum bone, and then one band goes to the navicular, one band goes to the cuboid. So there are two parts of it. If you compare this, one is a calcaneonavicular ligament. One part is called as a calcaneonavicular, and one is a calcaneocuboid. Calcaneonavicular, in fact, look at this cadaveric image. That's even better. Such a beautiful picture of this ligament. One is a calcaneonavicular and one is calcaneocuboid. Calcaneonavicular and calcaneocuboid ligament. And this ligament is broken especially when the foot is in the plantar flex position, wearing high heels, and then if there is an inversion injury of the foot here. So lateral, that anterior talofibular ligament is broken, but guys, this ligament is also broken here. So high heels, like the pencil heels, are usually the most common cause for this bifurcated ligament injury here. So when you like, okay, so when when your heels and your ankle don't play nicely, then this is what can happen. This bifurcated ligament can go. The anterior talofibular ligament and the bifurcated ligament, the both ligaments can go together here. Generally, they are seen, their injuries seen together only. Lisfranc ligament इसलिए बोल रहा हूं because it is a question asked in the recent time, guys. Lisfranc ligament, it's a ligament connecting the medial cuneiform to the base of second metatarsal. That was the only question asked. That's a Lisfranc ligament. Look at that ligament over there. It is connecting the medial cuneiform to the base of second metatarsal. Base of second metatarsal. And here is a radiograph. If this ligament is broken, if the Lisfranc ligament is broken, guys, this ligament is broken, the space between the base of first and second metatarsal becomes very evident here. Look at this picture. Such an evident space over there. You can see the base of second metatarsal and base of first metatarsal. The space is quite widened here, and that is because of the Lisfranc ligament injury. Chalo, sir. I think this deserves a break here, 100%. So we're done with the some part of histology, we're done with the embryology, general and systemic both, we're done with the upper limb, we're done with the lower limb. This is a time for the break. I'll give you exactly 20 minutes break, guys. Come back in 20 minutes, get your tea, coffee. ठीक है उसके बाद आते हैं and then we'll start with the head, neck and face and neuroanatomy. बड़े नहीं है, those topics are not big, but obviously we need a lot of attention in that here. So forget about MCQ, beta. MCQ, if I'll get into that MCQ thing, it will go very very long. I'll quiz so I can conduct in your group also. I had a plan to conduct the quiz also, but the problem is I have to keep switching from this presentation to other presentation for the quiz. So I'm thinking that let's get over with this. Quiz to hum kar lenge, quiz to we can do it later also. So that is not an issue. It is based on the same topics only. So let's take a break and catch this. Siddharth, I'll tell you something. I'll tell you one thing about the one-shot program is like I need to finish the thing in like 4.5 hour, 5 hour max. Like if that way, if I think about it, so obviously there is filtration has to come. Blood vessels of upper limb, lower limb, yes, important. Blood vessels anyways, anywhere are important because blood vessels surgery का एक integral part है. So obviously blood vessels are always important, whichever blood vessels. But I need to, again, I told you that when I look at the syllabus of anatomy, I need to look at, okay, if somebody is attending one shot and doing PYQs, will he or she be able to tackle at least 80% question asked in the exam in the anatomy? If my answer is yes, then the planning, the structuring I'm doing for this program is good. If I include everything in this year, तो बहुत बड़ा हो जाएगा ना. Then obviously it will be like a regular class or a course which will go for at least 3 days or 4 days. So that's a different story. So you need to take it as a one shot only. There are things which are important and we still have to kind of miss out on them because they're not very important. Okay, chalo sir. Recharged and let's go. So in head, neck and face, guys, first let's talk a little about the cranial nerve nuclei and the columns here. I'll just give you a brief idea about these columns here and then we'll see that what kind of questions are to be asked from there. In the cranial nerve nuclei and column, if you're looking at this, the very first column, the general somatic efferent, GSE column, the first column, I'm just telling you in a very layman language, the first column is for extraocular and tongue muscle, the GSE. The second column is for pharyngeal arches, the muscles of pharyngeal arch. The third column is parasympathetic column, which I will discuss with you separately in detail. The fourth column is a nucleus of tractus solitarius, fourth and fifth column together, and this is for all the visceral sensation, taste, anything visceral sensation. The second last column is for all the somatic sensation, like the sensation coming from body wall. Pain, temperature, touch, pressure coming from body wall. The trigeminal nuclei is present in it. And the last column is for auditory and balancing, that is hearing and balancing, SSA column. The question asked in the exam is about the arrangement of the cranial nerve nuclei in the sequence. Now, again, there is no need to remember all the 7 columns here. Zarurat hi nahi hai. If you know the first 3 columns, you are still sorted in this. The first column is GSE, the second column is SVE, and third column is GVE. So if I know the first 3 column, I automatically know the next 3 column in a sequence. You just have to do the mirror image. Usko ulta kar dena hai. For the GVE, we have a GVA. For SVE, we got SVA. And for GSE, this is GSA. So if you know the first 3 column, then you just have to like mirror image like this and you look at the next 3 column here. And the only odd column, that is SSA column, special somatic afferent column, is present at the end. That is a SSA column, the special somatic afferent. So for the question which was asked in the exam, which was about arrange the cranial nerve nuclei column in the floor of fourth ventricle from medial to lateral, that is all medial to lateral only. What is the sequence here? Please do not spend your energy in remembering the 7 columns. Pehle 3 yaad rakho, you're done with that. You know the first 3, then you know the next 3 also, because that's like a mirror image. And the last one is an odd column, which will not match with any efferent column. That is SSA column is the last one here. Out of these columns, guys, the third nerve, oculomotor nerve, is present in the first column. You can see third nerve is present in the first column. And Edinger-Westphal is also the nucleus for third nerve. So third nerve is related to 2 columns. One is GSE and one is GVE. GSE and GVE are the column for the third nerve. Now, nobody in the exam is going to ask you what is the reason for the column, but you should know that at least parasympathetic nerve, I'm not saying all the 12 nerve, but at least parasympathetic nerve के column कौन-कौन से? Third nerve, 7th nerve, 9th nerve, 10th nerve, the 4 parasympathetic nerve, what are their columns here? So third nerve column is first one, you can see it supplies extraocular muscle, and Edinger-Westphal is also the nucleus of third nerve, so that is the 2 column here. And for the 7th nerve, 9th nerve and 10th nerve, thank God, for the 7th, 9th and 10th nerve, we have all columns except first and last. Look at this highlighted column, guys. All columns except first and last. So leave the GSE, leave the SSA, and rest all the following columns are related to the 7th nerve, 9th nerve, and the 10th nerve, except the first and the last column here. Now again, nobody is asking you the reason for the column. You just need to know that which columns are there here. The question here is about knowing which column is not related to it. Which column is related to it? You automatically know it. If you know the first one is not there, last one is not there, then why would you like to know the thing like that here? This is all you need to know in this. कि मुझे पता होना चाहिए पहला नहीं आखिरी नहीं बाकी सारे column होते हैं. My job is done with that. Right? So third nerve nucleus, we have the first one and the third one, that is GSE and GV, And 7th, 9th and 10th nerve, guys, we have all columns except the first and the last, and you are sorted. That's it. You just don't have to do anything else in this. That is more than enough for the arrangement of the nuclear point of view. And I very strongly feel whenever the question is asked, it's about the parasympathetic cranial nerve, they ask you in that. Okay. Let's take this GSA column and GVE column in a little more detail, guys. If I talk about this GSA column, General Somatic Afferent column, the GSA column is having this big trigeminal nuclei present in that. One part is present in the pons, one part is in the midbrain, one part is in medulla oblongata also. The portion of this trigeminal nuclei present in the midbrain is called as a mesencephalic nucleus. Principal sensory nucleus is in the pons, and we have a spinal nucleus which is present in the medulla oblongata. But at DP, what is the significance of these columns? The significance of the column is it tells you that what kind of function the nerve is performing. If a nerve is having 5 columns, it tells you that the nerve is having 5 types of function. Secretomotor function, sensory function, taste function, blah, 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 whatever. Like different functions for the different nerve. That depends on the number of columns we have. Like third nerve is having 2 columns. So there are 2 types of function hote hain. To supply the extraocular muscle and to supply the smooth muscle. So that's why 2 columns are there. So significance is telling you the variety in the function of the nerve is holding. Mesencephalic nucleus, guys, it is for the proprioception. All the proprioceptive information will come to the mesencephalic nucleus regardless of where they are coming from and which nerve is carrying them. ऐसा नहीं सोचना है कि only the trigeminal nerve will come into it. No, nothing like that. Even a vagus nerve carrying the proprioception can come into it. Even the facial nerve carrying the proprioception from, let's say, facial muscle can come into it here. So it's regardless of the nerve. If it is a general sensation coming from the body wall, that will come into the trigeminal nucleus. Mesencephalic nucleus of proprioception. Principal sensory nucleus is for touch and pressure. All kind of touch and pressure will come into the principal sensory nucleus, the touch and pressure. And spinal nucleus, which is clinically very important, guys, it is for the pain and temperature. The pain and temperature sensation goes into the spinal nucleus. इसका example लेते हैं. Let's say trigeminal nerve, 3 branches, ophthalmic, maxillary, mandibular nerve. Now mandibular nerve is supplying this area, the chin area. So it's supplying the chin area here. Now, the muscle which are supplying the chin area, like the mentalis muscle and all that, the proprioception of these muscle will go through this same mandibular nerve only, but will end into the mesencephalic nucleus. If I touch here, or if I put a pressure on this area here, this sensation is carried by the same nerve, mandibular nerve, but will go into which nucleus? Principal sensory nucleus. But now, if I pinch here, I cause the pain. Or if I feel the burning sensation in here, that is pain and temperature, again carried by the mandibular nerve, but will go into what nucleus? Spinal nucleus. The nerve could be same, but the termination point could be different depending upon what type of sensation the nerve is carrying. It will go into the respective their kind of nuclei. That is about the... Now, mesencephalic nucleus is a question which is asked in the exam more than once for the different reason, guys. Mesencephalic nucleus, first of all, it's a nucleus for proprioception. It is a center for jaw reflex also. When you test your jaw reflex, it is a center for jaw reflex, mesencephalic nucleus. And the special point, it is the only site in central nervous system having pseudo-unipolar neuron, guys. That's a very, very important point. Pure nervous system mein, we do not have pseudo-unipolar neuron anywhere else except for the mesencephalic nucleus. The only site for pseudo-unipolar neuron in central nervous system. Moving on, the next important column that we'll talk about is a GVE column, the third column, guys. GSE, SVE, GV. बस ये 3 ही याद रखने हैं. Rest I told you, will remember it. GSE, SVE, GVE. This is GVE column, General Visceral Efferent column, which is also called as a parasympathetic column. Because it is the nuclei present in there are connected to parasympathetic nerve and they are connected to parasympathetic ganglion. So this is going to be a very important slide, guys. We are kind of discussing a parasympathetic connection and we're also looking at the parasympathetic innervation of the glands also. Look, there are 4 nuclei in the GVE column. One is present in the midbrain, that is called as Edinger-Westphal, that is EW, Edinger-Westphal there. One is present in the pons, 2 are present in the pons, that is the superior salivatory nucleus, and we have inferior salivatory nucleus. And the one which is present in the medulla oblongata, that is called as the dorsal nucleus of vagus. That is dorsal nucleus of vagus. The nerve coming out of the Edinger-Westphal, the nerve for Edinger-Westphal is what nerve? Third nerve. Third nerve Edinger-Westphal nucleus se bahar aayega. And this third nerve will go and relay into the ganglion present in the orbit, and that is a ciliary ganglion. So guys, the ganglion for the third nerve is ciliary ganglion. And then from ciliary ganglion, the multiple short ciliary nerves will come out, and the job of these short ciliary nerves is to supply the smooth muscles, and that is sphincter pupillae and ciliaris muscle, right? So that's the whole parasympathetic pathway. Edinger-Westphal nucleus, third nerve will come out of it, relays into ciliary ganglion. From ciliary ganglion, the multiple nerves, short ciliary nerves, I did not write the name. The post-ganglionic nerves, you can simply say, the short ciliary nerves will come out and they will supply the sphincter pupillae and ciliaris muscle. Superior salivatory nucleus is a nucleus for facial nerve. Now guys, superior salivatory nucleus is a nucleus of facial nerve. Now there are two branches of facial nerve which is required for the discussion. One of the branch of facial nerve is the greater petrosal nerve, as you can see the GPN. Greater petrosal nerve branch of facial nerve relays into the ganglion called as the pterygopalatine ganglion. It's a ganglion present in the pterygopalatine fossa, relays into pterygopalatine ganglion. And the post-ganglionic fibers from pterygopalatine ganglion will supply the lacrimal gland. That's the innervation of the lacrimal gland. That's one part. Another branch of facial nerve is called as cauda tympani. Cauda tympani nerve is also a parasympathetic branch. Now this will relay into the submandibular ganglion. And once it relays in the submandibular ganglion, the post-ganglionic fiber obviously will supply what gland? Submandibular and sublingual gland. So the name says superior salivatory nucleus, but the important thing is it is not only supplying the salivary gland, it is supplying the lacrimal gland also. If your superior salivatory nucleus or facial nerve for that matter is injured, then the loss of lacrimation will be there and loss of salivation from submandibular and sublingual gland is also there. Inferior salivatory nucleus is a nucleus for what nerve? Ninth nerve, glossopharyngeal nerve. Ninth nerve will come out of the inferior salivatory nucleus. Glossopharyngeal nerve, there is a branch of glossopharyngeal nerve called as Jacobson's nerve and all that. I'm not going to that detail. And it's the ninth nerve which is going to relay into the ganglion called as the otic ganglion. And guys, once it relays into the otic ganglion, the post-ganglionic fibers from otic ganglion will go and supply the parotid gland. By auriculotemporal nerve, they supply the parotid gland here. So by this, you can see that how third nerve, seventh nerve and ninth nerve are taking care of the smooth muscles and the glands, especially the gland part you think about, lacrimal gland, submandibular gland, sublingual gland, parotid gland, how they are supplied here. You know the preganglionic nerve also, you know the postganglionic nerve also. So this is very, very important. Dorsal nucleus of vagus, guys, it is a nucleus of vagus nerve only, and vagus nerve is not having a parasympathetic ganglion in head and neck. Vagus nerve के parasympathetic ganglion तो thorax और abdomen के अंदर है. So this is the one which is going to supply the smooth muscle and glands of thorax and abdomen here. So no ganglion here. It is like the ganglion are present beyond head and neck. So we have 4 parasympathetic nerve, we have 4 parasympathetic ganglion, but 2 parasympathetic ganglion are connected to facial nerve only. One is for the third nerve, 2 are for the facial nerve, and 1 is for the glossopharyngeal nerve. That is the parasympathetic. Parasympathetic nerve is 3, 7, 9, 10. Parasympathetic outflow. Guys, when I say parasympathetic nerve, that is 3, 7, 9, 10. If any nerve is supplying any smooth muscle or gland, that is a parasympathetic nerve. So obviously 3, 7, 9, 10 are the parasympathetic nerves. And apart from that, the sacral nerve, S2, S3, S4 are also parasympathetic nerve here. So it's 3, 7, 9, 10, S2, S3, S4 is called as a craniosacral outflow or parasympathetic outflow. Jabki T1 nerve to L2 nerve from T1 to L2, they supply the sympathetic supply, give the sympathetic supply. Thoracolumbar outflow is a sympathetic outflow. Dono question hai guys. Parasympathetic outflow is by craniosacral outflow, that is 3, 7, 9, 10, S2, S3, S4. That was the exact question asked in the exam, AIMS exam here. And that is T1 to L2. Nerve from T1 to L2 nerve, these are the sympathetic nerves. Whatever sympathetic supply we have in the body, it is all coming from T1, T2, T3, T4 or T12. L2 is the last. So 14 nerves. Overall, I can say 14 nerves in total are sympathetic. And look at these guys. 4 plus 3, 7 nerves are parasympathetic. The next picture that we have here is a transverse section of the neck, and this transverse section of the neck is telling us about the Dumpy fifth cranial nerve is actually not parasympathetic, but fifth nerve has a role to play in parasympathetic pathway because all the post-ganglionic fibers are coming via fifth nerve only. Till the ganglion, it's the third nerve, seventh nerve, ninth nerve. But after the ganglion, all these branches that you're looking at, they are the branches of fifth nerve which is reaching the gland. So I can say fifth nerve has a role to play in the parasympathetic pathway. Although it is not a main parasympathetic nerve, but it does participate in the post-ganglionic parasympathetic pathway. So guys, the next picture that we have is a picture of the deep cervical fascia. It's a transverse section of the neck here. And what we'll understand from this picture here, we'll look at this picture twice. First, हम इसमें nerve को identify करते हैं, and then we will identify the major spaces in that here, the topographic nerve. Okay. So let's get a quick orientation of this picture, guys. What you're looking at in this image here, this muscle here that is present on the posterolateral side, this muscle here is a trapezius muscle, and that muscle present on the anterolateral side, that is a sternocleidomastoid. Sternocleidomastoid and trapezius are the two big muscles of the neck. They are present anterolaterally and posteriorlaterally. And they're covered in this fascia called as an investing layer, guys. This fascia is an investing layer, this one here. Then the fascia which you see furthermore inside, which is covering the vertebral muscle, that is called as a prevertebral layer. The one which is covering the thyroid gland, again my hand will cut if I go beyond that, that is covering the thyroid gland, that is a pretracheal layer. And I'm pretty sure you can all identify the carotid sheath also in that, where the carotid vessels are present. Look, let's take them one by one. Okay, there are a few circles which I'm like pointing at. I hope that you are able to see those circles in this animation. Like, there are 5 circles over there which are encircling the nerves. Look at the nerve which is present in the tracheo-esophageal groove, present in between the trachea and esophagus. That is a recurrent laryngeal nerve here. In the transverse section of the neck, they have asked this question to identify the vagus nerve, but there are very, very good chances they can ask you other nerves also to be identified. Recurrent laryngeal nerve कहाँ पर present है guys? Tracheo-esophageal groove. That exactly in the trachea and esophagus. Then the nerve that you see inside the carotid sheath, that nerve is a vagus nerve. The vagus nerve that you see running vertically into the carotid sheath, that's a vagus nerve. Then you see a nerve which is behind carotid sheath. Look at that. The one which is behind carotid sheath, but in front of prevertebral fascia, and that is sympathetic chain. That is sympathetic chain. Sympathetic chain. And then the 2 more circles that you're looking at, those the animation you can see around them here. One of the nerve is present in front of scalenus anterior and one is behind the scalenus anterior. The one which is in front of scalenus anterior, that muscle is scalenus anterior between those 2 circles. The one in front of the scalenus anterior, present behind the prevertebral fascia, that is the phrenic nerve, guys. That nerve is a phrenic nerve. It is anterior to scalenus anterior, but posterior to prevertebral fascia. PVF is a prevertebral fascia. And finally, the nerve that you see between scalenus anterior and scalenus medius, in between the 2, that is the cervical nerves which are forming brachial plexus. I told you the entire brachial plexus, the roots of the brachial plexus comes out between scalenus anterior and scalenus medius. So that's the cervical nerve which are forming the roots of brachial plexus. Dr. Bhavya, if you've written third nerve is also having a GSA, that is not wrong. I'll tell you why. Probably you are reading the note, the older notes only. It is believed that the third, fourth, and the 6th nerve, when they supply certain muscle, they also carry the proprioception from that muscle. That's the reason for that. Like third nerve will supply muscle, let's say it is supplying the inferior oblique muscle. So inferior oblique ka proprioception में लेकर आता है, and proprioception goes into GSA column. That's the reason you must have written that the GSA column is also there. But I would say, if I go with the recent trend and the recent question with the latest grades which was released last year only, 2 column. Just 2 columns. Just check off this GSA column here. It's the GSE and the GV, the 2 column for the third nerve. Chalo, again, answering the question, मैं topic से बाहर आ गया, I should not be doing that. So recurrent laryngeal nerve in the tracheo-esophageal groove. Vagus nerve is inside the carotid sheath. Sympathetic chain is behind the carotid sheath but in front of the prevertebral fascia. Phrenic nerve is behind prevertebral fascia but in front of scalenus anterior. और scalenus anterior और scalenus medius के बीच में क्या है? We have the roots of brachial plexus. The roots of brachial plexus. Let me put this picture once again, and this time I want you people to focus on 3 fascia I'm going to show you guys. Just behind the pharynx, guys, the fascia which is covering the pharynx from outside is a buccopharyngeal fascia. Look at that. I hope you can clearly see the fascia over there. That is a buccopharyngeal fascia. Then look at the fascia present in front of the vertebrae. That is a prevertebral fascia. This one is prevertebral. And then there is a fascia in between them also, and that is called as the alar fascia. Some author even call the alar fascia as the anterior layer of prevertebral fascia. वो इसको इसकी anterior layer भी बोलते हैं. Because if you ultimately look at that fascia, both the prevertebral fascia and alar fascia are like kind of fusing on the side here, right? So buccopharyngeal fascia, alar fascia, and prevertebral fascia. The 2 major spaces between buccopharyngeal fascia and alar fascia, the space that you're looking at, that is a retropharyngeal space, guys. That space is a retropharyngeal space. And the one on which the question is asked here, between the alar fascia and prevertebral fascia, the space is called as a dangerous space of neck. Now, why we call it a dangerous space of neck? Because this space is open below. This space is not limited into the cervical region. This space is open below into the posterior mediastinum, and it is open till the diaphragm. That means any infection of this space, of this dangerous space of neck, it can go downward into the posterior mediastinum. It can compress the trachea and esophagus and can cause dysphagia and dyspnea also, guys. That's why it is called as a dangerous space of neck here. It can cause dysphagia and dyspnea, called as a dangerous space of neck. Yeah, it goes all the way to the diaphragm. Yes, correct. Okay, so The same section, but the previously we talked about the nerves, and this time we talked about the major spaces, the retropharyngeal space and the dangerous space here. Because they've already asked the dangerous space of the neck in the longitudinal section. Abhi kuch change karne ka time hai, so I'm pretty sure that they will ask you the dangerous space of neck. They might ask you in the transverse section. So please identify these fascias correctly in that. Let's talk more about this carotid sheath, because carotid sheath again is a question which is asked separately, guys. From the black screen, let's go to the white screen here now. Now, carotid sheath, guys, let me take that carotid sheath out of the picture. Let us say this is a carotid sheath. Carotid sheath is having got artery inside. It's a common carotid artery is inside, and common carotid artery will continue as internal carotid. External carotid artery will come out of the carotid sheath. So when you talk about the content of carotid sheath, it's the common carotid artery and internal carotid, vagus nerve, and internal jugular vein. But look at this, guys. When we talk about the contents of carotid sheath, definitely these are contents. Common carotid artery is there, internal carotid artery is there, internal jugular vein is there, and vagus nerve is there. But you know, carotid sheath is attached above to the margins of the jugular foramen and also to the margin of the to the carotid canal. Abhi jugular foramen and carotid canal ke margin pe it attached. So if any nerve is coming out of jugular foramen, that is also supposed to be crossing this. Ninth nerve, 10th is anyways there. Ninth nerve, 11th nerve, even hypoglossal nerve coming from hypoglossal canal will cross this carotid sheath and will go forward here. What I'm saying, vagus nerve is definitely the main content of the carotid sheath. No doubt about that here. Like, let's say, guys, if this is a carotid sheath here, vagus nerve is definitely passing through it here. But in the upper part, the couple of nerves are also crossing it here. Accessory nerve is going backward. Vagus nerve is going downward, obviously. Hypoglossal nerve is going forward here. So even 9th nerve, 11th nerve, 11th that is spinal accessory, and 12th nerve are also the contents of carotid sheath, or you can say it is traversing the carotid sheath in the upper part. If you have to choose one nerve, vagus is the answer, no doubt about that. But if the question is about what other nerves are also considered as content here, you're going to go with all the four cranial nerves, the last four cranial nerves, 9, 10, 11, 12, guys. Common carotid, internal jugular, vagus nerve, and as a 9, 11, 12 nerve, they traverses upper part. इसके upper part को traverse करके जाते हैं. So they are also the content momentarily only. The anterior relation of the carotid sheath is the ansa cervicalis. The ansa cervicalis which supplies the strap muscles. That is the anterior relation of the carotid sheath. And posterior relation of carotid. In fact, ansa cervicalis is adherent to the anterior relation. But posterior relation is a sympathetic chain. It is just relation, guys. Sympathetic chain is posterior relation, and we saw it earlier also. That sympathetic chain is present just behind the carotid sheath, but in front of prevertebral fascia. Between prevertebral fascia and carotid sheath, that is a sympathetic chain. Investing layer of deep cervical fascia, which is covering the entire neck. Now, investing layer, guys. Why do we call it investing layer? It is investing the entire neck. If a surgeon is approaching the neck surgically, you have to cross one fascia, जो आपको cross करना ही पड़ेगा, and that is investing layer, because it is covering the neck all around. Investing layer of deep cervical fascia is covering the neck all around, and it is called as investing layer because it is investing multiple structures. It is investing like two muscles, two glands. So there is a rule called as a rule of two for the investing layer. And what is the rule of two for the investing layer? Says that it encloses two muscles, that is sternocleidomastoid and trapezius, which you can see in the picture. It encloses two glands. One is the submandibular gland and even parotid gland, guys. Face is not having the deep fascia, but parotid gland is covered with a fascia, and that is made up of investing layer only. So remember, it's not the thyroid gland, it's a parotid gland block. Thyroid gland is present in pretracheal fascia. It's the parotid gland and submandibular gland in the investing layer. Another rule of two says the two ligaments of mandible, stylomandibular ligament and sphenomandibular ligament, are made up of this. Two spaces, one space is of the sternum called a suprasternal space here, and there is a space which is above the clavicle called as the supraclavicular space. These are the spaces which are formed in the investing layer, supraclavicular and suprasternal space. And there are two pulleys also. Well, obviously, which muscle will require a pulley, guys? The muscle which is having double belly. Digastric muscle को पुली का जरूरत है, omohyoid muscle को पुली का जरूरत है. So omohyoid pulley and digastric pulley are made up of investing layer. That's the rule of two for investing layer. Two muscles, two glands, two ligaments, two spaces, and two pulleys. Either they are made up of them or they are investing these structures inside. The rule of two for the investing layer. Okay, moving on from the deep cervical fascia. That was a major thing about the deep cervical fascia. The next important thing here is the dural sinus and the cavernous sinus is the most important in that, guys. You're looking at a coronal section of the cavernous sinus, and what you see in the cavernous sinus, first if I go with the lateral relation, it's a coronal section, guys. Medial relations are quite obvious. I don't have to tell you. Medial relation is, you can see that sphenoidal air sinus is there, pituitary gland, you can see clearly there. What are the lateral relations of cavernous sinus? There are four nerves present in the lateral wall. That is the third nerve. We got a fourth nerve. We got a ophthalmic and maxillary nerve. Mandibular nerve is not in the lateral wall. So we have V3, 4, V1 and V2, ophthalmic and maxillary nerve. The only nerve which is passing through the cavernous sinus, having the longest intradural course also, and that is the sixth nerve, guys. That's a nerve with the longest intradural course, that is the sixth nerve, along with internal carotid artery. Internal carotid artery is also inside. Now, if internal carotid artery inside, there is something interesting, guys. Internal carotid artery is the content, or it is inside the cavernous sinus. If there is any aneurysm of internal carotid artery, and let's say that aneurysm ruptures, what will it lead to? It will lead to the fistula called as a carotido-cavernous fistula. And because of this carotido-cavernous fistula, every time the internal carotid artery will pulsate, the entire cavernous sinus will pulsate, and it will also push the content of the orbit, and that causes the pulsatile proptosis also. If there is an aneurysm of the internal carotid artery, ruptures inside the cavernous sinus, that causes this pulsatile proptosis, guys. Look at this video here. You can see the pulsation of this eyeball. That is a pulsatile proptosis, not pulsating exophthalmos. It is pulsatile proptosis, and that is because of the rupture of internal carotid artery inside the cavernous sinus. Okay. Chalo. Moving on. The next thing we're going to discuss here is about the muscles of mastication. From the head and neck, this is a very, very commonly asked question about the muscle of mastication and their action. So you got to be very precise about that. What are the muscles of mastication and what their actions are here. Now, guys, first of all, look at this picture here. And the main reason I wanted to show you this animation here to understand that the muscle present outside, that is a masseter muscle you're looking at here, and the muscle which will be inside, that is medial pterygoid, their fibers are oriented in the same way. Although one muscle is outside, one muscle is inside, but their fibers are oriented in the same direction, and that's why their action will also be the same. Look at the masseter muscle here, and look at that muscle inside. That is a medial pterygoid muscle over there. So medial pterygoid and masseter. If you just compare both the muscle here, look at the masseter and look at that medial pterygoid muscle. Their fibers are oriented in the same way only. Although one is outside and one is inside, but that's why their action is the same. Their action is going to be the same. Like quite a few similarities are there in their action. Okay, let's take these muscles one by one. First, you're looking at the picture of the temporalis muscle here. And this is, I always say this, and I suggest you all you people guys, do not pay attention to the origin of the muscle. That's a waste of the time. Especially for the people who are preparing for the PGME exam. I mean, I'm not talking to the first year students here. For you people, what matters is the insertion. Insertion kahan par hai? The action of the muscle is decided based on the insertion point. Temporalis muscle ho, masseter ho, medial pterygoid, lateral pterygoid, every muscle is inserted on the mandible. They have to move the mandible. So obviously you need to see how it is oriented toward the mandible. And then you just have to see in the reverse manner that if the muscle contract, how it is going to pull the mandible. Like if you look at the temporalis muscle, forget about where it is originated. No, koi nahi पूछने वाला कि temporal fossa se aa raha hai, kahan se aa raha hai. It is coming from there. The temporalis muscle is inserted to the mandible in such a way that some fibers are vertically oriented, as you can see, and some fibers are going like anteriorly. That's why the fibers which are vertically oriented, they will cause the elevation of mandible. And the fiber which are horizontally, more or less horizontally oriented, they will cause the retraction of the mandible here. Elevation of the mandible is a strong action of temporalis muscle, but retraction of the mandible is a unique action of temporalis. Koi aur muscle, no other muscle of mastication can cause the retraction, only temporalis can do that. Elevation and retraction. Elevation is done by other muscle also, but retraction is not done by any other muscle. That's a unique action. So if you ask me, if the question is asked, what is the action of temporalis muscle? Will you write elevation or retraction? You will write elevation, guys. The major action is elevation. Retraction and protraction, ये कोई बहुत major action नहीं होता है. The main action of the jaw is opening and closing. So if you have to choose between the opening and closing and sideways movement and protraction, retraction, always go for opening and closing thing. Don't go for protraction, retraction, sideways movement. That is the main function here. But yes, if the question is asked that what is a unique function of temporalis which is not done by any other muscle of mastication, then retraction is your answer. Masseter muscle, if you look at this muscle outside, there's masseter muscle. Again, the muscle is oriented in such a way that the muscle contract. It is going to pull the mandible upward. So it is again the main muscle for elevation. It does help in protraction also. But again, protraction is a very, very accessory function. The main action of masseter muscle is elevation. It's a very strong elevator. It's a muscle for the clenching of the teeth. When you gussa aata, when you clench your teeth like this, you can feel the muscle outside here. It looks like a stone present outside. That's the masseter muscle. Then if you look at medial pterygoid, and I already told you guys, medial pterygoid and masseter muscle, the direction is same. Medial pterygoid is outside the ramus. If you cut the ramus and you see inside, look at that muscle over there. That is a medial pterygoid muscle shown over there. And medial pterygoid action, that's why it is also what? It also helps in elevation. Just like masseter, it is also helping in elevation. Both masseter and medial pterygoid, they does help in protraction also, but बहुत accessory function hai. The main function of the muscle is elevation. And then comes the very, very special muscle. 5 times there is an image-based question asked on the muscles of mastication. और 5 में से 4 बार this muscle is asked. That is lateral pterygoid. This is the muscle which is asked maximum number of times, and there is a reason to that. Look at that muscle here. First of all, talking about the question asked last year only, lateral pterygoid muscle, it extends, the tendon of lateral pterygoid extends in the cavity of TMJ as the articular disc. There is a fibrocartilage called as the articular disc present in the joint cavity of TMJ, and that articular disc is an extension of tendon of lateral pterygoid. So, एक question तो यही होगा, lateral pterygoid extension. Secondly, if you look at the two bellies of lateral pterygoid, the lateral pterygoid muscle is running horizontally. So the upper belly mainly helps in what? Protraction. And the lower belly will help in what? Depression. In fact, in one of the recent short videos which I am releasing nowadays on my channel, this lateral pterygoid is not actually the muscle for the depression. It basically brings the mandible in such a biomechanical position that the depression can be done effectively. जब तक आप mandible को protrude नहीं करोगे, unless you protrude the mandible slightly, then mandible will not come into the biomechanical position when the muscle can pull it down here. Actually, the muscle which are responsible for depression is not the muscle of mastication. It's the geniohyoid, anterior belly digastric. The muscle present here, they are the one which pulls the mandible downward. But the question is not about those muscles. The question is about these 4 muscles of mastication and their action. So let's look at this way, guys. Elevation or closing of mouth is done by what? It is done by temporalis also, masseter also, medial pterygoid also. But closing is done, opening is done by what? Lateral pterygoid. Okay. Protraction is done by which one? Protraction is by what? Lateral pterygoid. Retraction is by which one? The temporalis. And when it comes to the medial pterygoid and lateral pterygoid working ipsilaterally, only one side, the pterygoid muscle action working ipsilaterally is to deviate the jaw toward the other side. They rotate the jaw toward the other side. If I use my lateral pterygoid and medial pterygoid for right side, I will deviate my jaw like this. My jaw is deviated toward the left side. That is because of my right side pterygoids are working here. So they rotate the jaw toward the other side. That's about the muscles of mastication. From the muscle of mastication, the another important topic, guys, in the head and neck is a posterior triangle. Triangles of neck, all the triangles you need to know. Orientation, I'm sure the people who attended my lectures, they know that how important the triangles of neck are for the orientation sake here. But again, we're talking about the question point of view, posterior triangle. Nothing can beat the posterior triangle. And in the posterior triangle, the two nerves, which I always say the two most important nerve that is present inside, that is, one is the great auricular nerve, the nerve which is emerging from the posterior border of sternocleidomastoid, that is a great auricular nerve. Generally, people call it great auricular nerve. It's a great auricular nerve, guys. A very, very important nerve, which is again dividing into 2 branches, facial branch, mastoid branch, or anterior posterior. You can call it facial division, mastoid division, or anterior posterior division is there. And what makes this great auricular nerve so important? What makes the great auricular nerve so important, guys? The great auricular nerve, everything about great auricular nerve. First of all, let me start with the root value. That is C2, C3, or maybe C3, C4. It's variation, guys. C2, C3 or C3, C4. I'm going to go with the C2, C3 in this case here. C2, C3 or maybe C3, C4 also. So C2, C3 is the usual root value for the great auricular nerve. Great auricular nerve, first of all, it runs with the external jugular vein. Look at the animation there. That's the external jugular vein on the side of the neck here. And the great auricular nerve runs with the external jugular vein. Neat mein question pucha hua, guys. It's one of the neat question only, that which nerve is seen running with the external jugular vein on the side of the neck. That's great auricular nerve. Another thing, exactly, it supplies the lobule of the ear. This nerve supplies the lobule, lower 1/3, guys. Whatever I'm holding right now, that is a lobule of the ear. So, when we go for the ear piercing, that when we are screaming there, that is because of the nerve which is causing the pain while the piercing of the ear is the great auricular nerve only. That is the lobule, supplying the lobule of the ear. Then this nerve is also responsible for supplying the skin at the angle of mandible and parotid area, and that is the shaving area that you rightly said. It's a shaving area, guys. The shaving area, because that was also a recent question asked here. So the shaving area, that is the angle of mandible and the parotid region, supplies that region. And then we have in Frey syndrome. Now we know in Frey syndrome there is injury to auriculotemporal nerve. Now understand this. In the Frey syndrome, nerve कौन सा injured हुआ? Auriculotemporal nerve. Now when auriculotemporal nerve regenerates, it can join with some other nerve also. It can join with buccal nerve. It can join with lesser occipital nerve. It can join with great auricular nerve. But most commonly it joins with the great auricular nerve. That's why in Frey syndrome, when auriculotemporal nerve, when it stimulates, it is not only stimulating the parotid gland, it is stimulating the sweat gland also supplied by the auriculotemporal nerve in this region, great auricular nerve in this region here. So in Frey syndrome, the regenerating auriculotemporal nerve most commonly fused with great auricular nerve here. So look, all these different questions in there, and they're all about what only? The great auricular nerve. Or this sub question exam पूछे guys. All these questions are asked in the exam here, and it's one of them. Like in parotid surgery, the sensory loss in the shaving area, we already said parotid region is a shaving area only. They've asked this question once, that a patient 2 weeks after the parotid surgery came to the surgeon and he complained that he's having a numbness and sensory loss in the shaving area or while shaving. So shaving word बड़ा important है यहाँ पर, and that is obviously because of which nerve injury? That is great auricular nerve injury. But we are discussing the rule of 17 now. We're coming to that. Okay. Then look at this nerve, guys. The nerve which is actually coming from carotid triangle, passing deep to sternocleidomastoid and then supplying the trapezius muscle also, and that is the spinal accessory nerve. Apart from great auricular nerve, the second most important nerve to be remembered from posterior triangle is the spinal accessory nerve. Well, again, very important, guys. Spinal accessory nerve, we all know it supplies sternocleidomastoid and trapezius. Sabko pata hai? But the question is, when spinal accessory nerve is injured in the posterior triangle, when the nerve is injured in the posterior triangle here, in this triangle here, that means it is already supplied what muscle? Sternocleidomastoid. So sternocleidomastoid will be spared. Now, what are the functions of sternocleidomastoid? Like, if I demonstrate the function of sternocleidomastoid, guys, my right sternocleidomastoid will help me turn the face to the left side. So turning the face to the opposite side, that is the function of sternocleidomastoid. Tilting the head to the same side, that is also the function here. And the bilateral action of sternocleidomastoid will help in the flexion, and they also help in the protrusion of the neck like this. The flexion as well as the protrusion of the neck here. Bilateral action. Unilateral way, they are doing what? They are tilting the head to the other side, face to the other side here, and tilting the head to the same side. And if you try to perform both the function together, you will understand that why we have torticollis when there is a contracture of sternocleidomastoid. Because when there is a contracture of the sternocleidomastoid, both the function of sternocleidomastoid can be seen. That is what? Turning the face to opposite side and tilting the head to the same side. Like it looks like a torticollis only, guys. That is because both the function can be seen together. The muscle is contractured. If I'm facing like this, अगर मैं left side में ऊपर की तरफ देख रहा हूँ, तो it is because of right side muscle torticollis here, right? But my point is that spinal accessory nerve, if it is injured in the posterior triangle, that means the sternocleidomastoid will be spared. So all these actions will be spared. The patient can see toward the left side, he can do the forward bending, he can do the lateral tilting, all can be done. Only trapezius muscle is involved. First, the question is, why am I talking about only spinal accessory nerve injury? Because spinal accessory nerve is one content of this triangle which is present quite superficially, guys. Generally, the most of the important content, the subclavian vessels, the brachial plexus, which are present in the posterior triangle, they are present deep to the prevertebral fascia. Dekho, neck mein we have investing layer, and after investing layer, there is a prevertebral layer. And then we have imagined brachial plexus and all that. So two fascias are there. But spinal accessory nerve, it is present between the investing layer and prevertebral layer. That's one thing, guys. This nerve runs between the investing layer and the prevertebral layer, and that's why it is vulnerable to injury also. Because the moment you open the posterior triangle, the nerve which is running superficial in this triangle is the spinal accessory nerve. And as I told you, that injury to the spinal accessory nerve in posterior triangle, sternocleidomastoid muscle will be spared and only trapezius muscle will be affected. And the features of trapezius muscle will be seen. What are the features of trapezius muscle? Shrugging of shoulder. So patient will have a difficulty in shrugging of shoulder. There's a difficulty in retraction of scapula. And there's a difficulty in overhead abduction also, because trapezius helps in the overhead abduction by rotating the scapula. These will be the chief complaint of the patient here. Difficulty in shrugging, difficulty in the scapular retraction, and difficulty in overhead. All difficulty, guys. Nothing is lost completely. There's a difficulty in all these action because trapezius is involved. The main point from where the question is asked from this area is that when spinal accessory nerve is injured in the posterior triangle, आपको ये ध्यान रखना है कि sternocleidomastoid is spared and only trapezius is involved. So you just have to go with these features only. That's the main catch. Moving on, coming to the cranial fossa, guys, there are two important foramen because they're asked in the recent time, or repeatedly they asked in the recent time. So I should tell you about those two foramen, guys. You're looking at the skull foramina here. Foramen ovale, spinosum, ये सब पढ़ते हैं. That I'm pretty sure that you all read about these foramen also. But the two foramen on which the questions are specifically asked here, one is the foramen lacerum. Look at that here, which is present in the floor of cavernous sinus, and another foramen, that is the jugular foramen, guys. So first, let's start with the foramen lacerum here. The one question which is asked about the foramen lacerum is that this foramen is present between what bones? The foramen lacerum is present between three bones. That is a petrous temporal bone. The bone that you're looking at over there is a petrous temporal bone. I'm again out of the frame. That's a petrous temporal bone. Then you have bone which is coming from the inner side, that is a occipital bone. You can see foramen magnum there. Foramen magnum wali jo bone hai, guys, that is a occipital bone. And the bone which is present anterior to foramen lacerum, just see that, anterior to foramen lacerum, that is sphenoid bone here. So sphenoid, petrous temporal, and the basi-occipital or occipital bone. So sphenoid bone, petrous temporal bone, and occipital bone are contributing to the formation of foramen lacerum. What is there in the foramen lacerum? Now there are some contents which are traversing the foramen lacerum, which are crossing the entire foramen lacerum, ऊपर से नीचे तक, crossing the whole foramen lacerum. One is the emissary vein, and we have some meningeal branches of ascending pharyngeal artery, the one which are supplying the dura mater, guys. We have meningeal branches of ascending pharyngeal artery because it could be a trick question here. Which structures are traversing the foramen lacerum through and through? And there are some contents in foramen lacerum which are not traversing it completely. They are just present in the foramen lacerum, पर वो कहीं और से आ रहे हैं. Like greater petrosal nerve will come somewhere else and will go into the anterior wall. Deep petrosal nerve, internal carotid artery will come from somewhere else and enter there. So these are the contents which are not the true content, guys, because they are actually the content of carotid canal or Vidian's canal, but they are momentarily present inside the foramen lacerum, and these are the fill-ups जो उसको fill कर रहे हैं. What I'm trying to say, let's say if this is a foramen, guys, let's say if I'm demonstrating, let's say this water bottle is a foramen. Now obviously the content of this foramen is a nerve or any structure which is passing through. Like my finger right now, it's in the inside bottle here. That is a content. That's a content of the foramen. And if I just take out my finger from the other side, it's a complete content. But let's say if I just pierce this bottle from here and then I come out from the upper part here, then I'm not a true content. I'm just filling it up. The content which is through and through or traversing it are only the meningeal branch of ascending pharyngeal artery and emissary vein, and these internal carotid arteries, sympathetic plexus, greater petrosal, deep petrosal are just the fill-ups only. The another important foramen on which the questions are asked in the recent time is the jugular foramen. Again, very, very important, guys, and I again personally feel very strongly for these two foramen. ये दोबारा फिर पूछेंगे exam के अंदर. This is a jugular foramen, guys. The jugular foramen, it is like oval shaped foramen here. First of all, jugular foramen is giving passage to the two formative tributaries of internal jugular vein. The two veins which together will give rise to internal jugular vein, or two sinuses which will give rise to internal jugular vein. One is the inferior petrosal sinus and one is the sigmoid sinus. These are the formative tributaries of the internal jugular vein. The moment they come out of the jugular foramen, they join together and they form. Then they give passage to the 9th, 10th and 11th nerve also. Correct only, guys. 9th, 10th and 11th nerve are also coming out of it. 9th, 10th, 11th nerve. And we also have some meningeal branches of ascending pharyngeal artery. Not a very major content here, but some meningeal branches of ascending pharyngeal artery are also coming from that. We saw the same artery we saw in this foramen also, jugular foramen. Ascending pharyngeal artery is giving off the meningeal branches which are entering from multiple foramen here. It enters through hypoglossal canal, jugular foramen, foramen lacerum. So these are the branches of the pharyngeal artery which are supplying the dura mater. And out of the 9th, 10th and 11th nerve, as we know, 10th and 11th nerve, they together forms the vago-accessory complex. So both these nerves are present in the common dural sheath, and it's the 9th nerve which is having a separate dural sheath, and that was the question asked in the INICT, that which content of the jugular foramen is having a separate fibrous passage. And separate fibrous passages for which nerve? 9th nerve. 10th and 11th nerve are best friend, guys. They are the one which are going to join together and then supply the whole world. So that's why 10th and 11th nerve, they are together forming the vago-accessory complex. It's the 9th nerve which is having a separate passage passing through the jugular foramen. So that's about the two important foramen here, that is foramen lacerum and the jugular foramen. Next picture that you're looking at is a picture of the cranial fossa with the durameter intact. A problem kya hota hai when the durameter is placed here, it becomes a little more challenging to identify the nerves. How will you identify the nerve if durameter is there? I cannot see foramen. Let me enlarge that marked area, guys. If I enlarge this marked area here, what do you see? Look at that here. Now, this is the area of cavernous sinus. Let me just try to give an orientation for that. Guys, this is the area of cavernous sinus where my hand is placed here. Let's say this is the cavernous sinus area right now here. Now, in the lateral wall of cavernous sinus, we have third nerve. Look at this thin nerve over there, it's a fourth nerve. And we have trigeminal nerve branches. That's the whole trunk of trigeminal nerve I can see, which will go inside and divide into ophthalmic, maxillary, mandibular. So all these nerves in this line here, look at this one line, guys. All these three nerves are present in the lateral wall of cavernous sinus. That is a third nerve over there, this one. That is a fourth. This thin nerve over there is a fourth nerve. And that is a trigeminal nerve, which will obviously divide into branches. Over there is a internal carotid artery, and you can see which is also can see a nerve over there. That, guys, this is the anterior clinoid process. I mean, again, I'm going out of the frame only. That is anterior clinoid process where my finger is pointing right now. That you can see the tapering process over there. That is anterior clinoid process. Only one nerve is seen medial to the anterior clinoid process, and that is the optic canal, and that's the optic nerve over there. Now, number 2. In the lateral wall of cavernous sinus, we have third nerve. We got this fourth nerve, the thinnest cranial nerve, the fourth nerve, and even trigeminal nerve is also to be seen here. And then look, the question asked in the exam was actually on this nerve, guys, the one which I'm pointing right now, this one or this one. Now, this whole slope here, this slope is called as a clivus. This is a clivus where the brainstem is present, midbrain, pons, medulla oblongata is resting on this part here. And the only nerve that you see on the clivus is a sixth nerve, and that's the reason it is having a longest interdural course also. Imagine karo, nerve will enter into the durameter at this point only, and then it runs inside the cavernous sinus, keep going. So obviously the nerve is having the longest interdural course. So that is a sixth nerve, guys. Abducens nerve, it is the only nerve that you see on this entire slope, and that is the abducens nerve. A very, very important nerve and very likely to be asked again in the exam. In the posterior cranial fossa, we are not able to identify the foramen. So at least we can see the nerves in the tuft, guys. What I'm looking at here, it is the internal acoustic meatus. This is the jugular foramen area, और उसके नीचे hypoglossal canal. This तो obviously is a foramen magnum only. This is a foramen magnum. You can see vertebral artery over there. This is internal acoustic meatus. This is a jugular foramen area, and those are the hypoglossal nerve rootlets, small here. So if this is the internal acoustic meatus, 7th and 8th nerve will come out from there, right? If this is a, jugular foramen area, 9th, 10th, 11th nerve will come out from there. And if that is a hypoglossal nerve area, then obviously hypoglossal nerve will come out from there. So you can identify the nerve by the sequence also. Tuft of nerve, tuft of nerve, tuft of nerve. Internal acoustic meatus wali nerve, that is 7th and 8th, 9th and 11th, that is, and then we have the 12th nerve, the hypoglossal rootlets are present there. So if you're looking for the nerve to identify in the posterior cranial fossa, you just have to go in the sequence. ऊपर से नीचे जाना है, internal acoustic, jugular foramen, hypoglossal canal, and based on that you can identify the nerve. Because yeah, it becomes a little challenging, because if the cranial fossa is given and the durameter is present on it, and foramen तो दिख ही नहीं रहे, and we still have to identify the nerve in that here. Till date, they've asked this question twice in the exam. Both the time INI-CT and both the time it was a sixth nerve they have asked here, which is easy to identify, to be honest, guys. If you know that the only nerve present on the clivus is sixth nerve, then it is not difficult. Another thing which is very, very repeatedly asked in the exam, and I'm sure everyone will agree with me on this, and that is the styrion. The styrion, guys, the four bones which are contributing to styrion, as you can see, it's a frontal bone. You can see that's this H-shaped suture over there is a styrion. The frontal bone is contributing to it. The parietal bone is contributing to it. This is the temporal bone, and remember, it's a squamous part of temporal bone, and it's the greater wing of the sphenoid. यहाँ पर गलती करते हैं लोग. It's the greater wing of the sphenoid which is forming the styrion, and it's the squamous part of temporal bone, not petrous part. And this is the greater wing of the sphenoid. The four bones which are meeting at this point, that is called as a styrion. That point is called as a styrion. Oh, this circle started now. Now, what makes this styrion so important, guys? Now, I've kind of overlapped these two pictures together. I've just overlapped the brain on the skull image to see. And this is approximately the area of the styrion here. What is in relation, guys? Middle meningeal artery, and especially the anterior division of middle meningeal artery, is passing deep to the styrion. It's the anterior division of middle meningeal artery, and that is not the only thing. Anterior division of middle meningeal artery, number one. Then middle cerebral, because see, this point here is a Sylvian point. That's a Sylvian point. So middle cerebral artery will enter through it here. Broca's area will be present somewhere. Area number 44, 45. Broca's area is present here in this area only. On the left side, the Broca's area obviously on the left side that is present over there. Sylvian point, as I said. And to tell you, lesser wing of the sphenoid is also there, but on the inside. Lesser wing is in the relation, guys. Lesser wing is in the relation. That is not. Okay. So Broca's area, insular cortex. If I open this sulcus here, then obviously what is the hidden area inside? That is insula. So all these structures are present deep to the pterion. Obviously, their question generally is about the middle meningeal artery because that is involved in the extradural hemorrhage. But the structures, when you go deep to the pterion, you will find the middle meningeal artery, you will find the Broca's area on the left side, you will find the Sylvian point, you will find the insula. So all these structures are present deep to the pterion here, deep to the pterion. And it goes without saying that there's a very fragile area of the skull bone, the thin area of the lateral side here, and that's why any injury at the side of this can lead to the this is too violent actually. So rupture of the anterior division of middle meningeal artery, and that can cause the extradural hemorrhage here. The fracture of this region here, this bone is easily fractured here, and the middle meningeal artery rupture can lead to the EDH, the extradural hemorrhage. Stop. No worries. There will be no more delays in the PG examination. So this was a quick recap on this head and neck part here. Chalo, पहले जल्दी से मुझे review दो. If you are able to follow the major part here, then I will start with the neuroanatomy. 30 seconds break. Okay. Chalo, all going good. Some people brain is bursting, it seems. Better if that is the case. Chalo sir. Thank you so much. The break is over. Let's get back to the topic. The neuroanatomy. In the neuroanatomy, the first topic that I'm discussing with you directly is a Brown-Sequard syndrome. Because in the Brown-Sequard syndrome, we understand about that what the tracts are doing. Guys, and before I put the picture there, in the spinal cord, the three major ascending tract, the dorsal column tract, the spinothalamic tract, and spinocerebellar tract, and descending tract is a pyramidal tract. I'll tell you in a very simple format here. Again, examiner is like, they can ask you about the tract also, but it's usually about the lesions and injuries here. There is only one tract which is going to decussate at the level of spinal cord, and that is the spinothalamic tract. Spinothalamic tract, ascending tract, I'm talking about ascending tract. In the ascending tract, the spinothalamic tracts decussate at the level of spinal cord. Rest of the tract, they are not decussating or they are decussating above the spinal cord. So in the spinal cord lesion, like in Brown-Sequard syndrome, everything will be lost on the ipsilateral side except the things which are carried by the spinothalamic tract, and that is pain, temperature, crude touch and pressure. Pain, temperature, crude touch and pressure is lost on the contralateral side. बाकी सब कुछ ipsilateral side से जाएगा. Whether it is conscious proprioception, vibration, stereognosis, unconscious proprioception, okay, all will be lost on what side? On the ipsilateral side, except the things which are carried by the spinothalamic tract. Now, look, let me just go nice and easy in this. What you're looking at, right? Let me just put this picture first. See, this is a picture which is telling you about that what is happening in the Brown-Sequard syndrome. I'm sure everyone knows that in the Brown-Sequard syndrome, there is a hemi-involvement of spinal cord. Half of the spinal cord is involved. That means all the tracts at one level will be gone. Now, guys, let us say if this is a spinal cord here, and there is an involvement at this level where my two fingers are pointing that this is the injured on the side, one side, and this is involved. Now, at the level of lesion, everything will be gone. At the level of lesion, I'm not talking about below the 11 or above the, at the level of lesion, everything will be gone ipsilaterally. Whether pain, even the pain and temperature, touch, pressure, conscious, unconscious, everything will be lost on the ipsilateral side at the level of lesion. Ipsilateral loss of all sensory modalities at the level of lesion. जिस लेवल पे लीजन है, if the nerve comes inside, that nerve is not able to relay the sensation. It doesn't matter it is decussating, not decussating, decussating here, decussating up there, doesn't matter. The level of the lesion, everything will be lost at the level of the lesion here. Ipsilateral loss of all sensory modalities at the level of the lesion, वो तो होना ही है. Ipsilateral spastic paralysis below the level, I'll explain that to you. Ipsilateral loss of vibration and position senses, and contralateral loss of pain and temperature below the, I'll tell you guys. See, spinothalamic tract is the one which is carrying the pain, temperature, crude touch and pressure. And when it carries pain, temperature, crude touch and pressure, in the spinal cord only, they will decussate and they will go above. So if there is an injury at the level of spinal cord, if the injury is left side, so it is a mainly dominant loss is present on the left side here. Because the tract is decussating at the level of spinal cord. Agar it tract upar decussate karta in the brainstem, then the loss would have been on the same side only. Dorsal column tract runs on the same side. Cerebellar tracts ultimately come to the same side, so that the effect is on the same side only. Spinothalamic tracts are carrying the sensation and they decussate at the level of spinal cord. That's why pain, temperature, crude touch and pressure. They've only mentioned that pain, the loss of pain and temperature. It's not only pain and temperature, pain, temperature, crude touch and pressure will be lost from the contralateral side. Everything else is on the same side. Even paralysis is also on the same side only. The pyramidal tract will decussate and will go downward and supply. Now, once the pyramidal tract decussates in the medulla oblongata, it runs downward in the spinal cord. If the injury is toward the right side, the right side muscle will be gone. The tract is already decussated here. So, if the injury is now on the right side involvement will be there. But to understand the difference between the spastic paralysis and these, the flaccid paralysis, let's take an example, guys. Let's say this is a spinal cord here. Now, this is a corticospinal tract or pyramidal tract coming below to the spinal cord. Some fiber here, some fiber here. And these are all what? They are all upper motor neuron. Obviously, they are coming from the cortex. That is a spine. This is a corticospinal tract or pyramidal tract. That is the upper motor neuron. Lower motor neurons will come out from the spinal cord. That's a lower motor neuron. That's a lower. These are all lower motor neurons which are coming out from the spinal cord. If there is a Brown-Sequard syndrome, let's say at this level, guys, look at this point here where if this is the site for the Brown-Sequard syndrome, now what will happen? At the level of Brown-Sequard syndrome, you can see the cell body of this lower motor neuron is affected. And that is why at the level of lesion, it's more like a lower motor neuron lesion. That's why there is a ipsilateral flaccid paralysis at the level of lesion. At the level of lesion, there is a flaccid paralysis because lower motor neuron injured ho gaya. But rest of the lower motor neurons are working. You can see their cell body, you can see the rest of the axon, everything is fine. Lower motor neurons are fine, but their upper motor neuron is injured here. And that's why below the level of lesion, there is a spastic paralysis because lower motor neurons is working. They will keep on stimulating the muscle and the muscle will undergo the spasm. So at the level of lesion, there is a flaccid paralysis because it's a lower motor neuron type of lesion, and below the level of lesion all the neurons are working. The lower motor neurons are working, but upper motor neurons, they have to pass through this Brown-Sequard syndrome area, so obviously they are not working here. So there is a ipsilateral flaccid paralysis at the level of lesion, but there is a ipsilateral spastic paralysis below the level of lesion. Overall, if you look at the entire Brown-Sequard syndrome in the shortest format, what I would say that everything is on the same side. First of all, सब कुछ same side से जाएगा. Everything is lost from the same side except for pain, temperature, crude touch and pressure. First thing, except for pain, temperature, crude touch and pressure, which is gone from the contralateral side. Secondly, paralysis is also the same side, but at the level of the Brown-Sequard syndrome, it's a flaccid paralysis, but below the level of the lesion, it is a spastic paralysis, hai ipsilaterally. That's Brown-Sequard syndrome in short. If you remember this, guys, you will not get a question wrong on this here. That there is a contralateral loss of pain, temperature, crude touch and pressure, and ipsilateral loss of everything sensory or motor. But at the level of lesion, flaccid, below the level of lesion, spastic. That's it. Okay, now when you look at the brainstem, the ventral aspect of the brainstem and the dorsal aspect of brainstem, see, this question can never get old, guys. The ventral and dorsal aspect of brainstem, and because ventral aspect of the brainstem, it's all about how cranial nerves are coming out from there, and dorsal aspect of brainstem is about the fourth ventricle. So this has to be the very, very important. I mean, you no matter a question kitni baar pucha ho, you cannot leave this. Now, when you look at the ventral aspect of the brainstem, guys, what you're looking at here, this portion here is a cerebral peduncle, this portion here is the pons, and that is a medulla oblongata, right? So in the midbrain. In the midbrain, that is a cerebral peduncle over there. That marked area is a cerebral peduncle, also called as a crus cerebri. And between the two crus cerebri or cerebral peduncle, that fossa over there is called as the interpeduncular fossa, guys. That area on the inside where mammillary bodies are present, that is called as the interpeduncular fossa. You will see the nerve coming out from the interpeduncular fossa, that is the third nerve. The only nerve coming out from the interpeduncular fossa is the third nerve. The only nerve coming from the dorsal aspect of the brainstem, it is a fourth nerve. Right? Third nerve and fourth nerve, and you will see both the nerves are winding around the cerebral peduncle cage. So अंदर से आ रहा है वो third nerve है, the nerve coming from the dorsal aspect of brainstem, that is a fourth nerve. Pons, there are so many nuclei present inside the pons, but only one major thick nerve comes out of the ventral aspect of the pons, and that is the fifth nerve or the trigeminal nerve. The only nerve. Although you can see two parts of the trigeminal nerve, the thicker part is the sensory part and thinner part is the motor part here. Because trigeminal nerve mainly is a sensory nerve. So thicker part is sensory, thinner part is motor, but head trigeminal nerve is, guys. The only nerve emerging from the ventral aspect of the pons is the trigeminal nerve. Then from pontomedullary junction, we have sixth nerve, medial most. Then we got a seventh nerve. Again, you're looking at two parts of seventh nerve. It is marked on the other side. Two parts of seventh nerve. This time, thicker part is motor and thinner is sensory. Thicker part of the facial nerve is motor, guys, because facial nerve is mainly a motor nerve, and thinner part is sensory because thinner part of this facial, you know what is the thinner part called? It is called as a nervus intermedius. That's a main motor branch of facial nerve, and this is called as a nervus intermedius. And the function of nervus intermedius is nervus intermedius carries the parasympathetic fibers of facial nerve, and it also carries the sensory fibers of the facial nerve here. Sensory fibers and parasympathetic comes from nervus intermedius, and the main facial nerve is a facial nerve, this one. Kul milake, both are facial nerve only. And then the more laterally placed nerve is the eighth nerve. So 6th, 7th and 8th. 6th, 7th and 8th nerve, the three nerves coming out from what junction? Pontomedullary junction. When you look at the medulla oblongata, in the ventral aspect of medulla oblongata, guys, this elevation, this rounded egg-like elevation that you see, that is the olive. And more medial to the olive, that is a pyramid. That is a pyramid and olive you're looking at. The three nerves that you see coming from the dorsal side of the olive, or the lateral to the olive, that is the 9th nerve, 10th nerve and 11th nerve. And let me clarify this thing to you, guys. This is the 9th nerve. This is the 10th and cranial accessory nerve together. Vago accessory complex. This is the 10th nerve and accessory nerve together, cranial accessory nerve together, and this nerve where I've written 11th over there, it's actually a spinal accessory nerve. You can see it's coming from the spinal cord. It's a spinal accessory nerve, that is the 11th nerve here. So when you say 9th, 10th and 11th nerve, when you're looking at the 10th nerve, you're not only looking at the 10th nerve, you're looking at the cranial accessory nerve also in it. And then 11th nerve, which you're talking about, that is a spinal accessory nerve. And the only nerve that you see coming out between the pyramid and olive, that is the hypoglossal nerve. That is a hypoglossal nerve. So that's the ventral aspect of the brainstem, guys. Third nerve from the interpeduncular fossa. Fourth nerve is coming from dorsal aspect of brainstem. Fifth is the only nerve present on the ventral aspect of the pons. Sixth, seventh and eighth nerve, they are at the pontomedullary junction. 9, 10, 11 are lateral to olive. And 12th nerve is the only nerve between the pyramid and the olive. Between the pyramid and the olive. Let me take you to the dorsal aspect of the brainstem. Now that's a real-time picture of the dorsal aspect of brainstem. When you see the dorsal aspect of brainstem, guys, this area here is a midbrain area. That the one you see above. That is a midbrain area over there. I feel so helpless when I just move out of the frame. That is the midbrain area. And these are all peduncles, guys, cerebellar peduncle. We have a superior cerebellar peduncle. From below, we have an inferior cerebellar peduncle. And pons will have a middle peduncle. The three peduncles are there. And you can already see the rhombus shape inside. That is a fourth ventricle. So when you're looking at the dorsal aspect of brainstem, you're talking about the fourth ventricle here. Those four rounded structures over there are the superior colliculus and inferior colliculus. We have two superior colliculus, we got two inferior colliculus, and the superior and the inferior colliculus together, they are called as a corpora quadrigemina, guys. Four gem-like structure, they're called as a corpora quadrigemina. The four gem-like structure, this is called as a corpora quadrigemina. And the one nerve that you see which is coming out below the inferior colliculus, that is the fourth nerve. The only nerve emerging from the dorsal aspect of brainstem. Look at that. You can see it's a thin nerve over there coming out from there. Now, in the dorsal aspect of the brainstem, the question which is asked most of the time, it is on this elevation which is present in the floor of the fourth ventricle, and that is called as a facial colliculus. The other things are also there, but facial colliculus is their go-to question in this, guys. Facial colliculus is the one which is the main structure present over there. Facial colliculus, I'll tell you about it. Then just below the facial colliculus, we have a triangle called as a hypoglossal triangle. There is a hypoglossal triangle or trigone. And further below in inferior, there is a triangle called as a vagal triangle because vagal nucleus is present there. So we got a facial colliculus, the hypoglossal trigone and vagal triangle or triangle you can call them. And all these are present more or less in the same line only. In the real-time picture, it's difficult to differentiate them very clearly. Agar ye atlas image hota, hand-drawn picture hota, it will be more easier. And the triangle which is present more toward the outside is called as a vestibular triangle, where vestibular nuclei are present there, vestibular area you can call it here. So guys, if the question is asked that how many nuclei are present in the floor of fourth ventricle, then please don't get confused with the facial colliculus. Facial colliculus is not because of the facial nucleus, it is because of the facial nerve winding around what? Abducens nucleus. Like, look at this picture here. You can see facial nerve is winding like this, going toward the dorsal side, and then it is coming out forward. It's the abducens nucleus forming the internal genu. So facial colliculus is obviously having facial nerve deep to it, but obviously which nucleus? Sixth nucleus. So what nuclei are present in the floor of fourth ventricle? You will say it is 6, 8, 10 and 12. Facial colliculus is because of 6, I mean we have a 6 nucleus deep to it, 8 vestibular, triangle, there is the vagal is 10 obviously, and 12 is hypoglossal here. So 6, 8, 10 and 12. 6, 8, 10 and 12 here. And yes, that is the very next thing I was talking about, guys. Abducens nucleus surrounded by the lower motor neuron lesion of facial, lower motor neuron of facial nerve. It's when I say facial colliculus, the nucleus is abducens there, but the nerve which is surrounding it is a facial nerve. It's a lower motor neurons of the facial nerve which are surrounding it here. So every time we say there is an injury to the facial colliculus, तो सबसे पहले nerve जाएगा. The nerve will get injured first. Nucleus is like this and nerve is surrounding it here. So any injury to the facial colliculus, the structure which is involved or likely to get injured, first is the facial nerve, then there are chances of nucleus here. So always go for the muscles of facial expression involvement. Lateral rectus is not going to be the first answer, guys. Injury to facial colliculus, your preferred answer is a lower motor neuron lesion of facial nerve. Lower motor neuron facial nerve, and which will cause what? Ipsilateral facial paralysis. Which will cause ipsilateral facial paralysis. Which will cause ipsilateral facial paralysis. So that is about the dorsal aspect of the brainstem, and you're looking at the rhomboid fossa in this. Okay. Moving on, now coming to the ventral and dorsal aspect of the brain. So guys, let's talk about the sections of the brain. Now, from the core anatomy point of view, identifying the sections of the brain, according to me, is the most important thing, is the single most important thing in the neuroanatomy that you need to do. Sagittal section, transverse section, coronal section. Sir, sections को नहीं छोड़ना है. And I'm not saying that you may get a question on this. I'm telling you, you will get a question on this. There will be one question, at least minimum one question on any section of the brain. Could be transverse, could be sagittal, and they keep on asking these questions over and over again. If you're leaving the sections of the brain, that's a crime. Don't do that. First, the sagittal section, guys. If I look at the sagittal section, this will tell you about the third ventricle boundary. Let's get oriented to this picture first. If anyone read about this, then fine. If not, look at this. Now, what you see in this picture, guys, this here is a corpus callosum that you see above. That my hand is right now on the splenium of corpus callosum. Just below the corpus callosum, you can see that white matter bundle which is running over there. That is a fornix. And then below the fornix, whatever is this green highlighted area that you're looking at, this here is the third ventricle. That all green like highlighted area here is a third ventricle. If this is a third ventricle, let me just put that. If this is a third ventricle, now what are the boundaries of the third ventricle that you see? Above is the body of fornix, that white structure over there is the body of fornix, and just below that is the choroid plexus. Let me use these arrows only. So here is the body of the fornix, guys, and just below that you can see choroid plexus, and body of fornix and choroid plexus are forming the roof of the third ventricle. Posteriorly, this gland over there where I'm pointing at right now, I hope all of you can see that. I'm pointing at right now, this is a pineal gland. And pineal gland is having a superior lamina and inferior lamina. Superior lamina of the pineal gland is having a commissure called as a habenular commissure, और नीचे वाले lamina के अंदर we have a posterior commissure. There is a habenular commissure there. Then we have a pineal gland. Then we have this commissure called as posterior commissure, and further you can clearly see that is an aqueduct of Sylvis coming toward the fourth ventricle. That is an aqueduct. So habenular commissure, pineal gland, posterior commissure and aqueduct of Sylvis, they are all forming the posterior wall of the third ventricle. Posterior wall of third ventricle. No, yaar, I don't want to use that pointer. I don't like using these mouse pointer. I can use the mouse pointer there. But I like to be a little more animated and go and show the structures here. That's why I feel, let's say, ये तो मुझे पता pointer use कर सकते हैं यार. Okay. Let me put this pointer aside only. Okay. When you look at the anterior wall is by the commissure called as the anterior commissure. Look at that rounded structure over there is the anterior commissure. And just below the anterior commissure, there is this lamina terminalis. Lamina terminalis is the cranial most end of the neural tube. When we saw that today, when we talked about the neural tube, guys, neural tube ka jab the anterior end of the neural tube closes, that forms the lamina terminalis. So it is a representation of the cranial most end of the neural tube, that is the lamina terminalis, and both lamina terminalis and anterior commissure, they form the anterior wall. And then comes the floor. The floor of the interpeduncular, the floor of this third ventricle, if I see the floor of this third ventricle from this side, it is actually interpeduncular fossa. If I see it from this side, then it is the floor of third ventricle. So guys, if I see from here, this is the optic chiasma, this is infundibulum of pituitary, that is mammillary body, and that is posterior perforating substance, and all of these are present in the boundary or in the content of interpeduncular fossa only. But when you see it from the above, in that sequence, the optic chiasma, the infundibulum of pituitary, the mammillary body, which is a recent question, mammillary body projects into which thalamic nuclei? Anterior thalamic nuclei. And then posterior perforating substance, they are all present in the floor. Identification is the key, sir. Identification. In this section, you are looking at the boundaries of the third ventricle. As you can see, roof is by the body of fornix and choroid plexus. Posterior wall is by these four structures here. You can see anterior wall is by lamina terminalis, anterior commissure. And floor, the most important floor, is having optic chiasma, infundibulum, mammillary body, which is a recent question. Mammillary body projects into the anterior thalamic nuclei. But what is the lateral wall? I can see anterior wall, posterior wall, roof and the floor. What about the lateral wall, guys? Lateral wall, look at this rounded structure over there is thalamus only. And this one is the hypothalamus. This area is a hypothalamus here. So thalamus and hypothalamus is forming the lateral wall of third ventricle. So that way we have covered this transverse section also, sagittal section also, and we've covered the boundaries of the third ventricle as well. If I show this in the radiological picture, and because this was an INICT question asked, guys, they showed the picture something like that, and the two arrows were placed. One arrow is placed somewhere here, which is behind the inferior colliculus. Like, I hope you can make out that's a midbrain, that is pons, that is medulla oblongata, this is fourth ventricle. So there is one arrow which is just behind the, inferior colliculus, and one arrow, if I place, it is in the floor of fourth ventricle. What are the nerves present here? The only nerve which is emerging from the dorsal aspect of brainstem is the fourth nerve. No doubt about that. Fourth nerve will come out in the longest intracranial course. And if the arrow is placed in the floor of fourth ventricle, then we know facial colliculus. We just saw facial colliculus is like here. So facial nerve winds around the abducens nucleus and comes out. So it's a facial nerve. I'm not saying nucleus. Facial nerve is present here. So if ever they ask you the question and they put the arrow behind the brainstem, they either will put the arrow below the inferior colliculus, where the fourth nerve is coming out from, or they will place the arrow in the floor of fourth ventricle, where seventh nerve is coming out from. यही दो आंसर हो सकते हैं. Coronal section. The coronal section of the brain, where we will be appreciating about the lateral ventricle. In the sagittal section, we talked about what? We talked about the third ventricle. We already saw fourth ventricle, that is in the dorsal aspect of brainstem. Now in the coronal section, we'll understand about the lateral ventricle, guys. Now first of all, when you look at this section, here is the corpus callosum. Just for the orientation, this corpus callosum. These two cavities over there are the lateral ventricle, which are separated from each other by a thin septum called a septum pellucidum. And this is a third ventricle. ये दो lateral ventricle है, and then we have a third ventricle below here. And we already know that third ventricle lateral boundaries were thalamus only. That means this is thalamus, this also is thalamus. Corpus callosum is forming the roof of the lateral ventricle. If I talk about the lateral ventricle point of view, that is corpus callosum forming the roof. If I just look at the white matter first, guys, that is corpus callosum. And look at this white matter bundle. I hope you can make out this white matter bundle running vertically upward. This is internal capsule. Look at this one. This is the internal capsule over there. And the same internal capsule, once it reaches the level of corpus callosum, it radiates everywhere in the cortex, and that becomes corona radiata. So internal capsule till the level of the corpus callosum, it's compact. And by the time it reaches the level of corpus callosum, then it radiates everywhere, and that becomes corona radiata. So the corpus callosum is the junction of the internal capsule and corona radiata. The hidden cortex, which was, if I'm not wrong, the very first image-based question asked in the INICT exam, they gave this coronal section and they asked about the insula, guys. Hidden cortex. That over there is an insula here. This is the insula. Let me show on this side here. This is the hidden cortex. Unless I go into the sulcus from outside, unless I open this sulcus from outside, मैं इस एरिया तक पहुंच ही नहीं सकता. So this is a hidden area of the brain, and that is called as the insula or insular cortex. That is insula or insular cortex. And what you see between the insular internal capsule, the lentiform nucleus is present there. The lentiform nucleus is kind of sandwiched between the lentiform nucleus is between the insula and the internal capsule. Now let's focus back to the lateral ventricle. Now we say lateral ventricle, guys, roof is by corpus callosum. The medial wall of the lateral ventricle is by this one thing only, and that is a thin septum called a septum pellucidum. It's a pellucid septum. It's a translucent septum. We call it septum pellucidum. And then from here to here, everything is present in the floor. There is no, see, there was no third nerve in the third ventricle, and there is no lateral wall in lateral ventricle. नाम lateral ventricle but lateral wall नहीं है. Life is not fair, guys. The roof is there, medial wall is there, floor is there, but there is no lateral wall in this lateral ventricle. We have what? We have everything is floor. Starting from here, this rounded nucleus here is a body of caudate nucleus, number one. Then we have what? Thalamus, number two. And then whatever is present in the roof of the third ventricle, that is fornix and choroid plexus. Look at that, guys. That is a fornix and choroid plexus. They are present in the floor. Whatever is present in the roof of the third ventricle is present in the floor of lateral ventricle. With choroid plexus and fornix, we saw it is in the roof of third ventricle, so they are in the floor of the lateral ventricle. That is the floor of the lateral ventricle. Because this presentation is reaching you guys immediately after the moment I say the last word, and from the phone I'll post that thing in your group here. Okay, so that will reach you. This presentation will reach you. So don't worry about that. It's not that you will be getting the presentation tomorrow or somewhere. I know your time is precious. Tomorrow you have other subject to go, and I'm sure many of you would want to just read it tonight only. This and just want to get rid of this thing here. So वो आपको मिल जाने वाला. Like it's like my fingers are on the button only. The moment we end the class, and I'll not take even a minute to send the entire copy to you. I hope you understood these two sections, guys. The sagittal section told you about the boundaries of third ventricle, and the coronal section, apart from insula and internal capsule and everything, it tells you especially about the boundaries of the lateral ventricle. Roof is by corpus callosum for the lateral ventricle, medial wall is septum pellucidum, and everything that I've highlighted here, that is present in the floor. Now, the fornix, guys, in the previous section, you can see fornix was still looking better, but you cannot see the entire fornix. There is no possible way to see the entire fornix in a very normal section of the brain. Fornix is a white matter bundle which is running in such a way that ऐसा कोई section ही नहीं है जिसमें आपको पूरा fornix दिखाई दे. You're not able to see the entire fornix in any possible way. Like right now, it looks like just like something white over there, just some bundle over there. But actually, there are two fornix. It's like fornix will start like this. It will go. These are two fornix. Like my two fingers are projecting the fornix only. They will come very close to each other, and that's what you're looking at right now over there. And then they go downward and they terminate into the mammillary body. Let me show you a picture where we can try to appreciate that, because there was a question asked on the fornix twice. This blue colored bundle over there is a dissection done for the fornix only, guys. Just for your understanding first, this is once again corpus callosum. This is a lateral ventricle that you can see, obviously divided by septum pellucidum, which is not there. And then we have fornix. So if you see the fornix fiber, they're starting from where? Hippocampus. Hippocampus is the origin of the fornix, guys. That is the origin of the fornix. And termination of the fornix is ultimately into the interpedunclar fossa. Into what body? Into the mammillary body here. और सर ये क्वेश्चन एक से ज्यादा बार पूछा हुआ है, that fornix originates in the hippocampus and terminates to mammillary body. Be careful about that. They have already asked this question till now, that where they originates. Hippocampus. Maybe next time they will ask you where they're terminating, and that is mammillary body. Correct. Coming to the next section, and that is the transverse section, guys. Let's talk about the transverse section in this. Okay. The transverse section, guys, what it shows you, we saw the sagittal, we saw the coronal, and now coming to the transverse section. No, beta. Amygdala is joined by the anterior commissure. Dumpy. Amygdala is connected by the anterior commissure. You are mistaken there. Look, beta, this is the transverse section, and I'm going to show you something very nice here. I'm sure that you will like that. This is the transverse section, guys. Now, what you see, like obviously this will be the area where the corpus callosum is present. Corpus callosum obviously is present here. Fibers of corpus callosum are running from one cerebrum to another. That is also there. This is the anterior most part of the corpus callosum, that is genu part here, and there is a posterior most part of the corpus, that is the splenium. The fibers from the genu of the corpus callosum, they are running forward and they're connecting the frontal lobe of one side to the frontal lobe of the other side, guys. And those fibers are called as a forceps minor fiber. These fibers which are coming from the splenium of the corpus callosum, they are called as a forceps major fiber. But these forceps major fibers are present medial to the posterior horn. आपको transverse section में you will be able to see the anterior horn. Look at this horn over there. That's the anterior horn of lateral ventricle, and that is a posterior horn of lateral ventricle. The horns are visible, anterior horn and posterior horn. So anterior commissure is medial to the anterior horn, and posterior commissure is medial to the posterior horn. They are medial to the respective horns, guys. Anterior commissure Now I'll use your idea. Just one second. Yeah, what I'm saying is that this is the anterior horn and this is the posterior horn over there. So this point, this where I'm pointing at right now, this is the posterior. This is the posterior. What do you say? The forceps major here, and these are the forceps minor fiber. If you see, this forceps major fiber is such a thick white matter bundle that it is projecting into the medial wall of the posterior horn and producing this elevation called as the bulb of the posterior horn. Okay, that is forceps minor, this is forceps major, and because of forceps major, this elevation over there is called as a bulb of the posterior horn. That is called as a bulb of the posterior horn. More lateral to the posterior horn, guys, that white matter bundle that you're looking at over there, this is called as a tapetum fibers. That is again coming from the splenium and the posterior part of the corpus callosum, and they're also running backward only. But remember, they're covering the posterior horn. Posterior horn ki medial side mein hai to forceps major, and on the lateral side it is a tapetum bundle. Tapetum. And in this section, you can also see the internal capsule. Look at this. That's an internal capsule over there. This is the internal capsule to be seen in the transverse section, which is surrounded by these three important nuclei. That is a caudate nucleus. This time it's the head of the caudate nucleus, the thalamus, and lateral side, it is a lentiform nucleus. That is a lentiform nucleus. And another, what do you say, view of the insula. That's an insular cortex, guys. A cortex which is present on the lateral side. That is an insula. So these are the things that you should be able to identify in the Siddharth, beta, fornix, yeah, fornix are all three types of fiber, but association fiber, commissural fiber, and if you have tried the association fiber is the best example, commissural fiber is the second best, and it can also be counted in the projection fiber. It is all three type, but you're right, association fiber and commissural fiber is a better answer for the fornix if you have to choose two out of the three. Okay, guys, I hope you understood this section. Now, look at this, and this is something which kind of I really feel happy showing this picture to everyone. Now, this is an MRI that you're looking at, the brain MRI, guys, the axial section. Now, what I did is, and already my review of the class is being shared. Let me mark excellent myself. Koi aur kare na kare. Okay. Now look, guys, this is the transverse section here. No, she deleted it. There's a transverse section. Bhavana, that is okay. Chalta hai, that's okay. So, guys, the thing about this section is that MRI, the brain MRI axial section is. I took the picture, the picture which I just showed you guys. This one. मुझे बहुत मजा आया करने में ये वाला ना. I took this picture and I took this MRI and I just tried to superimpose them. And I really felt good because it superimposed so perfectly. Now, it will look like that somebody put the color in the MRI only. Guys, have a look at this. And I want to just enjoy this thing. Look at this. Wow, this is so satisfying, isn't it? It looks like a perfect match only. So it's just that this MRI image is given and we overlapped this with this cadaveric, this picture here, and it matched perfectly. And let me put all the labelings here. Just let me give you just a couple of seconds. Just look at this, guys. Just understand, on one side we have a cadaveric picture and one side we have MRI, and you can just compare the two. Whatever you can see on the one side cadaveric, the same exact thing that you can see on the other side in the MRI view also. Magic, okay. Magic kuch nahi hua. It's a good superimpose only. Yeah, I told that in the class. I love that actually. In the class with the picture which I've showed you, it was not an animation. In the class which I've showed you the picture which is overlapped already here. I kind of just showed you it overlapping it. I fade in kiya maine isko iske upar, so I find it very satisfying. Okay. Chalo guys, this is the transverse section, the same thing which we saw in this previous image. All I'm saying is that just do not leave these three sections. Question aana hai sir. You will get a question from either from sagittal, from transverse, from coronal section. You just cannot leave any of these three sections here. Moving on to the cerebellum. Chalo. Now, moving on to the cerebellum means in Bhatia's only, but moving on to the cerebellar cortex. So cerebellum, guys. Cerebellar cortex, there are three layers in the cerebellar cortex. As you can see, there is a molecular layer, there is a Purkinje layer, and there is a granular layer. In the cerebellar cortex, in the gray matter of the cerebellum, we got three layers there. Molecular layer, Purkinje layer, and granular layer. I'm doing full on masti in this class. Generally I don't do that much in the class. You must be knowing that. So, guys, in the molecular layer, we have two types of cell. What are those? We got a basket cells and stellate cells are there. Then we have Purkinje layer. We got a Purkinje layer. Obviously, we got Purkinje cells. The name says Purkinje layer, so we have a Purkinje cells. And guys, granular layer, we have two types of cells which are called as the granule cells and Golgi cells. When you read these slides, just go through that. The same color code is shown here. Not the exact way the cell will look like here, but that's a representation, a schematic representation. So in the three layers of the cortex, we got five cells over there. Basket cells, sealed cell. These are supporting cells only. Purkinje is the main cell. Our discussion basically lies around the Purkinje cell only. And then we have a granule cells and the Golgi cells which are present in the granular layer. As a matter of fact, whatever is present in the granular layer, उन सबकी spelling G से start होती है. Golgi cells, granule cells, glomeruli. G for ground floor, सबसे नीचे वाली layer भी यही है. So granular layer is the one which is having a granule cells and Golgi cells. Okay, guys, 3, 1 and 2 these. Now out of these 5 types of cell, now imagine out of the 5 types of cell, 4 of them are inhibitory. Granule cell is the only excitatory cell. So it is like inhibitory, like it is flooded with the inhibitory cells, guys. Like it's so many negative cells are there. Like this cerebellar cortex, yeah, it's so negative. It's all negative. All are inhibitory cells there inside. Only excitatory cell is a granule cell in this. Only excitatory cell is a granule cell, and that is why cerebellar cortex is the largest collection of inhibitory neuron in entire central nervous system. Nowhere in the central nervous system we have these many inhibitory neuron, except for this granule cells which are excitatory. Rest all of them are inhibitory only. Chali sir. So that was about the cells inside. Now let's talk a little beyond that. Now, Purkinje cells are the one which are coming out. We'll talk about the Purkinje cell separately also after this. Now guys, what about the afferent fibers? Now can you see this orange color and green colored fiber? These are fibers which are coming inside. If you look at the orange fibers here, they are the one which are entering the cerebellar cortex and reaching the topmost layer. And when you're looking at the green color layer, the green color fibers are the one which are reaching till the granular layer only. So we have two types of fibers. We got a climbing fibers and we got mossy fibers. Climbing fibers, when you say climbing fibers, because of their climbing capability, these fibers can climb to the topmost layer and they can directly make a synapse with the Purkinje cell. And mossy fiber, नाम सुनने में लगता है mossy ji, old body see mossy ji cannot go beyond the granular layer, ground floor. So mossy fiber will only reach the granular layer only. You can see the green color fiber, they're reaching the granular layer. And that also explains you that why granule cells are excitatory. Because mossy fibers will reach only to the granular layer. It's the granule cell which will form the connecting link between the mossy fiber and then the Purkinje cell. And that's why they're excitatory. All other cells are inhibitory, but they are excitatory because they are the connecting link between the mossy fiber and the Purkinje cell. So climbing fibers are the one which directly climb to the topmost layer, and mossy fibers are the one which will use the granule cell to make a synaptic contact with the Purkinje cell. Okay. Which fibers are climbing? Which are mossy? That is also very easy, guys. All fibers are mossy except olivocerebellar and paraolivocellular. That's it. Any tract coming from olivary nucleus or para-olivary, जहां आपको tract के अंदर olivary और para-olivary लिखा दिख जाए, olivocerebellar, para-olivocerebellar, it is coming from inferior olivary nucleus, superior olivary nucleus, they're going toward the cerebellum. Olivary or para-olivary nucleus, a tract, whatever they're coming, they're all climbing fiber, and rest everything is mossy. Rest all are mossy. Whatever tract, guys, are coming into the cerebellum, dorsal spinocerebellar, ventral spinocerebellar, cuneo-cerebellar, vestibulocerebellar, reticulocerebellar, dash cerebellar, jo bhi ho, doesn't matter. If it is coming into the cerebellum, and if it is not olivo or para-olivo, they're all climbing fibers. Yes, my dear, you get the PDF with all the memes only, but obviously memes will not be animated in that. Chalo. Now, this is a very low magnification section of the cerebellar cortex only, the arbor vitae, guys. When you look at the cerebellar cortex, let me enlarge it further here. That's how it is going to look like. You can see the 3 layers over there. You can see molecular layer. The junctional layer is a Purkinje layer. Purkinje cell will be at the junction. And then obviously the granule can be seen inside. That's a granular layer. To see the Purkinje cell, we have to like enlarge it even further. And if I enlarge it even further, now I can see the Purkinje cells here. Histologically, if they ask you a question, they can ask you the question on the granule cells only, or this Purkinje cells only, because that's the only cell you can differentiate. Baki to sir differentiate ही नहीं हो पाएंगे. How will you ask the question on them here? So this is the Purkinje cell, guys. That is a Purkinje, the Purkinje cells are there. Purkinje cells are the only cells which are forming the efferent from the cortex. Rest all the cells are having internal connections. All these granules and Golgis and your baskets and stellates and all these cells are having internal connections only. Purkinje cell is the only cell which will send the axon out of the cortex. So they are the only efferent from the cortex. But be please very careful with that. It's the only efferent from cortex. यानी कि वो cortex से निकल के आ रहे in the white matter of the cerebellum. They are not going out of cerebellum. They are only coming from the cortex to the white matter. And in the white matter, we have what? Deep cerebellar nuclei. The dentate, emboliform, vestigial, mainly the dentate nucleus. So deep cerebellar nuclei they're coming to. And from the deep cerebellar nuclei, then the efferent fibers will go out of the cerebellum and they are forming the efferent from cerebellum. Ye do alag questions are, guys. Just remember that these are two different questions here. Efferents from the cortex, Purkinje cell. Efferents from cerebellum are formed by deep cerebellar nuclei. The exam में question पूछा हुआ था, they gave the histological view of this cerebellar cortex, they put the arrow on the Purkinje cell, and the question was that marked fibers are inhibitory to what? Well, the marked fiber are coming to what cells only? Deep cerebellar nuclei, so they are obviously inhibitory to deep cerebellar nuclei. Purkinje cells are inhibitory cells only, and they are inhibitory to what? Deep cerebellar nuclei and not to anything else because they are not going out of the cerebellum. It's the deep cerebellar nuclei which will send the efferent out of the cerebellum. Which brings us to the question that in the cerebellum, we have three peduncles. The superior cerebellar peduncle, middle cerebellar peduncle, inferior peduncle. What tracts are passing through it? Again, we need to be very smart in this, guys. Just for the orientation, guys, you're looking at the cerebrum over there. This triangle over there is a thalamus. Let's say the triangle over there is a thalamus. And this yellow, green and pink one, these are the peduncles, the three peduncles here. Superior cerebellar peduncle, middle cerebellar peduncle, inferior cerebellar peduncle. Peduncles kya hote hain, guys? The peduncles are the one which are giving passage to the tracts, which are allowing the tract to come in and go out of the cerebellum. Superior cerebellar peduncle is connected to midbrain. Middle cerebellar peduncle is connected to pons, and you can see inferior cerebellar peduncle is connected to the medulla oblongata. That is connected to medulla oblongata. Middle cerebellar peduncle is giving passage to the copy of corticospinal tract, which is called as a cortico. You can see it's coming from cortex to the pons and then to cerebellum. So, naam hi kya hua? Corticopontocerebellar tract. It is a copy of corticospinal tract, guys. Corticopontocerebellar tract. It is a copy of corticospinal tract. Despite of only, there's not much of variety there, but still the middle cerebellar peduncle is the largest cerebellar peduncle out of all three, and it is purely afferent. Fibers are only coming inside. बाहर कुछ नहीं जा रहा इससे. It is only allowing the fiber to come inside. So corticopontocerebellar tract is the only tract, is the only major tract. I mean, as I said, we just need to look at the major tract only. Is the only major tract coming from the middle peduncle. It is purely afferent. You will not see anything going out of the middle peduncle. It is not efferent. It is only afferent peduncle, and it's the largest peduncle. It is afferent peduncle here. Superior cerebellar peduncle, it is allowing one tract to come inside mainly, that is a ventral spinocerebellar tract, the tract which is responsible for unconscious proprioception, ventral spinous, from the spine called spinocerebellar. And then the feedback which is going out of the cerebellum, that is going from the dentate nucleus. One is called as dentatothalamic. You can see going directly from dentate nucleus to thalamus, dentatothalamic. And from dentate to rubrothalamic, via red nucleus they are going. So dentatothalamic and dentatorubro-thalamic tract, they are passing from the superior peduncle. These are the feedback tract, guys. These are the major feedbacks which are going from the superior peduncle. Middle peduncle se ek tract yaad rakhna hai, that is a corticopontocerebellar tract. Superior cerebellar peduncle is giving passage to ventral spinocerebellar tract, and then dentatothalamic and dentatorubro-thalamic tract are passing through this. Or sir, inferior cerebellar peduncle, that is going to the VL nucleus, and the inferior cerebellar peduncle को क्यों याद रखना है? If you know the superior peduncle, if you know the middle peduncle, if अगर काम चल रहा है इसमें 3 tracts from superior peduncle, 1 tract from middle peduncle, then guys, why would I read the inferior peduncle here? Why would I do that? Why would I waste my time reading the inferior peduncle when I could do the question just knowing that there are 3 main tracts from superior peduncle, there is 1 main tract from the middle peduncle, and rest everything is passing from the inferior cerebellar peduncle. So if you come across a tract जिसका नाम ही ना सुना हो आपने कभी, if you never heard of a tract like stria medullaris, dorsal spinocerebellar, cuneo-cerebellar, ventral spine, reticulocerebellar, vestibulocerebellar. Opposite also, cerebello-vestibular, cerebello-reticular. All those tracts are from inferior peduncle only. So just use your brain, just method of elimination. You need to remember the couple of tracts only and you still get the right answer, guys. This was about some major topics which I believe that from the neuroanatomy are to be done. Now, a little dose of histology after that. 30 seconds break. I will finish in time. Well, guys, this is still break going on. I mean, once the class is done, as I said, I'll definitely will be. I need to drive back home also, so obviously I will be answering your queries once I'll reach home or maybe tomorrow morning. But obviously I know that you have other subject to attend tomorrow evening, so I'll make sure that everything is answered before that only. PDF, so I'll share it right away only. And but I need the feedback from all of you guys. I need the feedback from each and every one of you, detailed feedback, because your feedback, I always keep saying that this is something which keeps us going. So whether it is here or on Instagram or any other gram or kilogram, jahan par bhi ho, wherever you are present, just make sure that you give the feedback and because I want to understand that how beneficial this method of teaching is, so that I can kind of use it more frequently in my YouTube sessions also. Maybe like in the class also I can use a few things like that. Chalo sir, break is over. Sir, the cartilage that you're looking at here, that is a hyaline cartilage. Sir, hyaline cartilage identify karna, it's very easy. Hyaline cartilage, to identify the hyaline cartilage, first of all, just some few features about that. We have a type 2 collagen fiber inside. Hyaline cartilage and elastic cartilage, they have perichondrium. They do have perichondrium, which way we have a fibrous layer. Outer layer is a fibrous layer, and inner layer is the cellular layer. You can see that outer layer is a fibrous layer. ऊपर की तरफ दिख रहा है आपको, and नीचे you can see the chondroblasts are there. That is basically the cellular layer, the inner chondrogenic layer ही बोलते हैं इसको. And this what do you say? The perichondrium is present in the hyaline cartilage, and it is also present in the elastic cartilage here. Fibro में नहीं होता बेटा. Okay. The main feature of the hyaline cartilage is that you see the chondrocytes. The chondrocytes are present in the groups, guys. Chondrocytes are present in groups here, and this cluster of chondrocytes is called as cell nest. That's a unique feature of hyaline cartilage. देखते समझ जाओगे this hyaline cartilage. Look at these clusters over there. 3, 4, 3, 4, 3, 4. The patches you can see over there. This is the chondrocytes present in the group, and that is called as a cell nest. And around this cell nest, you can see a darkly stained matrix, and in between you have lightly stained purple matrix over there. So darkly stained matrix is called as a territorial matrix, and in between you have an interterritorial matrix, which gives a different like appearance here. These patches will be seen here. Around the chondrocytes, we have territorial matrix, and then in between we have interterritorial matrix. That is a slide of hyaline cartilage. It's very easy slide to identify here. Romit, I 100% am starting with this 3 question series here. I'll tell you, actually, from the few days I was on pause and not able to do that here. Number one, there's a lot of recording is going on right now, and busy at other things as well. There was no break in the classes. I had a class, continuous classes without a break. Every single day there was a class, and moreover, I was waiting for this session to get over. Once this session is get over, like now you people have kind of revised the anatomy with me. Now it will be more beneficial if I post those 3 questions every day, which I will do. From tomorrow onwards only, कल से आपको 3 questions मिलेंगे in my Telegram group. Every single day till the INSCT exam, you'll find 3 important questions in the group. Okay, the next slide here, this is the slide of a elastic cartilage. Now, why I'm saying elastic cartilage? Again, you can see perichondrium. First of all, there is a perichondrium there. Same outer layer is a fibrous layer, inner layer is cellular layer. Now this time you will see chondrocytes are present there, but they're not in clusters. There was no territorial, interterritorial matrix. There individual lacunas are there, and there is no cell nest are present in this case. So that is the important thing. That elastic cartilage, guys, we are expecting to see the elastic fibers, but we will not be able to see elastic fibers in the H&E staining. For that, we need some special stain only. that obviously I don't think that they're going to give you any special stain or urgent heavy stain. That's why when it comes to the cartilages, elastic cartilage is not very likely to be asked. It is a fibrocartilage and the hyaline cartilage, and the fibrocartilage looks something like this. This is a slide of a fibrocartilage. In the fibrocartilage, the important thing to notice, first of all, there is no perichondrion, sir. And number two, we have type 1 collagen fiber. We have loads of collagen bundles are there, parallel bundle of collagen fibers are there. All these are bundles of collagen fibers which are running. And these collagen bundles, they squeeze the chondrocytes in such a way that sare chondrocytes line mein aa gaye. It's like if I just put multiple structures over there and I like with both the hand, I squeeze like them. So they all come in the one line only here. So that is the chondrocytes present in a row. Chondrocytes having a linear arrangement is one of the feature of the fibrocartilage. There is a fibrocartilage. I'll share all the links with you guys, my Telegram and Instagram and everything here. And I want you people to flood me. Now it's your turn to flood me with the messages here. But let's get over with this topic. So the last topic that we're going to discuss, guys, for the day is something about the pelvic vessels and the perineum. So again, it's about the percentage of questions. I'm not saying thorax se kuch nahi pooch sakte. They will not ask anything from thorax. But you can kind of, if in your one-shot revision or in a quick recap program, you can keep thorax out of your preparation part. In the abdomen also, cut it down to mainly to the perineum part, because perineum pe OBG obviously is asked heavily in the exam. Perineum questions are definitely heavy, and even in my regular class also I say that here perineum is the most important topic to be paid attention to. Okay. Now first thing, guys, we'll discuss a little about this internal iliac artery here. Now again, if you've read about the branches of internal iliac artery, nothing like that here. Anterior division, posterior division, just to understand that what they are supplying, where they're going. For the understanding, that is okay. Right now, I'm talking about from the exam point of view. Internal iliac artery, that is internal iliac artery looking at, it is dividing into this posterior division. Look at this posterior branch here. And this big division over there is the anterior division. Posterior division of internal iliac artery gives off 3 branches, and that is the lateral sacral artery, the one which I'm encircling. We got a superior gluteal artery, and it's a iliolumbar artery over there. It's the posterior division, guys. Posterior division, which is giving off 3 branches, and the branches are also very much posterior. Look at the branches. It says iliolumbar. Lumbar piche hoga na, iliolumbar artery. Lateral sacral. Sacral is also posterior. Superior gluteal. Gluteal region. So the branches coming from posterior division are 3. The posterior division branches are 3. That is superior gluteal, iliolumbar, and lateral sacral artery. It's a very commonly asked question that what are the branches coming from anterior division, what is the branch coming from posterior division. And trust me, I have seen this question. I can recall this question all the way back to 2008, 2010, 11, 12, 16, 17. पूछते रहते हैं इस question को. Internal iliac artery की which branch is from anterior division, which branch is from posterior division. As I said, if you read about the anterior branches, superior vesicular, inferior vesicular, the vaginal artery, uterine artery, middle rectal, internal pudendal, inferior gluteal, all these arteries obviously are coming from the anterior division here. But from the MCQ point of view, if you know the posterior division branches, the 3 branches over there, then again, why you need to remove the anterior division? From the exam quick revision point of view, just remember 3 branches from posterior division, anterior division. Again, why should I? अगर क्वेश्चन उन्होंने यही पूछना है बार बार कि which branches are from anterior, which branches of posterior division. So if I know the posterior division branches, I automatically know everything is from the anterior, as rest everything is from anterior division only. Whatever is not coming from posterior is from anterior division itself. That's what है ना, आज का मेरा थीम यही होने वाला था. Why should I? Why would I do that? Why should I do this? Why you would do this? No need to do that. Okay, sir. Now let's come to this topic, the last topic, but the topic which we need to discuss in detail, because we know that there are almost 100% chances, almost, that to get at least one question from this part, and that is a perineum part here. So I'm going to take like whatever time, 15, 20 minutes, whatever it take, maybe not that much, to complete this topic, the perineum. And let's start the perineum, guys, the understanding the perineum from the pelvic diaphragm. Okay, here we go. Now pelvic diaphragm, you're looking at the pelvic diaphragm from the inferior. Let's say if this is a pelvic diaphragm for me, if you're looking at the pelvic diaphragm like this, agar maan lete, this is a pelvic diaphragm for me here like this here. The pelvic diaphragm is the highest structure in the perineum, and then we'll just need to keep the building perineum downward. If this is a pelvic diaphragm, whatever picture or images I'll show you in this way, guys, like in the lithotic position. You're looking at the pelvic diaphragm and you're seeing it from the inferior aspect. That's how you're going to look at that. Okay. This is a pelvic bone, and here is a ischial tuberosity. There's a sacrum bone over there, and that's a ligament called a sacrotuberous ligament. That is a sacrotuberous ligament. Pelvic diaphragm is a combination of three muscles coming from three different parts of the hip bone. One is coming from pubis, that is called as pubococcygeus. One muscle is called as a iliococcygeus, and one muscle is called as a ischiococcygeus or simply coccygeus. So three muscle over there, that is a pubococcygeus, there is a iliococcygeus, and there is a ischiococcygeus, and all these three muscles together are called as a pelvic diaphragm, guys. Three muscles together are called as pelvic diaphragm. But out of these three muscle, ischiococcygeus muscle in human being, this muscle is of not much use. It's kind of vestigial muscle. That's why only pubococcygeus and iliococcygeus together are called as levator ani. So when it comes to levator ani, only two muscles are counted there, that is pubo and iliococcygeus, because these muscles are capable of elevating the anal canal. Iliococcygeus and pubococcygeus can do that. Ischiococcygeus is a muscle for the movement of tail. We don't have tail. I mean, obviously, this muscle is not required for this. We don't have to wag our tail in front of anyone. So, ischiococcygeus muscle is a vestigial muscle in human. It is forming a part of pelvic diaphragm, but it is not the part of levator ani. Now, let's say if this is a section of female perineum, guys. Let's say, guys, we have this is a section of female perineum. What you'll see that there are three openings there: the urethral opening, the vaginal opening, and the rectal opening is there. Urethral opening, vaginal opening, rectal opening. The muscle which is present closest to them is the pubococcygeus. So we have muscle like the extension of pubococcygeus will cover them. So there is a muscle called as the pubococcygeus. There we go. Then we have muscle iliococcygeus. I'm sorry, what do you say? Pubovaginalis, I'm sorry. That is pubourethralis, I'm sorry guys. That is pubourethralis covering the urethra. That is pubovaginalis. And there's a puborectalis muscle which is covering the rectum. So the three muscles which are the modifications of the pubococcygeus here. The modification of pubococcygeus involves what? Pubourethralis, pubovaginalis, and puborectalis. Especially puborectalis is very, very important because this muscle maintains the anorectal angle. It maintains the angle between the rectum and anal canal, and that's why it is also called as muscle of continence. It is also called as a muscle of continence, right? So that is, you all started. So if you're looking at the pelvic diaphragm from below, that's a first layer, guys. That's a first layer done. You're looking at the muscles forming the pelvic diaphragm, which part is levator ani, and then the three modification of pubococcygeus. Chalo, iske niche aate. Now let's go further below that. The more I say we go below, we are going downward. That means we are going superficial, guys. Hum deep se superficial ja rahe. We're going from deep to superficial. So again, the views from the inferior side only. The views from inferior side, same boundaries, same here. Now there is another diaphragm present there, and this is called as a urogenital diaphragm. There was a pelvic diaphragm. Below the pelvic diaphragm, that's a pelvic diaphragm. Below that there is a urogenital diaphragm, and you see it like this. So that's a pelvic diaphragm there, and this one is a urogenital diaphragm. And what you're looking at right now is an inferior layer of urogenital diaphragm, guys. Inferior layer. It is an inferior layer of urogenital diaphragm. There are two layers. दो layer होती है urogenital diaphragm में. One is superior, one is inferior. We are not looking at the superior. We're directly looking at the inferior layer of urogenital diaphragm, which is also called as perineal membrane. This inferior layer of UGD, urogenital diaphragm, which is also called as a perineal membrane. So in total, actually, we're done with three layers. First was the pelvic diaphragm, then it is a superior layer of urogenital diaphragm which we did not see, and then we have an inferior layer of urogenital diaphragm, that is a perineal membrane. Below perineal membrane, let's say this is the bulb of the penis covered with a muscle called as a bulbospongiosus, and that is the crust of the penis which is covered with a muscle called as a ischiocavernosus, guys. Bulb ke upar jo muscle hai, that muscle is called as a bulbospongiosus because the same muscle will cover the spongy urethra also. And the muscle present on the crust is a ischiocavernosus. Muscle is called as ischiocavernosus. And there also is a muscle which is running transversely in the perineum, which is called as a transverse perineal muscle. And because this muscle is present below the perineal membrane, that's why you're able to see, this is called as superficial transverse perineal muscle. This is below the perineal membrane. That's a superficial transverse perineal muscle. Guys, please look at this once again. Let me do that again here. So what I'm saying is, there is a superior layer and inferior layer of urogenital diaphragm. Below inferior layer of urogenital diaphragm, we have, this is the inferior layer of perineal membrane. You can call it perineal membrane also. There is a bulb of the penis called as bulbospongiosus. I mean, in female it is bulbo vestibule. Muscle is same only, bulbospongiosus. And then we have a ischiocavernosus which is covering the crust of the penis. And we also have a superficial transverse perineal muscle as well. So guys, if I start counting from the top, like right now you're seeing the lithotic position. अगर आप ऊपर से देखेंगे तो pelvic diaphragm, superior layer of urogenital diaphragm, inferior layer of urogenital diaphragm, and then we have this bulb and the crust and all these muscles are there, right? bulbosponges, ischiocavernosus, and all that. In the posterior triangle, what we have here is anal canal. That is the anal, the superficial. That's the anal canal there, and this anal canal is covered with a sphincter that is called as the external anal sphincter. Guys, that sphincter over there is the external anal sphincter. That is the external anal sphincter, and that point, which is you can see indicating over there, guys. This is the junction of most of the muscles in the perineum, the fibromuscular node, which is called as a perineal body. That is called as a perineal body. So guys, before we see what muscles are contributing to perineal body, like let's have a look at the picture, an atlas image, to kind of correlate with this. I hope you understood this image. Let's try to correlate with the atlas image here. There we go. Now I hope you can see that first thing, that's a pelvic diaphragm here. This one I'm showing, that is all pelvic diaphragm there, this one. Below pelvic diaphragm, this is a urogenital diaphragm. Like we coming below, that is a urogenital diaphragm. Which layer of urogenital diaphragm is that? That is the inferior layer, also called as a perineal membrane. Muscle bulbospongosus, muscle ischiocavernosus, muscle superficial transverse perineal muscle, and that is an external anal sphincter. That is an external anal sphincter. And this here is the perineal body. Look at this fibromuscular node over there. That is the perineal body, guys. That is a perineal body. The question is that what muscles are contributing to perineal body, guys? If let me bring that picture back to you. Perineal body is made up of 10 muscles. And in these 10 muscles, 4 are paired muscles and 2 are unpaired muscles. So 4 paired and 2 unpaired. What paired muscles are there, and what is the common mistake we do? The paired muscle is superficial transverse perineal muscle, obviously. If you have a muscle called as superficial transverse perineal muscle, there must be a muscle called as deep transverse perineal muscle will be there. Okay, ye bhi ho gaya, deep transverse. Then the bulbospongosus, that muscle is there. And the fourth muscle is the one usually people get it wrong here. It's not ischiocavernosus, guys. How can we have ischiocavernosus? How can we have this muscle, this one, the ischiocavernosus muscle in the perineal body? The muscle is far away. It's like anterolaterally placed. You cannot have that muscle in the perineal body. So it's actually levator ani. It's the levator ani muscle which is a paired muscle contributing to perineal body. Superficial transverse perineal muscle, deep transverse perineal muscle, bulbospongosus and levator ani, and not ischiocavernosus, guys, and not ischiocavernosus. Unpaired muscle, central muscle like external anal sphincter, and we have some longitudinal muscles also in the anal canal that is also contributing to it. Longitudinal muscles of anal canal is contributing to it. So 10 muscles, guys, that is 10 muscles contributing to perineal body. You're very careful in the perineal, especially in the episiotomy, guys. If you do the episiotomy posteriorly, then obviously perineal body can get injured here. If the perineal body, what is just behind the perineal body? External anal sphincter is there. The next thing which can get injured directly is the external anal sphincter. So in the posterior lateral episiotomy, we make sure that perineal body is spared and only the transverse perineal muscles are compromised in that case. Because it's a junction of 10 muscles. So if the perineal body is injured, obviously that can lead to the prolapse as well. Okay, now this is the moment of truth, guys. Now we look at the whatever layers we discussed. Let's look at those layers in the side view. Like it's like if I take a sagittal section of the perineum, the first layer, the second layer, the third layer, the fourth layer, like this. Like let's understand the layer like that here. The first layer is the highest layer. Javed, you're right. This is the pelvic diaphragm. It's a sagittal section, guys. Let's say I'm facing this side. That's a pelvic diaphragm. Just below pelvic diaphragm is a superior layer of urogenital diaphragm. Below that we have inferior layer of urogenital diaphragm. And superior layer of urogenital diaphragm and inferior layer of urogenital diaphragm, they are fusing with each other anteriorly and posteriorly. This is pelvic diaphragm. This is superior layer of UGD, and that is the inferior layer of urogenital diaphragm, which is also called as perineal membrane. This red line over there is corresponding to perineal membrane. And you can see this superior layer and perineal membrane, they are fusing anteriorly and posteriorly. Below perineal membrane, because it is a mid-sagittal section, the section will go from the bulb and the shaft of the penis. So there we have this bulb and the shaft of the penis. And here is the urethra. That's the urethra passing through, right? That's the bulb of the penis, and that's the urethra you're looking at here. Now, to understand that what is the floor of this region here, guys, on the anterior abdominal wall, you know the anterior abdominal wall is having a fascia called as a Camper's fascia and Scarpa's fascia. Scarpa's fascia present on the anterior abdominal wall. The same Scarpa's fascia will continue in the scrotum in the form of dartos muscle, and the same dartos muscle will continue behind as the Colles fascia. This is the dartos muscle there. That is the dartos muscle, and that is a Colles fascia which is merging with the perineal membrane only here. So Scarpa's fascia continues as the dartos muscle, and dartos muscle will continue as Colles fascia. And the moment you put the Colles fascia here, now we have the two pouches, guys. This space over there is a deep perineal pouch because it is above, And this page below here is a superficial perineal pouch. The two perineal pouches, superficial pouch and deep pouch. Deep pouch is above and superficial pouch is below. Deep perineal pouch, it is not wrong to say that deep perineal pouch is present between the two layers of urogenital diaphragm. Or you can simply say the space inside the urogenital diaphragm is the deep perineal pouch, whereas the superficial perineal pouch is present below the perineal membrane. So you write only that perineal membrane separates the deep pouch and the superficial pouch. Upar deep pouch and niche superficial pouch. Knowing that this is a deep pouch and superficial pouch, guys, let's take it one step forward here. Okay. About the extra vestige of urine. This urethra here is the membranous urethra, and this urethra here is a bulbar urethra. Now let's take it to the next page here. That's the membranous urethra. Any injury to the membranous urethra, any rupture of the membranous urethra, the urine will accumulate in what pouch? In the deep perineal pouch only. Injury to membranous urethra, urine goes into the deep pouch. But if the injury is to the bulbar urethra or spongy urethra in the bulb of penis, the urine come into the superficial pouch. Unfortunately, superficial pouch anterior wall is deficient. There is no anterior wall. So actually urine can go into the scrotum also. And this dartos layer is a continuation of the scarpa's fascia. Urine can go behind the scarpa's fascia in the abdominal wall all the way to the axilla. And it can go downward into thigh as well. So that's a different story altogether. When the injury is to this pouch, to the bulbar urethra, urine can go into the superficial pouch, it can come into the scrotum also, it can go on the anterior abdominal wall, and it can go downward into thigh as well, guys. So that's the main thing here, that if the question is asked, what will happen if the membranous urethra is injured? Urine accumulation, deep perineal pouch. What if the injury is to the bulbar urethra or spongy urethra in the bulb of penis? Superficial pouch, scrotum, anterior abdominal wall, upper part of thigh, and that is because there is no anterior wall. There is no anterior wall of superficial perineal pouch. That is the reason. Contents of deep pouch and superficial pouch, you should not bother much about that, guys. Superficial pouch, whatever we saw, guys, in this picture, if I just take you back for 1 second, look here. These are all content of superficial pouch only. Everything which is present below the perineal membrane, they are all contents of superficial pouch. Bulbospongiosus, ischiocavernosus, superficial transverse perineal muscle. And especially remember one thing, that female gland is present in the superficial pouch and male gland is in the deep pouch. Because see, there is an external urethral sphincter here, and there will be the bulbourethral gland. The Cowper's gland upar hota hai yahan par. Cowper's gland is here in the deep pouch. In female, the Bartholin's gland is in the superficial pouch. The two major content to remember, that Bartholin's gland is present in the superficial pouch, and the male gland, the Cowper's gland, is present in the deep pouch. And finally, coming to our last topic, that is the ischioanal fossa or ischiorectal fossa. Chota sa topic hai, but again very important, guys, and the questions are very, very frequently asked from here. Ischiorectal or ischioanal fossa. The reason we call it ischiorectal fossa, because here is the ischial tuberosity. Look at my finger here. That is on the ischial tuberosity there. And this is anal canal, or you can say rectum and anal canal. So fossa in between is called as ischiorectal fossa or ischioanal fossa. In the ischiorectal fossa, if I just replicate that picture over there, that is anal canal. This is the skin, like this. Let me just keep on corresponding. That is the skin or forming the base of the ischiorectal fossa. That is the skin over there. This is the skin over there, guys. That is the base of the ischiorectal fossa. And lateral boundary of the ischiorectal fossa is by this muscle. Look at that muscle over there. That is muscle is the obturator internus. That muscle over there is the obturator internus muscle. This is the obturator internus muscle, which is forming the lateral boundary of ischiorectal fossa, obturator internus. Whereas sphincter, external anal sphincter like here, and the muscle levator ani, pelvic diaphragm, are forming the medial wall. That is external anal sphincter. That is external anal sphincter. And then we have this levator ani. That is a levator ani or pelvic diaphragm. That is the one which is forming the medial wall. So guys, levator ani, or you can say pelvic diaphragm. So lateral wall is by obturator internus. Medial wall dono se ban raha hai by external anal sphincter and levator ani. And you know, obturator internus muscle is having a very thick fascia covering it from inside, called as the obturator fascia also. There is an obturator fascia as well. Okay. Obturator fascia, this obturator fascia, it forms a canal very much on the lateral side of ischiorectal fossa, and this is called as a pudendal canal, also called as Alcock's canal or pudendal canal. I'm sure aap sabne OBG mein padhai hoga, or Alcock's canal, when you the pudendal nerve block, when you do, it's in this canal only. This pudendal canal is holding the pudendal nerve, and internal pudendal vessels, guys. Pudendal nerve and internal pudendal vessels are the content of this here. In the ischiorrectal fossa, the main content of ischiorrectal fossa here will be fat. Look at this, all fat, 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 everything is fat over there. And what you have on the lateral side, the obturator fascia, mainly the obturator fascia forms this canal called as a pudendal canal, and which is having a pudendal nerve and internal pudendal vessel present inside. If I show you the ischiorrectal fossa content from the inferior aspect, if I see it from below, guys, see, ischiorrectal fossa content to be seen from inferior. First of all, fat is there. Fat is there, number one. Number two, pudendal canal and its content is there. Pudendal canal content is there. Now, let me put the third content very carefully. This is a picture in which you're looking at the pudendal canal. Just a schematic representation. It's not a very accurate representation, guys. That's a pudendal canal, like more toward the lateral side. This fossa here is a ischiorrectal fossa only, and that is a pudendal canal. We said pudendal canal, it allows the pudendal nerve and internal pudendal vessel to go anteriorly like this. Pudendal nerve will pass through it, and internal pudendal vessel will pass through it here. These structures are very much toward the lateral side, so they are very, very safe. They're very safe. If there is an abscess in the ischiorrectal fossa, guys, first of all, I hope you know that one ischiorrectal fossa abscess can easily go into the another one behind anal canal, called as a horseshoe abscess or horseshoe recess. एक ischiorrectal fossa से दूसरे ischiorrectal fossa में the abscess can go easily because behind the anal canal, not in front. In front we have perineal body, but behind anal canal it is possible that from one ischiorrectal fossa the another ischiorrectal fossa can receive the abscess. The pudendal nerve and internal pudendal vessels are very safe in the ischiorrectal fossa because they are very much toward the lateral side. So if you put an incision in the ischiorrectal fossa to drain the abscess, they will not get injured here. What will get injured here is one nerve and one blood vessel which is crossing the ischiorrectal fossa horizontally, and that is called as inferior rectal nerves and vessels. Inferior rectal nerves and vessels are the contents written over there. Inferior rectal nerves and vessels are the content which are running horizontally, and they are the one, artery and nerve both beta. Artery also, nerve also. Okay. So that is the one which can get injured in the ischiorectal fossa abscess. So when we drain the ischiorectal fossa abscess, this is something which can get injured. So this is about the ischiorectal fossa abscess. 11 guys is considered lucky for you people. I've finished my session at 11 here. This is what I had in my kitty to serve you today. Invest in your dream. Grind now, we will shine later. Grind like this, gentlemen. I'm still very energetic right now. I couldn't go for hours and hours the way you people have responded in the group here. बेटा ischiorrectal fossa and perineal membrane कोई relation ही नहीं है इसमें. Ischiorrectal fossa is posterior, perineal membrane is forming the anterior wall actually. Wow, we're already sending some great pictures. Thank you guys. Thank you so much. Thank you. Really, thank you so much. I mean, this is my job to teach you people. Obviously, I have to sit here and teach you guys, but it takes a lot from your side also. This is a commitment. This is a process I was talking about in the beginning, that this process that you sitting over there, hearing everything, trying to absorb as much as you can, trying to learn everything that you, trying to ask the queries, being part of it, like laughing with me, and you know, just basically being a part of this session is what all is needed. Keep doing this same process with every subject. No matter you find it very interesting, you find less interesting here. Karna to hai yaar. We have to do it here, because the next time when I'm meeting you people, I really wish to meet you all somewhere in life. First of all, wherever we get to meet anywhere, okay, do not hesitate to meet. I've seen people meet at airports and hotels and other places here, but what people does, they don't come and greet. Sometimes they are shy, something else here. If you find me anywhere, please do come and at least say hello. I will be really happy to do that here. Okay. And as I said, I really hope that next time we are meeting, like I'll be sitting like this on the chair here, you'll be sitting on the other side of the chair, and the question I'll be asking you is like, okay, where did you attend the anatomy class from? How you get this such a great rank? So things like that. Well guys, bless you all. You just, as I said, I know this is a time which is a little stressful for everyone, but there's only two way out here. Either we grind through it and churn this, this milk and convert it into butter and come out of it, or we can just drown into this. So I'll rather choose the first one. So thank you so very much for your time and being the way you were, and being so respectful, so nice, and so funny. I'll be sharing my Instagram and ID and YouTube ID and everything with you. Please Do write your reviews, good, bad, whatever critics. I'm open to everything over here. Thank you so much, and bye-bye. All the best.
All right, guys. So I hope this one shot program was very, very useful for you. है ना? So can I say that the entire subject was revised in a very, very quick amount of time? But as I told you earlier, this is not the end. Now what you have to do is you have to attempt the test. And how will you attempt the test? You have to download the eGurukul app if you have not done it. And in this eGurukul app, go to the test section. In the test section, go to the QR test. And in this QR test, you will see the test of this subject. Click on that test, gallery or camera. They will ask for a QR code, and here is the QR code. Scan this QR code or download it and put it into your gallery, whichever option that you want, and you are good to go. Please make sure that you are not finishing your day without attempting the test. I wish you all the best for the test as well as happy reading, and I am sure that you will reach to the success in the exam ahead. Take care and God bless you all.